Visionary Programme is practical and peer-led and aims to equip medical professionals with the knowledge and tools they need to lead the fight against viral hepatitis and empower them to take action to drive elimination efforts. So, okay, what does the No Hep Medical Visionary do? They maximise the role of medical professionals in improving hepatitis diagnosis, linkage to care, treatment and chronic pain. Chronic care, sorry, not chronic pain. They make a real difference to elimination efforts through bold and innovative actions from local to international levels that advance progress and bring about change. And they actively engage peers, other medical professionals, budget holders, patients, the public and political decision makers to advocate for change. That makes it sound very dry and very boring, and it's really not. It's actually amazing. We have some incredible meetings and we cover lots of different topics. And today, the topics that we're going to talk about today is innovations in technologies, the role of technology in hepatitis elimination. It gives me great pleasure to ask Dr. Vivek to come and join me as my co-chair. And we have some great speakers today who are going to do a little bit of presentation. It's just an informal chat, and it's an opportunity for medical professionals to gather together to have a discussion. Today, it's around technologies. Last meeting, it was around mental health. So I do hope that you'll enjoy the session. So I hand over to you. Would you like to?
Morning, and I hope you're not tired after a long day yesterday. I'm sorry it did overrun, but I hope you enjoyed all the scientific sessions as much as I did. Now, I'm pleased to host this with Rachel. I'll just kickstart the whole thing. I think technology is so important. The world is changing. I think if we have to embrace technology, you have to move forward in any field. It's as simple as that. Let it be in social media, let it be in research, let it be in disease awareness creation, let it be in testing. I think there are lots of innovations coming up, and we as an organization and all the other social organizations and NGOs and everyone has to adopt technology to move forward. I think that's extremely, extremely important. Otherwise, we will be left behind. So, I'm sorry, do you have the agenda? So, without wasting much time, could I invite, could I invite my good friend Ajit from AIIMS Rishikesh to deliver the first talk, please? Ajit.
Thank you so much, Dr. Vivek, Rachel. Thank you, the organizers, to invite me to speak on this very important topic, the role of technology, role of innovations to hepatitis care. So I'll be talking about what we are doing at AIIMS Rishikesh and how to change the slide. I have to click here. Okay.
Maybe he's got it, then you'll press it, you can get it.
Thank you. So I'll be talking about innovative approaches which we are doing at AIIMS Rishikesh through preventive hepatology. So preventive hepatology in itself is an innovation. We have started 3 years back in AIIMS Rishikesh, try to give comprehensive preventive care to the patients, not only to the patient, but also to their family members and also in the community. So this is my team at AIIMS Rishikesh. We have 2 hepatologists, we have a outreach person, we have a microbiologist, and we try to do all the public health preventive work together. So we publish, we try to do advocacy, and we run preventive hepatology clinic in the institute with liver clinic, with fatty liver clinic, which is run by gastroenterology department, and also do fatty liver screening camps, hepatitis B, hepatitis C screening camps every 2nd and 4th Friday in the community. And we are also trying to have a book on preventive hepatology so that it can be utilized for our undergraduates to give them a knowledge when they are in the initial phase of medical education, that what is the importance of liver diseases, how the burden is rising, and how all diseases, they are preventable when we talk about liver diseases. So capacity building we all are doing in the National Viral Hepatitis Control Program. There is a specific budget allocated to these trainings, and everybody is utilizing it in all states we are doing. But the innovation here is the lit up approach, which is liver induction training and update program. So whenever we train them for hepatitis, we also train them for fatty liver, we also train them for alcoholic liver disease. We also tell them how comorbidities can change the progression of these infections when they end up into some liver diseases. So LitUp has one more innovation, that is update program, and this update we do by using the Eco platform. We are the Eco hub. We do multiple trainings for multiple diseases in Uttarakhand state, and we are also utilizing this Eco hub to update them, to keep in touch with these medical officers, lab technicians, data entry operators, and pharmacists who we train through National Viral Hepatitis Control Program initially, and then we are in touch with them. We do hand holding, we do case discussions, so that when they are back in their respective areas, and when they are performing whatever they have learned, if they are finding any difficulty, we are there for helping them. Then we always celebrate World Hepatitis Day, and we try to take up some areas to do these activities. Like this is in 2022 we targeted hepatitis B birth dose in the state. We did trainings of the labor room staff of the private clinics which do deliveries, and we trained them for hepatitis B birth dose, because most of them, they were not even knowing that it's there. It's a mandatory vaccine which should be there. So private clinics should be involved, as mentioned by Dr. Rakesh Agrawal yesterday also, that private partners, they are very important. We have to pull them in the program so that we can get the accurate data. We do trainings for nurses also. We do trainings of the residents. We do training of all healthcare staff whenever we have these World Hepatitis Day celebrations. So when you have the data from your clinic, you can find out whether there are any hotspots in the community. So we find out those hotspots from the data, and we go and talk to the community leaders, and we organize these community screening camps so that maximum people, they can be benefited by the program. And we do all the activities in sync with National Viral Hepatitis Control Program. We get kits from there. We make the diagnosis, confirmatory diagnosis through the program system, and then give them free drugs through the program. We also do research. This was a pragmatic cluster randomized controlled trial to document the effectiveness of hepatitis C self-testing as an additional test for hepatitis C. It was done in urban slums. We had 3 arms. One was the control arm, and other 2 arms were like home and facility-based availability of these hepatitis C self-testing. And we documented that the testing uptake was increased whenever you go closer to the community. So we started this micro-elimination project in district jail last year, and the target was to screen all prisoners through using hepatitis C self-testing kit, and we have screened all these prisoners, and the positivity rate was 72 out of 1200, so it was around 6.2%. The poster was presented yesterday by one of my residents, and we did this in close collaboration with the administration of that prison. The request came from their side, and then we started this project. We have completed this project, and now we are planning to continue the care, giving the care for hepatitis to this prison. So if we talk about innovations, technology, we have used drone, and we have a drone service in AIIMS Rishikesh from last 2 years. It has been utilized for many programs. And when I got the call from the jail superintendent mentioning that they find it very difficult when somebody is positive to arrange a vehicle, to arrange policemen and send them to our AIIMS Rishikesh. So we thought, why not to take the help of this drone? So this drone was utilized to send the drugs to the prison and get the samples from the prisoners, so that we can do the testing at our institute. You can see we put that drugs in the drone, then we can track it also. In the second image, you can see we can track the whole drone, how it is going, whether it has reached or not. There's a specific center for drone which is there in AIIMS Rishikesh. We can communicate with them also whether they have received whatever we have sent to them, whether there is anything, any difficulty, we can communicate with them through this video conferencing, and then we receive back the samples from the prison. We also utilize telemedicine services. We are a center of excellence for telemedicine at AIIMS Rishikesh. We utilize this service also to be in touch with the prisoners. And this is not only for hepatitis C, but also for hepatitis B, fatty liver, and other diseases also. And we run a fixed sessions on every Friday, 12 to 1. We call it as a preventive hepatology clinic. but they come with many other diseases also, which is taken care by our telemedicine team. So these are all innovations which we are trying to do to increase the care for hepatitis in the state. And I'm happy to answer if there are any questions.
Thank you. Please come sit with us. So it'd be really lovely. In a minute, we'll have all the presentations and then we can maybe just have a discussion. But thank you. I mean, the innovation is incredible. There's lots. I have to say, in the UK, drones are used by gangs to fly drugs into prisons, not Bloods and Medicon. So it's amazing to hear a positive use of a drone. I'm going to move on so that we have an opportunity to sit and discuss together. So it gives me great pleasure to introduce Dr. Shilash. Would you like to come and, who's from Technology and Community Work is the presentation.
Thank you so much. I don't have slides, but I want to discuss about technology and community work and how we simplify technology for the communities. We are all been talking about decentralizing hepatitis management. My colleague Anil Parmar also spoke about bringing it to the people where they are. But most of the technology becomes alien when it comes down to the community level. When we talk about decentralization, the challenge that in Mumbai we have is tracking people. In slums like Dharavi in Mumbai, we have multi-layer households which are not available to track on any platform. And to enable us to do that, we conducted a vulnerability survey using something called as a Google Plus code. If you go on Google Maps and you click on any of the random buildings that you see, which don't have a name, it will still have a plus code. It will have a 4+3 plus code, and that plus code is accurate to 2 meters of the door of the building. So we used that. We used it for 15,000 households in the slums of Dharavi. We assigned them a plus code. So each of the houses has a board that has a plus code written on it. What it makes is that for any of our Anganwadi Sevikas or Asha workers or anybody, they have this plus code mapped against the patient or the family name. And all that they have to do is go on Google Maps and just enter the plus code. It will direct them to a radius of 2 meters from the vicinity of the household. The challenge that we had before this is because this household is not mapped, it would take a lot of time for any health worker to reach it by asking people where this family lives. But by assigning this plus code, it becomes easier. It also helps the beneficiary, it also helps the family, because when they have to tell the address at any of the PHCs or any of our healthcare workers, because they don't have addresses. In the slums, there are no addresses, there are no postal addresses for them. All that they have to mention is the plus code that is written on the door of their household. And with this, there are 3 benefits that we have identified. One is for the end beneficiary, that they have an address now. They have a location where anybody, it's not necessarily just healthcare workers, but police, fire brigade, emergency services can find them. That is one. Secondly, it helps our healthcare workers for easy tracking of their beneficiary. It reduces their time in tracking the families. And third, at the dashboard, it helps us to see the clusters of any of the health vulnerabilities. So whenever we are conducting surveys in the community or whenever we are conducting activities in the community, for each family, we just take the plus code. So we are not taking names of the family. There's complete privacy on their part. All that we need is the plus code so that we can understand if there is a cluster that is forming in the terms of any disease. It can be hepatitis A, hepatitis B, or any of the outbreaks. And by that, it is because it's live, because it's real time on the dashboard, action can be taken immediately. There is no need for anybody to sit with a physical map and map all these households where the outbreak is happening. So this is one technology that we have used, and it has helped us very well to understand the health vulnerability. But when I talk about community work, the essential observation that we have had is most of our tech is difficult for our field workers and the beneficiaries to understand. It does not give a feedback mechanism. Most of the tech is receiving data. It is not analyzing data and passing on the recommendation to the healthcare workers. So they are doing their work based on whatever SOPs have been designed for a general action on the health. It is not customized to each person that they are attending to. And this is where we are now trying out our actions where we have a feedback mechanism. So we are currently working on different projects where we are trying to design apps which help the healthcare worker on the ground after inputting data to get a real-time recommendation on what is the next course of action at that family or at that beneficiary. And I think in terms of hepatitis B or hepatitis C management, it will work whenever the reports are inputted, wherever the consultations are needed to be done, counseling, and also when the contact tracing is needed to be done. So we need to invest in technology which is designed for the beneficiaries and not only for the decision makers. And I think from an organization point of view, we are investing in that, and I request everyone to look at the other side of hepatitis management is the end beneficiary, and design their tech, design their platforms which can be accessed. And we found this during our COVID vaccination, that when technology or platforms are designed that can be accessed and understood by the end beneficiary, there is high uptake in terms of medical services. So what we need to do is make them simplified, make them localized in the local languages, and make it accessible for people to create that transparency among the people in terms of what services are being provided and what uptake is happening. So we are working on it, and I'll be happy to discuss any of this, anytime. So thank you.
Our third talk is by my very good friend Dr. Ganesh, who's a scientist at the ICMR. My partner in crime, I have to say. Yeah, most of the things which you see here, half of them I think is probably done with the brain work of Dr. Ganesh. Ganesh, thanks.
Thank you very much. Good morning, everyone. Thanks for this wonderful opportunity for the NoHep organizing this, and I wanted to share some of the concepts which I've been working on this past 10 years, an important cross-cutting area which is called digital public health. Thanks for the previous speakers who has mentioned a lot of great examples of how we can harness technology for service delivery component of it, be in terms of like accelerating the care delivery, or in terms of innovative ways to empower the healthcare workers at the ground level to take decisions promptly, be it is like artificial intelligence based chatbots or other things. My focus is more on program implementation. So how this particular area is evolving, and that is called digital public health. And this definition is having a lot of confusion across the multiple disciplines. But fundamentally, I wanted the audience to focus on these three important elements of this definition, which is it's a systematic approach of information technology and data in order to support informed decision making. That's the most important part. And most important fourth part is that it's to strengthen the resilience. This is a definition which is from the interoperability working group of digital health. The part here, what we are trying to do in any public health program is data to decision, and this decision to action. Do our information system in whatever the health programs, be it is National Viral Hepatitis Control Program, or it is a National Program for Non-Communicable Diseases, or may our popular program, National Tuberculosis Elimination Eradication Program, NTEP, is trying to provide this particular information out to the key decision makers. That's some number thing. Number two is, this is the 6 pillars of the health system. And if you clearly see that, like, technology has a role for each and every pillar, that one pillar, which is called the information and communication system, is the cross-cutting pillar for the rest of the other pillars. A technology should help the leaders and governance to take decisions very correctly. It is data, it should be data driven. Service delivery can be accelerated through a technology where the information system makes a greater role. Medical products and vaccines and technologies, by itself, its virtue, it's having its technology aspect. Fintech is now coming up in terms of health financing. Lot we are benefiting in insurance sector. And finally, the health workforce, where one of the presentations that I will be talking about, yesterday we launched on learning management system, how you can use technology in order to empower those health workforce on that. But what I am trying to tell in terms of an effective public health program delivery, the information system should inform that where you are investing it in terms of human resource, money, time, and rest of the other resources, whether we have delivered those outputs or not. Do we have an information system to track that? I learned we do have one such information system at a different levels, which is trying to inform the viral hepatitis control program to inform cascade of care. And when I say this cascade of care, it all starts from these 4 important key functions of this digital health information system: data generation, compilation, analysis, and communication in use. Any one of that is missing, then it is not complete. If there is no communication, then there is no decision making. If there is no analysis, then there is no interpretation. And if there is no compilation, it doesn't make sense. And if there is no data, then we are just, it's in the dark. Even a patchy data is also a major issue in terms of it. I'll take an example about an NCD control program. I don't see any major difference for the viral hepatitis also, which is also a chronic care related to that. The quantum of information we generate in any chronic program is very huge. And when we are going to do that much amount of information, because your beneficiaries remain in the program for longer period of time. With such a breadth of information, you need to have a very robust information system. In my past 10 years, I have seen a lot of failures of information systems, digital public health. And I will put one slide about why digital IT fails majority of the times. Okay, right? But basic information required for any control program, here I am taking up an example of an hypertension control program. I put it on these important life cycle of a program as input, process, output, and outcomes. It has to capture the minimal available information for the cascade of the care and care delivery related to that. It may be related to resource mapping, it may be related to service delivery, it may be related to an immediate outputs that what we are generating out of it. Are we doing it? That's one important potential question. But what in good information system do based on the literature for program implementation is, at least it should have some of these characteristics. It should have better indicators for planning. It should have better day-to-day decision making. It should inform and control and oversight of the program where it is steered upon, and should reduce the administrative burden. I wanted to focus on this particular slide, that why many digital health fails. Literature has been documenting again and again that digital health IT fails repeatedly is because of various reasons, and these are some of the points which I am highlighting. When it comes to the health decision makers, or when it comes like health leadership, always there is a huge amount of a pressure in order to take shortcut outputs. And we don't wait for that, because we see this is, health is a sensitive, we need to deliver it. And always there is a shortcut, there is no time we are investing in order to understand the system analysis, that design thinking, or in terms of user experience. Second, we don't consider the end user. All our top-down approaches, majority of them, you name any health IT which has been designed along with the user, very rare. Third, unsuitable technology for the scale and usage. We don't understand that public health matters on two things. One is the scale, second is sustainability. If you are not simplifying it, it is not scalable. If you are complicating even by 1%, your scalability potential drops majorly. And sustainability is a question mark. And poorly planned budget or a rigid budget. This is a major issue. Software is a service. It is not a product. It evolves and technology changes. We need to keep all these things in mind in order to decide our budget for that, which is not happening per se in majority of the public health initiatives. Pilot systems are not evaluated honestly. Often we don't talk honestly among us to see what is the failure. It's a seen as a kind of loss of pride. We should talk openly about where we failed. And that's the opportunity when we have pilot systems. So this is all been listed by this wonderful publication from PATH along with the WHO Planning and Information Systems Project, which is a toolkit for public health managers. So the common problems are these things, which is poorly used systems are poorly scaled and purpose is lost. So there are certain specific steps, but I wanted to focus here on 6 important design principles. Small is big, knowledge is not enough, intentions are not actions, truth are always buried, context always comes first, context is the king, attention is elsewhere. Thank you very much.
Thank you very much, and it's great to have that kind of overarching aspect included as well. So I guess maybe before I have a couple of questions, but maybe before that, is there any questions from the audience? Anybody got any questions or comments? You know, maybe how you use. Yep, please. Oh, it's just coming. Are you coming? Okay. Oh, it's one more speaker. Where's our other speaker? Sorry. I'm so sorry, everybody. You can see we obviously had a really late night, and we're totally disorganised. Yes.
My fault or your fault? Your fault. That's all right then. We apologize. Jyotsna, please come up on stage and give us a talk on the role of information systems. I mean, clearly technology is not working here. My iPhone isn't working.
This is why we need it.
Yeah. We need a printout. Sorry, Jyotsna.
That's all right. Thank you. I think that was a very interesting way to start. But yeah, and also I realize that I'm following on a very detailed presentation about digital public information systems, and I am going to be talking about information systems. So, yep, let's get started. Good morning, everyone. I'm Jyotsna from the William J. Clinton Foundation. We are an Indian affiliate of CHAI. I lead the hepatitis and HIV programs as part of the infectious diseases portfolio. We are a Section 8 registered company working across 14 programs in 16 focus states in India. Addressing both preventive and curative healthcare interventions. And our approach combines management perspectives, systems thinking, and business tools to enhance equitable access to healthcare. We've been working on the HIV program since 2003 and the hepatitis program since 2016 at both the national and state levels. Core to our work is the belief that good data is the lifeblood of successful programs. So transforming data into actionable information requires building responsive and user-friendly systems for program managers and service providers. And these systems must enable structured reporting of patient-level longitudinal data, which is a step beyond traditional aggregate reporting. So I'll be talking about 2 examples of work done within the NVHCP program that cover 2 different aspects of data for health programming. The first example is, of course, the NVHCP MIS, and the second is Project Sampark run in Madhya Pradesh. So yesterday, Dr. Dhiman and Oriel had narrated the journey of the NVHCP program, and the MIS is part of that journey. Its life began at the state level, and it laid the foundation for the development of the current national level system. This is a paperless tool fully integrated into the Government of India's data ecosystem through the ABHA module. It features detailed clinical modules, decision support systems aligned with the national guidelines, and provides role-based access for users. And additionally, the system supports data-driven administration with real-time dashboards, which provide snapshot and trend views for state and national program managers. The MIS is fully ABDM and FHIR compliant. It has an LFU module as well, and it's backed by root cause analysis tools, which provide insight into and address patient interruptions, allowing program managers to make informed interventions. So in Punjab and Madhya Pradesh, the platform's data has helped identify demographic characteristics, risk factors, and comorbidities, aiding the development of sub-regional strategies. It has helped clinicians monitor adherence to treatment protocols and identify gaps in care. The MIS also helps collate aggregate data reports from the district upwards to help program managers monitor critical parameters across the hepatitis B and C cascade. And the built-in clinical decision support system helps differentiate cirrhotic patients and enables the early treatment, specific management, and continuous monitoring. Another example of data-driven innovation is Madhya Pradesh's Project Sampark. This was part of optimizing the processes of linking hepatitis B and C positive donors who were turning up at blood banks to referral pathways and treatment linkage. Ultimately, there was an exercise conducted by the state which had revealed significant gaps, including non-standardized SOPs and unfortunately unverified donor contact details, which were hindering effective linkage to care. So to address these issues, the state unit launched Project Sampark in 2022. Its backbone is an Excel-based data management system with live access for blood centers and facility managers. In its pilot phase, the initiative led to 385 blood donors across 7 blood banks getting successfully linked to further care. The processes in place supported by the data tool also generated considerable efficiencies in linkage to care. Primarily, this was the reduction in the turnaround time from the time that the donor got screened at the blood center to linkage to care. There was an 86% reduction in time. It decreased from 53 days to 5 days. So the results of the pilot phase have made a case for statewide scale-up, which is currently in progress. And we also have worked with the state of West Bengal to develop a pilot tool, which is an integrated monitoring system for triple elimination program, which is now being developed into a formal tool by the state to aid in the program scale-up. So to conclude, data-driven initiatives provide templates for states to take up structured approaches to improve referral pathways and linkage. The ultimate goal of any program's MIS is to lay the foundation for effective outreach, advocacy, and service delivery. And more importantly, building a system that serves service providers is the first step. This creates a robust framework that can evolve to support enhanced monitoring as we move closer to elimination. Thank you.
Thank you so much, and for being so kind for us missing you on the agenda. And what an important presentation, because if I understand that correctly, that's the dashboards are measuring the care pathways. So I guess, can I just start with one quick question? We have a limited amount of time. Is that available only to healthcare practitioners, or is it something that could be rolled out for anybody delivering services? So it could be community providers as well.
Currently, the system can be accessed by providers who are working within the NBHCP program. So it's not it doesn't go outside the program currently. So it's for patients, again, linked to the program.
Okay, so not for, okay. So we have to stick, I've got an organizer sat next to me, and we have to finish on time today. So there was a question, I know, before yes, would you like to go? And then maybe if any of you have any questions for each other, that might be a nice way as well. Please.
Thank you. My curiosity, it's more of a curiosity, not about question. Like in Mumbai, it's known for the Bawala. and in a stage like where the foods are delivered in doorsteps, how they are doing it when we healthcare providers are struggling for that same.
Okay.
Thanks.
Okay, very nice question. So, if somebody doesn't know what is a Dabbawala, it's a tiffin provider, service that's been there for more than, I think, 40, 50 years. They have their own coding system on the tiffin boxes. So they know exactly where the tiffin goes without fail, and the failure rate is absolutely close to nil. And this has been something that has been appreciated a lot. And that's where, when you talk about this technology that we use, and it's available, it's not something that we are inventing something new, right? It's the code of it. How can you simplify it with just 7 alphanumeric characters that you assign it to someone? And we have seen this happen. So if you are standing in the corner of that room, I'm sitting here, we will have different codes, which on Google Map, you don't see it because both of these places are unmarked, right? But imagine about 100 households, 100 buildings in between you and me right now. How will I tell you that I have your medicines and you can come and collect from me? All that I have to give you is a 7-digit alphanumeric code that is stuck on any of the walls around me, and you can come and see me in the vicinity of 2 meters. The thing that I am trying to say is there is technology available. There are solutions that we are not exploring. There are things that we are probably just not noticing. If we integrate those in our programs, it will always make a large difference in the service delivery for sure.
Thank you.
There's one question there.
Hi, this is Sumit. So I come from health tech background. So since we are talking about this ID platforms and device management, or let's say data management systems, right? Just to continue with his thought, I believe she has just mentioned about the ABDM platform, and this is the biggest thing we have now because India is building world's biggest healthcare ecosystem. We are not following anybody's else model there, right? So my question to all of you is that, let's say, how do you envision the scaling of AI solutions to the data-driven platforms, both when it comes to high income and low resource healthcare settings? And what key implementation challenges do you anticipate in order to implement those things in both the settings there? Because most of our population resides in tribal and rural location. And this is where exactly we need to reach out with the technology. This is what I think.
Shall I? Yeah. Thanks for that question. Like, we do have already a proven example how we scaled up UPI, Unified Payment Interface. In the whole world, we demonstrated that how we scaled up it is. It is well user designed. The uptake from the user was very high. The same way was the Unified Health Interface, ABDM, was also rolled out. What we missed, apart from UPI, is that in UPI, already we have, de-identified, or we have on a clear-cut identification of the users by PAN number. So there is no duplication in terms of it. In health sector, for the past 50 years, we don't have a common registry of health service provider or the healthcare organizations. There is no common registry of healthcare providers apart from NMC registration number, which is also only by state. We don't have a common number. Since the lack of this registry is the biggest hurdle for rolling out and scaling up of Ayushman Bharat Digital Mission and Unified Health Interface. Now, once this HPR, Health Professional Registry, and Healthcare Organization Registry, first it has been formed, I think then we can cross that hurdle, wider implementation could happen. Thank you.
Thank you.
Okay, this is more of a comment. My name is Gokul. I build health tech systems. When health systems are built, they try to build everything for everybody. That's what people are trying to do. When they build a hospital management system, they try to build one system that serves the likes of Apollo and the nursing home. Different levels of healthcare delivery have different kinds of challenges. So we need different systems to build for different levels. even within primary care, if you do a specialist care delivery or a mohalla clinic delivery or a mobile van delivery, the system should be different. But I don't see that happen anywhere. They just want to build one system that does offline, that does specialist care, that has hospital management system. I don't know why that's happening. Could you say something about it?
I think, number one, I think in public health programs, there are different systems in place because I think the differentiator are the processes, right? No two programs are alike. The service providers involved are also pretty different. So, I mean, I understand that hospitals might have uniform systems. Largely, the architecture might be similar, whether it's a larger hospital or a smaller hospital. I think the difference is the number of modules that come in and the kind of processes that need to be accounted for when you're building the system. So,
no, I kind of think that the kind of devices that are used by a larger hospital in a resource limited setting versus a resource abundant setting, they all bring different use cases and different challenges. But it's very hard to find anything like that. That's why I asked the question.
right.
Just one small comment on that. Sorry, Ajit, you want to? Yeah. One comment is that like I see it all starts from that particular the understanding of the system. When I see a success in finance industry, I see a success in manufacturing industry where they are trying to develop for the respective users. Whereas when it comes to health, the health leadership and digital health literacy, I feel so it is much lower when compared to the other disciplines. That is a major hurdle which I think to be first fixed. That's why they always think as a one size fits everyone. The leadership thinks that this can work in hospital, this should work in primary health center, this should work in a community, and it's that kind of like an coercion thought is a major hurdle is what I see when based on the interactions I've been doing with many health leadership.
I saw that you brushed up on saying that there is not enough budget or something, right? That's what kind of happens everywhere. That's why I thought.
So if I give the example of NVSCP, so we have one common portal. So it's a common portal for everyone. Like if I'm sitting at a tertiary care center, I'm using the same portal by using the login ID and password. I'm going into it and entering the data. Same a person, if he's sitting at a primary health center, if he's going through entering any data in that portal, he's also using the same, same dashboard. But if you see the differences when he's entering data about the screening, how many are negative, if positive, what he has done, either referred or not referred. And if the person is referred to a higher center, they have a common ID, and they keep on entering the same further data whether RNA is done or not done, whether fibrosis assessment is done or not done. If the person is then going to a treatment center, they're entering the data for the treatment initiation, second dose, third visit, and then the follow-up. So keeping one portal keeps it simple and uniform when we talk about health programs. So I think that's the only reason why we have one common.
That is such a top-down look.
Gokul, we're going to stop. Yeah.
Sure.
Dr. Rakesh, please.
I think if you stay there, see, Dr. Ganesh, you said that if we can have a financial system that can be shared, same can be true for medicine. The two are very different. First of all, I may deal with 10 banks. Some parts are common. The data to be transmitted for shifting money from one bank to the other, irrespective of whether it is from A to B, B to C, C to Z, is identical. You need very few pieces of information. In medicine, it's going to be extremely challenging. Remember, banks have one method when we want to make payments. They have a different method when we want to take loans. They have a third method when I want to invest in equity. And finally, if I deal with 5 banks, just like if I deal with 5 healthcare service providers, I need to go to each bank's app. The bank still won't share data. No bank would allow that there would be a platform where you could get all the banks, all the data. So I think that's the difference. The previous person who was at the podium who was asking the question was referring to, that we will need not one platform which will be able to do everything. And that seems to be the challenge, and I would kind of agree with what he was saying. Thank you.
No, he's not going to answer, sir. Because time is up. I'm sorry about that. We can't start the first session, second session late. So thanks everyone. There's exciting times, and I think technology, we can speak for many days about technology. Thanks to all the speakers, and thanks to Rachel, my co-chair. We'll have the next talk, or next talk we're going to do it, is it? Are we the chair for the next talk also? Okay, we'll close this session, and then we have one more talk actually by the heat is on. Apologies again. No, there should be a heat talk. No, I put the program. Or just state, sorry. So can I have the next panel, please? Thanks.
A very good morning, ladies and gentlemen. To those of you that have just joined us, welcome. We're going to dive right into today's proceedings. We had a very, very interesting and power-packed day yesterday, and I'm sure that today will be the same. We move into session 8, if we're continuing from yesterday, which is a discussion on state perspectives on enhancing linkages to care. I'd like to invite our chairs to take the stage. A round of applause for Dr. Asha Hegde, the Director of HIV, Hepatitis and Syphilis for South Asia at PATH. She's worked in the National AIDS Control Program for over 15 years and implemented HIV and Hepatitis C self-testing projects across India. Dr. Asha, welcome. I'd also like to welcome Dr. Ajit Singh Bhadoria, Additional Professor, Community and Family Medicine, AIMS Rishikesh. He's worked in preventive hepatology and liver disease prevention for 12 years. Let's give him a round of applause. I'd like to also invite on stage Dr. Pallav Bhattacharya, Dr. Vinay Kumar, Dr. Rajkumari Rosie, and Dr. Praveen Kumar Karan. Let's give them a hand, ladies and gentlemen.
Thank you so much. Good morning, and I welcome you all for this very important session on states' perspective. So we all know that the implementation of National Viral Hepatitis Program is given to state NHM, and the state is responsible for implementing this program. And these are the very important speakers who are working in their respective states. And we would like to understand how they are implementing this program in the state, what are the challenges, what are the opportunities, and we want to learn from each other. They have to learn from each other, how we can include the best practices and what are the difficulties they are facing and how we can, take care of those difficulties. So I'll start with Dr. Pallav Bhattacharya. He's advisor, State Task Force on Triple Elimination of Vertical Transmission for HIV, syphilis, hepatitis B in West Bengal. He has over 35 years of experience in public health domain. He has contributed to national and state level initiatives at National AIDS Control Program, and also in adolescent school health, communicable diseases, and viral hepatitis. He has worked with UNDP on various public health initiatives. So over to you, Dr. Pallab. Thank you.
Good morning, all. A quest for reach. Let me first outline that a quest for reach coupled with enablement of access to care. These are the twin forces which have driven the state program and the philosophy of the state program from its very early stages in West Bengal. So that's how we have looked at it, and our advancement has been on that course. So it doesn't move. Oh, this one, nah? This one, the big green one? Or? Huh? Oh, the big green one. Yeah, okay, fine. So it's all greenery. So essentially, looking at it, we have been doing tweaks and changes along the course of the program as we have moved along the journey. So introductions like whole blood RDT in the early phases and downline coordination, establishing downline coordination protocols in the form of district coordination meetings with set agendas was something that we began with very early. And as we have moved along, there have been decentralization and task shifting all along the course. Similarly, private sector engagement has been brought into the fold over the last 2 or 3 years. You realize that the program has been a very young program, yet in its infancy, hasn't yet moved into adolescence. So telementoring of management has been another important activity that we have factored in to ensure that decentralization is supported and enabled. We were one of the first few states, rather the second state in the country to declare hepatitis B and C as notifiable. That naturally prioritized the whole program concept and created sufficient positioning and prioritization of the program. And of course, as we have moved along, we are looking at differentiated modes of management, and metro model of care has been devised for the megalopolis like Kolkata, where saturated facilities and the difficulties encountered by people to navigate care has been circumvented by taking care to the level of select UPHCs, urban public health centers, which are again mentored and monitored by 5 treatment centers, established treatment centers. So that's how we have been moving along, and the viral load systems have been mixed. It's a hub and spoke molecular diagnostics with state-of-the-art high-throughput systems in place. We have 4 SRLs now, state reference laboratories, functioning in tandem with point-of-care reflex viral load estimations put in place for difficult and challenged populations. So it's a hybrid model that we have put in the state as we have gone along. So this has aided in the progress and expanding access. So that is what the key issue is. So importantly, as we have been saying, integration is the buzzword. But a pious declaration of intent, unless translated into concrete action, would somehow lead us nowhere. So that what is important is that in each of the co-linked programs, we have established SOPs, flows, workflows, and defined roles and responsibilities on the part of the staff, of the people who are involved with rolling out the program and carrying out the linkages. So that is what has essentially been done. In each of the segments, defined roles and responsibilities have been worked out. And secondly, it's a shared responsibility. Both ends need to track and link. It's just not one-sided referral. So that is what is important. And counseling services have been a key to whole of it. That I'll elaborate when we go along. So certain essential systems engineering that have been done. So by now, in 2 visits, treatment initiation has been enabled across the treatment centers in the state. And as I have mentioned, there are over 49 treatment centers now, and around 13 to 14 are sub-district levels, and in 2 districts now we have moved to blocks. So in this case of blood centers, what had been seen is, in one of our studies, that it was in 21, that the linkage was around 27%. So that has now come up to around 46%, because that's another difficult area. I need to mention that blood centers and again IDU segments, these are the challenging areas where linkage is a difficult proposition. So here, what has been done is viral load aliquots are sent along with the TTI aliquots, it's collected, and the viral load is done in one single go. So what happens is, there is no separate visit for the viral load. And the person concerned, in case of C, we get to have only those who are confirmed who need to be linked. And for B, the viral load is already done, and so what happens is that the process becomes easier. Treatment center visits have been curtailed to only 1 for correctional homes, inmates. And essentially, we now have major 6 central correctional homes identified as regional treatment centers for correctional services. So it's again, it's jointly done, and out of them, 2 are having point of care reflex testing arrangements done within the correctional home. So that makes, again, this is a difficult area. Things become easier when we can do this through this mechanism, and linkage happens to be easier. So metro model has been established, as I was telling you, and UPHCs have been involved. Capacity building of, again, we have involved informal healthcare providers into the system. So informal care provider capacity buildings happen to ensure that often they are the first responders at certain points of time, so that they can be allies in the whole process of early linkage to the treatment care system. Counselors, there is a big army of counselors within the health system. So say around 1,000 in our state, all of them have been involved in different roles and capacities, and their capacities have been built to ensure prevention and linkage to care in case of viral hepatitis services. And each treatment center is assisted by 1 or 2 counselors of any hue, and we all know that HIV/AIDS program has a big chunk of counselors, NCD has counselors, the tobacco control program has counselors. So the whole pool, there's been optimization of the system, so to see that they are within the total grid. So procurement system is again integrated. It's not in a silo. It's within the state systems. And for private facilities, we have provision the availability of Hep B birth dose and HBIG for those in need. So this is from the government system. So it's a partnership with them. So it's essentially been a journey of from evidence to action. So very early on the course, we did an injection safety practices study, prevalence estimation in adults, estimation in under 5 children. That was again there as a poster presentation by one of my colleagues yesterday. District categorizations have been done. Safety efficacy of DAAs among children and adolescents has been worked on. And of course, I mentioned about the linkage to care in blood center studies that have happened. So there are a host of others, but these are some which I am mentioning. So essentially, now what we are looking is integrated WBVH-MIS, which goes a step ahead of the national MIS. Here, it will be a seamless journey, end-to-end, from the moment somebody is screened, and the whole process is tracked. So, from screening to management, to notifications, to generation of reports for viral load, whole of it within the total gamut of the WBVH-MIS. So it's nearly done. Just 1 or 2 steps left for portability with the national portal. That's in agreement. Whole of it has been done in agreement. So we will be coming up because of the essential need to ensure linkage so that the whole journey is captured. This we have worked out upon. So way forward is micro-elimination in thalassemics that we are looking at because West Bengal has a higher thalassemia burden. Enhancement of engagement of private sector, clinical establishment portal is established, and there private sectors report. There is a tab for viral hepatitis there, other than dengue and malaria and such notifiable diseases. So we have interventions with the police, law enforcement agencies. It's Shuddhi Plus, wherein those in conflict with law, particularly in case of substance use, are brought into the rehab networks, and then hepatitis care is provided. We are looking at DBS PCR for challenging populations, and of course, last but not least, triple elimination of MTCT for HIV, syphilis, and Hep B is well on the way ahead, march ahead. Thank you.
Thank you, Dr. Pallav, and thank you for reminding us that linkage is both-sided, the responsibility is both the end. Now I invite Dr. Vinay Kumar. Dr. Vinay Kumar is Joint Director, Immunization and State Immunization Officer at Tamil Nadu. He has 14 years of experience with World Bank-supported Tamil Nadu Health System project. He leads the Universal Immunization Program in Tamil Nadu. Over to you, Dr. Vinay.
Thank you, ma'am, and good morning to everyone. I wish to share the state perspectives on enhancing linkages with respect to Tamil Nadu state. Yeah, got it, thank you. So what the thought going about state perspectives for enhancing linkage of hepatic elimination is, we should think about what hepatitis elimination refers to a global goal of reducing the burden of hepatitis, which we already discussed in the day 1 of the entire sessions. So through a combination of prevention, that is through immunization activities, diagnosis has been dealt by many other speakers yesterday, and the treatment modalities, and also the care initiatives. With respect to care initiatives, we need to stress more importance on the care initiatives. And what I thought about enhancing linkages to care is, such strategies of enhancing linkages to care should focus on the strategies to improve the access to hepatitis testing, treatment and prevention services, which we have in Tamil Nadu, more than 42 treatment centers, and we have many 2 model laboratories also in the state. And it also should address the barriers of the underserved population in receiving the care. For example, till now, I just doubt that whether the prisoners have been really screened for hepatitis B till now. And this enhancing linkages service is a multifaceted effort which require the collaboration of the public health agencies, healthcare providers like private and public, and also the community organizations, because government cannot do everything for all its citizens. We need the support of community-based organizations and NGOs. Again, it needs a comprehensive approach to reach the outreach as well as integration services, because Tamil Nadu, of course, many of you know, we have the three-tier system in Tamil Nadu. We have the primary care, secondary care, and the tertiary care, respectively administered by the Director of Medical Education, Director of Medical Rural Health Services, and the Public Health and Preventive Medicine. They all work together to the Health Secretary of the Health Department. So we need to combine and comprehensive approaches across all the levels of care in order to reach this goal of hepatitis elimination. And also we should take care that it should align to the national goals. So what we do in a National Hepatitis Control Program, incidentally I am the State Immunization Officer and not directly dealing with the National Hepatitis Control Program. As being said by the previous sessions, is being given to the National Health Mission, where the National Health Mission Tamil Nadu pivots the entire Directorate of Medical Education, Medical Rural Services, and the Public Health and Preventive Medicine in implementing this program in Tamil Nadu. So these are the set of activities we have phased out in Tamil Nadu. In mother screening, administration of human hemoglobins, administration of hepatitis B vaccination, and high-risk group screening like screening and confirmation of hepatitis B and hepatitis C, treatment of confirmed cases, and follow-up of these cases. And also we are targeted, initially when the program started, it was only towards the healthcare workers, and now the focus on the high-risk group also shared to the vaccination aspects. So with regard to what are the ways to enhance the linkages, I thought of like this. So AIN mother screening, we have about 10 lakh AIN mothers screened every year. 10 lakh mothers being registered in a state portal called PICMI, Pregnancy, Infant and Cohort Monitoring, which is similar to the RCH 1.0 of Government of India. So we try to capture all the details of the pregnant mother from the day of AIN registration to the childbirth. So which should be a mandatory routine screening, and which is happening in Tamil Nadu. Almost all the AIN mothers are being registered in the PICMI portal and being screened for hepatitis screening. And incidentally, about 65% of the deliveries happen in government institutions and 35% happens in private institutions in Tamil Nadu. So the target should also be reaching the private institutions also in taking care of this. And what we thought about that, right now the nodal person for the hepatitis control program in Tamil Nadu is the we have a medical persons over there, and I thought that it should be a public health program rather being a clinical program, because the first base you require for any treatment of hepatitis is the person to be screened. So we need a denominator, and this denominator to be screened first of all. Whether we need to analyze whether all the pregnant mothers and they have cohort are being screened. In such approaches, we are running many public health programs. So I thought that most important point in giving more linkages will be the making a public health person to run as a public health program rather being a clinical program. And next is administration of immunoglobulins, and of course we know 99.9% in Tamil Nadu are institution deliveries, and we have this civil registration system which registers more than 100% deliveries in the institution. So we know in Tamil Nadu it is 99.9, especially just 0.1% are home deliveries because of the maximum, because of this lobbies, anti-delivery lobbies, all those issues. At the same time, immunoglobulins, we need a capacity building. We know that we need to give the immunoglobulins within 12 hours, and there should be periodical capacity building to the staff involved in the delivery processes. And hepatitis B administration, third point is about hepatitis B to the pregnant mothers against linkages within UIP, Universal Immunization Program, which I am the Joint Director Immunization, and we had to link with the National AIDS Control Program, TANSACS, and we roughly see that the linkages is there, but not very frequently and very constructively, so it should be more positively. And again, the State Steering Committee, as per the National Viral Hepatitis Control Program, we have the State Steering Committee to be convened, and it has been convened at periodic intervals. And the thing is, the partners should be more discussing about all the three levels of care, as also TANSACS and the Medical Science Corporation, because Tamil Nadu Medical Science Corporation is a corporation which we procure drugs for the reagents for the testing reagents and other drugs. All the drugs and reagents have been supplied centrally. And next is about high-risk groups. High-risk groups for hepatitis B screening, we need a state-run specific programs. We cannot do with the normal routine screening programs, so it's better to have a space-specific running programs. And also we need to enumerate the periodical high-risk groups. And again, we depend upon the community-based organizations and NGOs formulation of these high-risk groups. And treatment of confirmed cases, again, we need the access to antiviral, and we, thanks to Government of India, we have adequate supply of drugs for the treatment cases. But only thing is, we have two centers, Madras Medical College and another one is Madurai, and with this we can think about a telemedicine for this hepatitis care, because Rajiv Gandhi Hospital is one of the apex center, and we can have this telemedicines to the other sub-district hospitals also. At present, we have this one treatment center per district, and we can, in possible, we can improve the more number of treatment centers. And the most important problem we see in the system is the follow-up of cases, both retention in care and retention in treatment. So as the previous speaker told about the counselors, we do have many counselors, and as RMNCH counselor, SNC counselors, ART counselors, and HIV counselors, many persons are there, and many counselors are there. So we can do a task shifting aspects in making them to give knowledge about hepatitis B and reasons for continuation of the care and treatment for the hepatitis B and hepatitis C, and then we can think about the game changers. And vaccination finally. And finally, I as a state immunization officer, I only vaccinated only 33% of the healthcare providers till now. And I run this program for 2 years. Instantly, I've seen only 33% of the healthcare providers have got their at least one dose of vaccination, of 0 dose, or at least one dose of vaccination. So I feel that even the awareness among the healthcare providers is much less, and we need to make them to aware about the risk of hepatitis B and hepatitis C, and we need to go for hepatitis B vaccinations. And finally, I would say that everything should come from the behavior change. I should know that if I am a health worker, I am in high risk group, I should get vaccinated. So this will be the game changer for enhancing cases. Thank you.
Thank you so much, Dr. Vinay, and for highlighting the importance of vaccination in healthcare workers and also in high-risk groups. Now I would like to invite Dr. Rajkumari Rosie. She is Senior Public Health Specialist, DHS Manipur. She has 14 years of experience with World Bank supported Tamil Nadu, and she is currently State Nodal Officer for National Viral Hepatitis Control Program, along with many other programs also. Over to you, Dr. Rosie. Please take care of time, now we are running out of time.
How to come back? Okay. Yeah. So a very good morning, and also wish you all a very happy new year. And before I start my session, I also would like to thank the organizer and also the partners for inviting me and giving me such a platform to share about Manipur. So coming to Manipur, Manipur is a very small state in the northeastern region of our country with a population of 28,56,000 and having 16 districts, and we have facilities under government. We have 2 medical colleges, 7 district hospitals, and at the last we have sub-centers 416. And the facilities under the National Viral Hepatitis Control Program, we have 2 model treatment centers at RIMS, Regional Institute of Medical Sciences, and another one at Jawaharlal Nehru Institute of Medical Sciences. So we have established a model treatment center at these 2 centers, and we have 2 state laboratory centers at these 2 medical colleges, and we have 16 treatment center. We have 16 districts, so we have 16 treatment center in each district, and in addition to that, 2 more model treatment centers. And we have decentralized the treatment, the screening to all the districts, and for only screening center, we have around 67 in our state. And regarding the viral load testing, we have decentralized the viral load testing also to all the districts except for 3, that is Kamjong, this is border to Myanmar, another one is Farjol and Kaksing. And the status as of now. So in Manipur, it was rolled out in 2019 with the with operationalizing 2 model treatment centers and started hepatitis C treatment. And from 2021 onwards, we started hepatitis B treatment. So now we have covered all the districts. The achievement for hepatitis B so far, a screen and then a patient put on treatment is 1,173. So here I'm showing this figure because we have lots of loss to follow up. And C, also the same thing, but here I just want to mention that viral lot detected is 6,361, but put on treatment is more than that because some of the patients, they go to the private lab for a viral lot test. That is the reason why it is high. The best practices so far, we have started screening at the PPT center, that is prevention from parents to child transmission at Manipur State, under the Manipur State AIDS Control Society at Reams and Jennings, where we have 2 model treatment centers, and also screening for the prisons. That is in collaboration with one NGO, that is Nirvana Foundation. We are doing it every day. We have 2 prisons, one for male and one for female. So we have started at the male prison settings. And screening of HRGs, also we have started in collaboration with Manipur State AIDS Control Society at the targeted intervention TI NGOs under the Manipur State AIDS Control Society. We have altogether 50 TI NGOs under Manipur State AIDS Control Society. And outreach came for screening of hepatitis B and C, and also vaccination and linkages to the treatment center is an ongoing process with now the NGO who is working in the field of hepatitis, that is, as you all know, this is CONE, the NGO that we supported. And the challenge is always there, as we have our manpower is also a big problem for us, and tracking of loss to follow-up is a big challenge for the state of Manipur, and mobilization of HRs unless and until we coordinate with the Manipur State AIDS Control Society and the other NGOs. We, the National Viral Hepatitis Control Program, only can't do it. And we have ASHAs to support us, especially for mobilizing the pregnant women, but not for the HRZs. And because the HRZs, they don't want the ASHAs to mobilize them, they don't disclose their status because of the stigma and discrimination. And reaching out to hard-to-reach areas, especially as you all know, that Manipur is having a very, we have some problem in our state. So visiting the hard-to-reach areas for health camps and all, it is a challenge for us as of now. And the way forward, yes. In collaboration with the Manipur State AIDS Control Society, screening of hepatitis B and C will be strengthened, and we have already discussed, and we are going to come down to the OSD sites. We have altogether 58 OSD sites, but we are going to select only few, that is to start with. So in the 7 district hospitals and Reams and Jennings, we are going to start. There's screening for the HRGs. And the viral load testing for, as I have said, only 3 districts are left out for screening of viral load, that is Furzol and Kamzol, that very soon we'll be doing, because once I go back, we'll be doing the training for the Furzol and Kamzol for starting this viral load test so that we can do have our own treatment centers in these 2 districts. And the private hospital engagement is also another challenge. But now, once we go back, we have already decided, we have already put up the file for a meeting with the private hospital. This is what we are expecting, and we expect good things to come out of it. And this is what we have this National Viral Hepatitis Control Program since the inception. We also have the privilege to do a poster presentation, and for that we got the 2nd prize during the National Summit, which was held in Gujarat. Thank you all. Thank you so much.
Thank you, Dr. Rosie. And thank you so much for the single window model for a pregnant women screening. Our next speaker and the last speaker is Dr. Praveen Kumar. He's a state epidemiologist from Government of Jharkhand. He's also the nodal officer for Viral Hepatitis Control Program. He leads the initiative in One Health, Rabies Control and Disaster Management. Over to you, Dr. Praveen.
Yeah, thank you. Thank you very much, and good morning to all of you. As since morning we have been talking on the efforts for elimination of viral hepatitis by 2030 as per SDG goals. So now moving to Jharkhand scenario, as we know that Jharkhand is a 25 years old state carved out from Bihar in year 2000 millennium year. And we are having the good infrastructure, and as per the NVCP guidelines or framework strategy developed by the Ministry of Health. So we have been following that with this existing infrastructure, having 24 districts, having, as per IPHS norms, we require 36,000 doctors, but still we're having the 2,000s. And we're having the 7 medical colleges, including AIMS at Devghar, and 2 private medical colleges, and RIMS Ranchi, that is autonomous institution under Ministry of Health. And we have developed model treatment center for management of complicated cases of cirrhosis of liver. And all district hospitals, that means 24 district hospitals, are established or identified as a treatment center for point of care diagnosis and management of non-complicated cases up to and dispensing of the drug up to health wellness center, that is now upgraded as Ayushman Arogya Mandir. So as per SDG goals, strategies have been defined by the ministry, and main, as per the estimated population of hepatitis B and incoming, the inception of the program in year 2019, it was estimated that 60 lakhs to 1 crore 20 lakhs people for hepatitis C urban level will be treated, as well as for 40 millions, that means estimated to about 5 crore people will be screened for hepatitis B, and having the carriers will be screened for better treatment. So this is the burden in Jharkhand as per the seroprevalence study by NFHS 4. That fact sheet has been released in year 2021, in which seroprevalence rate of Jharkhand, West Bengal, that group 2 states are, for B is 1.1 to 1.5%, and for C is less than 0.05%. So surveillance to be enhanced. It doesn't mean that proper screening should be done. And as per the NVCP program's guidelines or operational guidelines for diagnosis as well as management, efforts is being made by our government, followed by the different cascade of the community engagement as well as the capacity building of healthcare workers and providers too behind this elimination objective. Okay, we know this Indian scenario. Since morning we have been talking. So etiological factors are there in the form of sporadic outbreak for hepatitis A and E. But however, for B and C, we need to screen the high-risk group, including vulnerable population, and integration to linkage. For this purpose, we are having the robust immunization program in our state also. And already our previous speakers has emphasized on the integration, that means hepatitis B birth dose, and adult administration of hepatitis B, that means at 0, 1, and 6 months. So this kind of administration will prevent, and we have identified the high-risk group healthcare workers in the first phase before the scale of this program. So process, this is just...
Dr. Praveen,
yeah.
Dr. Praveen, yes, just cut it short and talk about state.
Sure. So this which I am skipping, as you already said, this is the Government of India initiatives, and we have been following. Before going to details, yeah. This is the main things. Yeah, NVCP MIS portal. This is very challenging because this is well defined by CHAI. And in these modules, we are having the registration, screening, viral load, testing, non-history, then prescription, dispensing, and SBR at every 3 months. So this data punching of the patient registration to the outcome is the main key challenges in our state also, because development partners generally used to give the solutions. But execution will be done by the government at district and block level. So at Model Treatment Center, Ranchi, we have deployed 3 manpower under NHM, 1 medical officers and technical officers and LT pharmacists for punching of data and follow-up of these patients and punching in this portal for proper data management. So that's we have been doing, and treatment centers are also being given for the login ID and passwords, because non-complete cases can be managed at district level because drugs are CMSS supply. So unless alternate diagnosis is not made, then drugs will be wasted. So in that fashion, we have identified proper dedicated manpowers for diagnosis at point of care kit and viral load transportation, that is facilities only at the RIMS Ranchi. So serum will be transported to the RIMS Ranchi for assessment of viral load, and for every 3 months SBR is being done. This is the integration model in which we ensure the quality aspects, access, and integrated testing of TB, HIV, and Hep B. That was done this year also. And prisoners are the high-risk populations apart from the drug users and STD peoples. So through this, under one umbrella, we have been integrated. And up to district level, we are in the referral lab, because after COVID pandemic, we have strengthened our RT-PCR lab at different district hospital also.
Dr. Praveen, please
please
bind up.
2 minutes. Yeah. So this is our integration existing model with the RCH integrations and screening through outreach campaign at the district and block level, because PVTs are another vulnerable group in our district. Travel populations are proportion of 26% in our state. So they are the most having the good comorbidity. And so that's why we have leverages with existing surveillance program of viral hepatitis surveillance program at the Central at RIMS Ranchi, and the existing Jharkhand State AIDS Control Society, as well as Jharkhand Ayushman Bharat. Key interventions we have been following as per the behavioral change. For these aspects, we have engaged so many development partners for risk communications, and through that, we have been getting their reports, and we have enlisted the patients for proper for the line listing on the basis of HCV RNA and for further treatment. So these are the sub-key interventions. Okay. And at sub-district level, up to Ayushman Arog Mandir, we are having the CMSS drugs. Drugs are there, but unless or until, that's why we have established model for transportation of sample from periphery to the RIMS through the courier. Courier has been impaneled at the state level, just like with the integration of the TB department and under NTP. So because in the same model, NTP will be existed with the NVSCP, because both diagnosis treatments are same almost. This is drug regimen. This has been following at our MTC and treatment center for C and for B. Surveillance signal sets are in the RIMS Ranchi. This already I have been told. Yeah. And we have having some existing indicators under NVSCP, and monitoring is being done. And this is our HRG populations. Prisoners 18,277, patient living with HIV 22,250, female sex worker 15,144.
Dr. Praveen, we don't have time.
Yeah, just 2 minutes.
These are all National Viral Hepatitis Control Program slides. We have already seen those.
I will take 2 minutes only. And this is our Healthy Liver campaign. This is the model for community engagement and screening in a high-risk group. So on the eve of World Hepatitis Day, we have done this Healthy Liver campaign. Rajasthan and Jharkhand both have been started for this screening at the periphery levels. This is some pics, just I'm escaping. The screening started, then with surveillance enhanced, and definitely for CBRNA is required. This is some IC activities and media news, and this is capacity building. So, and this is our IC generation. And this year, prisoners. For prisoners, we have done screening at the jail. Some district IC activities and treatment center aspects I am trying to show you all. This is integration of this one, TB, HIV, and Hep B. Just I am skipping. This is hepatitis treatment center is well documented at district level.
Dr. Praveen.
Yeah. This is Right. Yeah, this is the one last slide data. Since 2020, we are having the, till December 2024, we have detected 2,704 for acute screening have been done. And out of that, acute hepatitis B 38, carrier hepatitis B 1,803, and number of patients put on treatment for C is 863. And out of that, 91% have been benefited till now.
Thank you, Dr. Praveen.
Yes.
I think we'll end. Thank you so much.
Thanks.
Thank you, Dr. Praveen. I think the last slide was the most important one. So please come sit. So in the interest of time, we can take 1 or 2 questions. Otherwise, we'll end this session because we are already crossed the time. Yes, Dr. Gideon.
Thank you. I think it's really encouraging to see some of the states doing really well. I don't know if we have a targets of, say, for example, 90-65 in terms of reduction, and also there are underlying targets of, say, 90% diagnosis and from that 90% treatment. Not sure if any of the states have specific prevalence, if not mortality, at least the prevalence among separate populations, to see how much they should actually be covering if they are to reach those targets. National targets ultimately will go up to the global targets. So maybe that would, I don't see any of those in the presentation. So maybe that would be some sort of a research that states could invest on as a part of their program to understand what is it that we're looking at and what is it that we are going to in terms of, scaling up in terms of responses. Thank you.
Yeah, that's a very good question, Ketan. I think this is very important that states should understand what are the baseline, data and how they are performing and whether they are towards achieving those targets of decreasing mortality by 60%, decreasing incidence. Do we have that data? I mean, that's important to at least start working on that. Yes, Dr. Pallav.
Yeah, very pertinent issue. I had just mentioned cursorily because today it was mainly enhancement of linkages. So we have been guided by that. So we have seroprevalence estimates done for both B and C. In fact, 2 estimates were done, one for the general population and one for urban-centric slum populations. So we have that data, and that is what is guiding us into action. Accordingly, we have done district prioritizations, and the program is guided by all that evidence that is translated into action.
Probably I didn't observe in the yesterday's presentation, but what stood out in the presentation on Manipur was that the HIV program is linked with the national state health HIV/AIDS program. And I think this is the national pattern, I believe. Now, looking at the issue of stigma, I think linking hepatitis with HIV/AIDS is a bad idea. I think it will be better to change the name of State AIDS Society into a more umbrella-like organization that covers everything than just HIV/AIDS. I think HIV/AIDS was the one that created the biggest stigma. And hepatitis was not a stigmatized disease even in the earlier days. So I think, linking up with HIV/AIDS could be a bad thing for hepatitis.
I think this is a very debatable topic. There are 2 school of groups which thinks like one, there is stigma and should not integrate, and there are one group which says it should be integrated because most of the services, they are almost same. So that's why the program is separate. So we have a separate program, but integration is very important to, successfully get this program also implemented in line with how AIDS program is doing, wonders in India. So integration is important, definitely, and I disagree with that it's the stigma will come up and will, decrease the service, the beneficiaries will not come up because it is integrated. So
Sir, I have one question.
Just to share, I'm also not differing with sir, but looking at Tamil Nadu AIDS control activities in the initial stages when the prevalence of HIV was high, we have a lot of impact and importance given to the, even just simple example, needle stick injury registers. And at present, I don't find many needle stick injury registers in any of the hospitals being maintained. So it may be in the indirect way of approaching the hepatitis B, but not as you rightly said. Thank you.
Yeah, one last question from Dr.
So, Dr. Ajit, if we try to look at similarities between the HIV program and the hepatitis program, and for that matter, any other disease program, for instance, tuberculosis, NCD versus hepatitis, the activities there are also very similar. The activities are screening, case finding, diagnosis, treatment, follow-up. So really speaking, we can't say that there is greater similarity between HIV and hepatitis than, say, tuberculosis and hepatitis. I think that's the point the previous person who came here was trying to make, and I thought, let me express my disagreement with you more vocally, because somehow it is just because both are transmitted by blood. No, that doesn't, but then for that matter, there are many other diseases which are spread by the same method, but we have different approaches.
Yes, sir, I agree with you. I'm not talking about the similarity between the diseases. I'm talking about the similarities between the services which are provided. And that's true that it is not only for HIV, it's for all programs. And
the whole thing is universal health. Yes. All diseases, all health conditions have the same steps. Screening, case finding, confirming the diagnosis, treating, follow-up, and then disability management. Thank you.
Very true, sir. And there should be integration wherever and whenever possible with all programs.
Just one word, just on the back of this, that's basic understanding at this point of moment, particularly when we are delivering on the field and all, is de-silo, de-silo, and de-silo. Because basically it's all have to function in unison. And then 1 + 1 will make 3 or 4 or 6.
Thank you so much, and I would like to ask Dr. Asha to conclude, please.
May I have? Okay. You have time?
We can have discussion later on because we are
running. Discussion. So this is a very important point that I just want to bring out on this. So I am a nodal officer, lab nodal officer from a government medical college in Theni, Tamil Nadu. So I don't think there is a due importance given to the hepatitis A and E under the NVHCP program. So there is a lack of funds and also the momentum on the NVHCP. So I would like to, in the summit, to make, if there is any agenda to be given to the NVHCP, to the government of India, I think due importance has to be given to A and E testing. Thank you.
That's true. There is only a small budget which is given to model treatment center. I think this is around 50,000 which can be utilized for A and E, but only at model treatment centers, which we have seen there are only few in the states. So over to Dr. Asha for concluding.
Thank you so much.
Can I have last questions?
Sir, I think afterwards. We're short of time, sir. Sorry, sir. So I just wanted to begin my closing statement with Dr. Rakesh. I think Dr. Ajit objected to only one statement, that HIV and hepatitis should not be integrated. The point was that, nothing else. And I think we have learned a lot of learning from this session, especially the single window approach. And I think private sector is a challenge. If we had more time, we could have asked a question to that, to Tamil Nadu. And also courier system, I mean state-based engaging courier system. And these are all good learnings from this program, from this session. Thank you very much.
Thank you so much. I'd like to now invite Ms. Lavanya A. to please join everybody on stage.
Thank you so much. Good morning, everyone. I'm here presenting about our project findings on HBV and HCV burden in India and plan for the testing capacity assessment. The project run by Chennai Liver Foundation in collaborated with National Institute of Epidemiology and funded by the Task Force for the Global Health. Next. So there are 1.3 million deaths globally happen due to the viral hepatitis, and 40 million individuals living with the HBV infection in India, and the World Health Organization aims to eliminate the viral hepatitis by 2030. However, many remains unaware and undetected for their infection. Testing for hepatitis B and C for making them aware is key for prevention and the treatment, but there is a lack on testing infrastructure. So we started and we have conducting this study in 3 phases. The phase 1 will be evidence synthesis on burden of viral hepatitis conducted by systematic review and meta-analysis, and phase 2 we will be assessing the testing capacity, and phase 3 we will be developing a model to enhance the testing capacity. I'm going to most focusing on our systematic review and meta-analysis findings. So we have focused on, the review question focused on zero prevalence of HBV and HCV in India and its distribution, and we have registered this protocol in Prospero, and we have considered the studies performed in Indian population in all ages and published till September 2024, and studies reported with laboratory confirmed HBV and HCV and outcome assessed the zero prevalence of HBV and HCV. We have excluded the studies if it is case reports, case series and experimental trials and non-peer reviewed publications we have excluded. So we have identified 6512 records through different databases, PubMed, Embase and Scopus. After carefully screening the articles, 89 studies met eligibility criteria and included in our review. So here the characteristic of our included study, there are 61 studies reported HBV zero prevalence and 69 studies reported HCV zero prevalence, and 47 studies published during 2011 to 2020, and currently in last 4 years there are 31 studies reported HBV and HCV zero prevalence, and majority of the studies conducted in hospital setting, which is 82 studies. In terms of study population, 7 studies conducted among the pregnant women and 5 studies conducted in general population and 29 studies conducted in high-risk population and 25 studies conducted in hospital patients. So in terms of distribution of laboratory investigation for detect the HBV infection, majority of study used ELISA method. Similarly, for detecting HCV, majority of the study, which is 30 studies, used ELISA method. So here we have the zero prevalence, meta-estimate of zero prevalence of HBV. Total 61 studies reported zero prevalence of hepatitis B with a pooled sample size of 693,879. The zero prevalence estimated was 3% with a confidence interval 2% to 4%. And by year, the zero prevalence of hepatitis B across similar in all decades, which ranges from 2% to 4%. By setting, we have observed 7% in community setting and 2% observed in hospital setting. And by the region, the zero prevalence of hepatitis B similar across all the region, which ranges from 2% to 3%. And by the population, the higher zero prevalence estimated in general population, which is 9%, and the confidence interval ranges from 1% to 22%. And followed by that, 4% we estimated among the high-risk group. So here we have the zero prevalence of HCV. 69 studies reported the zero prevalence of HCV. The pooled sample size 10,79,000, and the estimated zero prevalence of HCV was 4% with a 95% of confidence interval 2% to 7%. By the year, if we note, it is similar across all the year, ranges from 4% to 5%. And HCV zero prevalence by study setting, we have observed 5% zero prevalence in hospital setting, 3% observed in community setting. And by the region, if we see, higher zero prevalence of HCV observed in north and east region of India compared with south and west region of India, which ranges from 10% to 2%. And if we see the seroprevalence by the population, the higher seroprevalence observed in high-risk group, which is 11%, and seroprevalence of HCV observed in hospital, which is 5%. Here we have summary to estimate the estimation of seroprevalence of HBV and HCV. We estimated seroprevalence of HBV is 3% and HCV was a 4%, and HBV similar in all the region and HCV higher prevalence noted in east and north state. And high risk 4% of HBV prevalence noted in high risk population, whereas in HCV 11% estimated in high risk population. And in general population, the seroprevalence of HBV noted 9%. And in phase 2, we are going to assess testing capacity of viral hepatitis by using WHO laboratory assessment tool to identify diagnostic gaps and generate actionable insights. And in phase 3, we will develop a model to enhance the testing capacity by conducting the qualitative studies among the stakeholders to create the model illustrating the barriers and facilitators to improve the testing capacity and accessibility. Thank you. Thank you.
So thank you, Lavanya. I think this is a very important study. I congratulate NIE team because I think the biggest gap in National Viral Hepatitis Control Program is the diagnostic gap. So if we'll find out the reasons and if we strengthen the system, I think we'll do wonders in this program. And may I ask you a question like, so do you find any reason why the burden of hepatitis B was more in general population as compared to hospitals and even high-risk groups? Anything specifically you noticed while reviewing those studies?
It may be the limitation we can say due to the heterogeneity present among the studies. Heterogeneity present among the study. Also, the confidence interval for this is overlapping, which is 1% to 22%. So we can say like it may falls between the 1% to 22%. We can't exactly say it is a 9%.
So are these on general population or camps also?
It's only general population. Also, I'm having the another reason also, because 3 studies only conducted in the general population, and among the 3 studies, 2 studies with lesser sample size, which is less than 1,000. So, because due to this information, due to this, there may be the increased prevalence.
Thank you. Thank you, Lavanya. We can go to floor. 2 questions.
Yeah, 2 questions.
No.
So it's more on the observation. Thank you, Lavanya, for the study. It's well done. But 2 observations. One is like it has been divided into 4 divisions. Instead of if you can separately analyze northeastern part, that would be helpful because the infection is more in that region. So currently it might be diluted. 1. And second, in nowhere, the tribal population, it's never represented for these infections. The practices among these tribes are different, which are making them more vulnerable for HCV particularly. So if you could separately have a separate table, something on tribal population, that will also be helpful. Thank you.
Thank you for suggestion. I agree, neither you nor I. But there was a gentleman called Newton who said there is gravity. Okay, so Dr. Lavanya, I would only say that we need to be extremely cautious. There seems to be something unusual somewhere. I've been working in the field of hepatitis for several years, and the number of studies available is much, much larger than the number of studies that you have been able to identify. Secondly, a lot of studies are full of a lot of biases, and you'll need to take that into consideration. And finally, as has been said by the chair, and you know, these are just unbelievable numbers. We work with patients day in, day out, and rates are actually much, much lower than what you have presented here. I think I'll stop there. please, 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 you have previous systematic reviews. Just look at those and see why your results are so very different. Thank you.
Thank you so much, Dr. Rakesh. I think these are very important suggestions, and I hope that Dr. Lavanya will look into it and will see like if she has missed those studies because of some, search strategy defects or some other reasons. And I'll conclude this morning's session by saying thank you to all my speakers and Dr. Lavanya also. And thank you so much for being a patient listener and for such lovely questions. Thank you.
Thank you so much to our chairs and our speakers. Can we give them another big round of applause? I would also request our chairs to please do the honors and present a token of appreciation to our speakers for being here today. Requesting Dr. Asha and Dr. Ajit to please do the honors. And now I'd like to call upon Dr. Ganesh Kumar to present our chairs with the token of appreciation. Thank you so much. Also a reminder to everyone to kindly collect your certificates from the registration desk. And now I'd like to call upon Dr. Vivek, who would like to felicitate a few special people on this occasion.
Morning and thank you. I'm sorry this was supposed to be done yesterday at dinner time, but I think we were all tired. So it's just going to be quick, 2-3 minutes. I just wanted to thank a few people which we did not do yesterday. Of course, it was in the pipeline, but of course, for want of time, we didn't do. First, of course, I'd like to thank my father for starting this Chennai Liver Foundation. So, but for him, we wouldn't be here. So, of course, I'd like to thank him. And of course, Abba, can you be on stage, please? I want you to felicitate a few people. First, I think the first person who's been pushing us and who's been helping us, guiding us, mentoring us, who's a long-term friend, Dr. Rivari, please. Can you have a round of applause, please? Dr. Rivari has done so much for viral hepatitis in this country. He's a good friend of ours, good friend of my father. Now can we, come on. Just a quick felicitation and thank you, sir. So thank you very much, sir. So could I call upon Dr. Rakesh Agarwal, please? Dr. Rakesh, sir. An old friend of my father who's been very, very instrumental. I think I had 2 sessions with him for this program to shape up, and only then it really shaped up. And he was very crucial in putting this program together for us. Just an honor that he's here. Thank you very much, sir. Of course, I did mention yesterday that our second family is the World Hepatitis Alliance. I think without them, we wouldn't be here. Without them, I don't think many would be here in the first place. They've been true leaders. They brought up leaders around us. So I think we've been a member for the Alliance for over 10 years now. So could I call upon Carrie, please? I don't know how many number of text messages I've sent him, how many number of phone calls I've made. And he's been supreme, I have to say, in supporting us. Thanks a lot, Carrie. Jess, could you call up on stage, please? Could you come up on? Of course, yeah. These are all friends. This is nothing formal. This was done to be done during dinner time. We're just thanking all our friends. And last but not the least, Dr. Ganesh. Dr. Ganesh, my very close friend. I think he's been a pillar of support for us for various research programs, a scientist in ICMR, a very good friend. A big round of applause, please. Thank you very much. Of course, apart from this, there are many other people who've supported us. Apologies if I've missed a few names. Of course, I've written a few names down, but John, thank you very much. No, it's been a pleasure. As I said, you've traveled 48 hours for a 16-hour meeting. No, you've been here for over a month now. We've done so much. Thanks a lot. Of course, Path, MPP, Chai, Ajit, of course, friends from the Tamil Nadu government, Dr. Murugan, Dr. Prem Kumar, Professor Sareen for supporting us, EPEN. So I think there are many other friends who've worked for us and who helped us put this summit together. And of course, a big round of applause to Showspace, who was, Anshul, can you put your hands, who are our event managers, who really put this together, please. I don't think we'll have time for a formal vote of thanks. I thought I'll just do all these things now. And then of course, our Canet is our social media team. Datri and team, stand up from there. These are the people who sit there. I mean, of course, they've designed everything, whatever you see. They sit there and they do all the tweets, and every minute tweet is happening here. So thanks, Datri and team. Raj and Sheshu, I'm not sure they're here, but thanks a lot. Of course, my team comprises of 3 people. I'm not here, I don't know if they're here in this hall. Karthik, Vaishnavi, and Subbalakshmi, 3 of them given specific tasks. And I think they did a great job. I'm not sure if they're going to be with me on Monday because they could even resign, given the amount of work which I've given them. Of course, all the friends and my own family. I don't think my family is here this morning, but they've all helped me put this all together. I really hope you enjoyed this. This is just the beginning. There's lots more things we can do. Thank you very much indeed.
Well, ladies and gentlemen, it definitely takes a lot to put together an event of this magnitude. So a big round of applause for everyone who put in their effort, their support, and of course their presence to make this event so special, both on stage and off. And now we move on to our next session. This one is the innovative implementation strategies for viral hepatitis elimination. I'd like to welcome our chairpersons on stage, so a big round of applause for Rachel Halford, President, World Hepatitis Alliance. She's a member of the National, Global, and European Strategic Boards representing Patient Voice, And also a round of applause for our chair, Dr. Polin Chan, Regional Advisor for Hepatitis, HIV and STIs, WHO, with over 27 years of experience in public health and epidemiology in African conflict settings. Also a round of applause for the rest of our speakers, Dr. John Ward, Dr. Ramesh Reddy Alam, Dr. N. Kumarasamy, and Ms. Mila Maistat.
Okay, thank you. We are here for an exciting session on innovative implementation strategies for hepatitis elimination. So without further ado, we have 4 speakers. We'll start with John, who will talk about success stories. So we are all ears, John. Over to you.
Okay, great. It appears that this is not the correct file for my slides. This is the slide set I sent in several days ago, and I revised it after hearing some of the presentations from yesterday. I sent those in this morning. If you could pull those up. It has the, yeah. Yeah, no, yes. Well, we'll see what we have here. So what I'd like to do is expand our discussions to give some examples of other low and middle income countries and how they're advancing progress toward hepatitis elimination. As I mentioned yesterday, we really have a very unique opportunity to eliminate hepatitis B and hepatitis C by the virtues of the biologic aspects of these 2 infections, and because we have the technical interventions to prevent transmission through vaccination and interruption of exposures to contaminated blood and body fluids, as well as reliable tests and effective treatments for B and curative treatments for hepatitis C, which gives the endorsements possible for the WHO goals for dramatic reductions in new infections and mortality to reach goals of eliminating hepatitis B and hepatitis C as public health threats by 2030. So let's see what progress is being made on the, yeah, okay. Well, one benefit has been the dramatic improvements in infection control in medical care settings. There's still much work to do to improve injection safety in healthcare. As you can see, there's an estimated 50,000 new hepatitis C infections that continue to occur through those exposures. But when you compare it to the estimated incidence in earlier years, there's been dramatic declines in those rates of transmission in those settings. But I'd like to point out how the rates continue to be highest in India, Pakistan, and South Asia, and relative to other parts of the world. The other good advance has been the advances in improvement in immunization coverage through 3-dose infant immunization and through newborn vaccination. Infant immunization is close to the 90% coverage target set by WHO. Still much more work to do in achieving that 90% coverage rate for birth dose vaccination, particularly in countries of Africa. But that said, there's been dramatic improvements in public health, with an estimated 22 million deaths averted through those improvements in vaccination coverage since those vaccines were first recommended for infants in 1982 and for newborns in 2009, with those improvements in health expected to continue as those coverage rates continue to increase. One of the biggest remaining challenges is the low percentage of people who who have these infections that are diagnosed and treated. As you can see, as was pointed out by Polin yesterday, virtually no one really is getting treated for hepatitis B virtually, with about 15% being treated for hepatitis C in this region. So that percentage is going to have to improve dramatically for us to reach elimination goals. We seek to assess progress in countries putting together the effective programs that can advance progress toward hepatitis elimination. So we've been working with local partners in Taiwan and in 32 countries to assess their strategic planning, the type of policies they have in place, and the types of programs they're putting together to deliver these prevention, testing, and treatment services, and how that's affecting progress toward hepatitis elimination. And you know, when you look back over the history of effective disease elimination programs, really essential components pop out. The importance of data to guide planning and to assess progress, the importance of national planning, the importance of pilots to put together feasible models appropriate for those countries, the importance of political commitment, the importance of focus on health equity so that everyone benefits from the disease elimination program, really looking to integrate within existing health systems, the importance of financing so you can sustain your efforts to your goals until achieved, and operational research to continue to look for improvements in your programs over time. You know, one of the ways that we help programs put together is a program we call HEAT, whereby, as you just heard, for India, there's an effort to assess the burden of disease in an area, and then the next step to assess the capacity to test and refer people to care and treatment, to identify gaps, and to help quality improvements in those areas. Now, when we look for examples in improvements in or advances in elimination, you have to continue to celebrate the achievements of Egypt, once a country with the highest prevalence of hepatitis C, with an initial focus on improving access to treatment, but with the availability of curative treatments produced in that country, the president decreed that all adults should be tested at least once for hepatitis C. The country then embarked on a very ambitious program of heavy health promotion to encourage testing, making testing available in a wide variety of community and clinical settings, using point-of-care testing, and then, if positive, referring that person to a facility for virologic testing and then treatment if found to be positive. They also put in place a very excellent data management system so they could track almost in real time as people progress through this care cascade. As you can see, they tested 75 million, 5 million found to be positive at the time this slide was developed, 4.5 million people treated, 95% of people cured, with a prevalence dropping from 10% to 0.38% in viremia in the country, and already seeing declines in new infections and mortality, the ultimate goals of elimination. And for their efforts, they were recognized by WHO as reaching the gold tier on their path toward hepatitis elimination, the first country to be recognized as such by WHO. Another excellent example is Mexico, which has used an integrated approach, starting with integrating HCV testing and treatment within their HIV clinics, starting with just 20 to 30 clinics several years ago, and now moving beyond HIV to a target of 5,000 clinics providing testing and treatment in the country, all at no cost to patients. The government of Rwanda, really following the lead of Egypt in many ways, a country with a 4% prevalence, again embarked on an all-adult testing program, training primary care physicians to treat hepatitis C, again making testing widely available in community and clinical settings, with a decline in prevalence of 69%. They estimate they have diagnosed 95% of people with that are infected with hepatitis C. And we, using modeling through the HEAT program, we project their declines in deaths from hepatocellular carcinoma and cirrhosis. Now, country of Ghana, which tends to have a higher prevalence of hepatitis B versus hepatitis C, and one that had done relatively little in planning or putting together programs to make testing and treatment available. So with that as a backdrop, we conducted a HEAT evaluation there and found an unexpectedly high prevalence of hepatitis C in the northern part of the country, about 4%, and how there was very little testing capacity there. With that information, we brought the government of Ghana together with the government of Egypt that at that time was offering to provide high-quality HCV medications used in their program, making that available to other African countries at no cost to patients. So through that health diplomacy, Ghana started the first pilot HCV test and treat program, and that program is continuing at the present time. Now, turning to Pakistan, now is the country that has the highest prevalence of hepatitis C. Indeed, about 1 out of every 5 people with hepatitis C in the world reside in Pakistan. Progressively over the last several years, they have taken steps to expand access to testing and treatment, and making testing and treatment in many cases available at no charge to patients. But still with a large percentage of people yet to be diagnosed and treated for hepatitis C. So in that regard, Prime Minister has announced a national hepatitis C program whereby federal resources will be combined with state-level resources to greatly scale up hepatitis C testing and treatment around the country. And those monies just became available this month. And so that program is just now getting off the ground, but a great advance in Pakistan. We assisted in supporting a pilot program known as LEAP, whereby persons went door to door in Rawalpindi to provide point-of-care hepatitis B and hepatitis C testing, and then if positive, those persons were referred for virologic testing and treatment. And that pilot testing was adopted by the local health authorities as a routine program. That Pakistan, with that national initiative, is now stepping forward globally, becoming a leader in the UN Group of Friends to Eliminate Hepatitis, which is a group of countries expressing global solidarity toward hepatitis elimination, of which there are now 55 of those countries. And this is the quote from the health minister expressing Pakistan joining that leadership circle, really demonstrating a global leadership coming from that national initiative. As you just heard, there's a HEAT evaluation going on in Chennai, and we look forward to the testing component of that evaluation to evaluate testing capacity and what different new strategies could come from that assessment. When I look at there are other examples from other countries. Brazil is making great progress in expanding access by simplifying models of care to be delivered by primary care physicians, removing patient copays, and onerous frequency of clinical visits by patients, et cetera. The government of Morocco is another example of a middle-income country. Thailand has just started a birth cohort strategy to test everyone for hepatitis B and hepatitis C born before 1992. So there are other countries. But I think what's most remarkable and what's consistent with all of those other countries is a national commitment to hepatitis elimination, where they bring together external resources for catalytic funding that can stimulate program development, or investing national resources to begin programs. And then more often than not, when those programs start, that investment is sustained and those programs continue. And I really am really struck in our presentations and discussions yesterday and just recently in the session that preceded this one, just the remarkable pilots that are going on all around India. And I think the magic ingredient that needs to be added to the recipe for hepatitis elimination in India is a national commitment. And I look forward to exploring that further in our discussions in this session and the ones later today. Thank you.
Thank you, John. Really, such an important piece of work, and such a, I think particularly the heat plans, you know, what do you call them? When the actual report, when it comes out? Yeah, the National Hepatitis Profile. Sorry, I should know that because we've got one. But, I mean, I think it's, really useful, but, well, not I just think it's really useful for each country to have it, you know, and going through the process with you and with your team is really useful to really look at what individual countries are doing. Because, yeah, I just think it's brilliant. I'm going to move on to the next speaker, and then we'll have time to do some questions at the end. So it now gives me great pleasure to welcome Dr. Ramesh, the CDC's role in advancing hepatitis elimination in India. Thank you.
Good morning, ladies and gentlemen. First, I would like to thank the organizing committee for the invitation for CDC to be part of this important session here. And being back to Chennai and alumnus of the NIE here. Okay. Yes. So, as you can see in this slide, CDC through its 4 key strategic directions is providing the support at both globally and at specific states to provide the holistic support for elimination of viral hepatitis. CDC India is primarily supporting the National AIDS Control Program through the PEPFAR support and its investments. And PEPFAR is working with partners across 55 countries, and you see on the panel on the left, the strategic framework, the re-imaged 5x3 pillars that we call in the PEPFAR world, wherein there are 3 facilitators: the community leadership, the innovations, and leading with data is the premise with what CDC works within the PEPFAR commitments. And if you look into the areas where PEPFAR actually gives its country operation plans, it's to align to the WHO consolidated guidelines, and all states or these 55 countries look into the holistic person-centered care for models of integration and support robust referrals and linkages and technology assistance for cutting-edge prevention to care treatment models. Coming to CDC India, the technical assistance has been a laser focus towards elimination of hepatitis B and C among key populations and people living with HIV. So this is the core area where we work in India, and this is to advance equity, engage empowered communities and civil societies that you have been listening since yesterday, and cultivate innovation and data-driven experiments that we do within these specific geographies where the prevalence of HIV is really high, and foster strategic and transformative partnerships, and again, facilitate or foster person-centered services. Now, I'll just try to take you through certain interventions that CDC, through the host state governments and the implementing partners of CDC that we have in this room, are providing to each of the states. Optimizing systems, sectors, and partnerships for impact is one important area that WHO strategic direction gives us. And in this, the integrated models of care among key and vulnerable populations that we see in the Northeast region. So one area where CDC closely works with states of Manipur, Mizoram, and Nagaland. So you see that the prevalence of HIV is really high in the northeastern part of the country. The HIV prevalence is high in these 3 states. They have a different geopolitical and religious dynamics compared to the rest of India, and technical assistance needs are varied. You see 2 photographs there. They give you how different it is in reaching and accessing the service. A healthcare worker had to cross a river basically or go in a rough road to provide service, and it is from the healthcare point of view. And the person reaching the healthcare also faces the same challenges. So how better we tailor our interventions, that's where CDC and its implementing partners focus along with the states. This is a slide again trying to give the high hepatitis C prevalence that you see in the northeastern part of the country. Here, the previous slide and this slide, we assess that the HIV, hepatitis, and tuberculosis rates are really higher here, and we are in this niche area where we need to have some coordinated interventions that have person-centered care as the fulcrum. The technical assistance to prevent, detect, treat, and build systems towards hepatitis C elimination among the people with injecting drug use population. On the left, you see on the slide is taken from the WHO guidelines. This are a package of services that we offer to PIVOT population groups. These are the recommendations that we have. And the technical assistance that is being provided through the state governments, the respective state governments in the Northeast is number 1, high up on their agenda, and the fulcrum of intervention is on enabling environment where communities are engaged and discussions happen over the table. And they are part of the technical resource group and treatment literacy campaigns. And then the entire interventions are cemented properly on the needle exchange, overdose management, and the OST care, which again is the core of harm reduction interventions that we have within the program, and we only provide technical assistance to how better both get married together to have a good outcome. We have been listening since yesterday how best to integrate systems. So one example I'm trying to give you here, this is a one-stop center that we have in Nagaland state, in Dimapur, again a high prevalence state for HIV. So what we try to do there with the state government of Nagaland is they have initiated a person-centered care model wherein all the pivots who are not able to access services or who really need a specialized care come up to these centers. These are shelter homes. And then we give a varied package of service, and here hepatitis is one among them. You can also see tuberculosis screening happening, HIV, and then referral from this particular facility to the MTUs or the TUs that are part of the NVHCP. So here we are not topping anything. The state government is just doing a little calibration in the workflow. The test kits are placed within these shelter homes so that everything can be accessed here. So there's no topping of resources, anything, but really trying to focus, have the radar focus on how better to have the patient-centered care and linkage them. Our partner here, PATH, is one key implementing partner here who supports this intervention. Looking at the WHO guidelines, we have these same models that I have showed you in the previous slide for each population groups. We can now focus for a couple of minutes on transgender population. This again is an intervention from Manipur in Imphal city. Dr. Rosie is aware of it. So here with the government of Manipur, the stakeholders there and CDC through the implementing partners support having a one-stop center, a health and wellness clinic. The name is a health and wellness clinic there for transgender populations. We have around 1,500 of them at this center and continues to register them. And here you see again is the gamut of services of health plus psychological support that is being provided, and the Jenims Regional Institute directly provides the psychosocial support at these sites. So this again, we see about 55 patients who are, the clients who are positive, and about 50% of them who actually access care, and 100% of them are linked for care there. So this again is an integrated model. Again, this needs replication, looking at amplification where all this can be done with the national program. Now coming from the hills to the plains, that is, we will try to also look at what we do in other areas in the southern part of the country. We also work in states of Andhra Pradesh, which again is the second largest burden of disease that we have. You see on the slide on your left, which is showing the burden or the number of PLHIV. Almost around 300,000 patients are estimated to be living with HIV in state of Andhra Pradesh. And the panel on the left depicts the distribution of the health facilities. And you see that there are more ART clinics or the ICTC centers compared to the NVHCP facilities. We just have, I think, 3 MTUs there and 24 treatment centers. So here, access and linkage is one key important thing that we try to work on. So the government of Andhra Pradesh had called in all the line departments within the states and tried to anchor a health systems approach and an implementation framework wherein the state had taken up operationalization of hepatitis B screening, vaccination, and management of hepatitis within the state, and mostly among people living with HIV. So that was the area where the work was on in terms of integration. And you see that all steps that we have been discussing since yesterday were actually followed in spirit to put up the intervention. Breaking the silos, let's see what the results are. We're talking about 200,000 patients living with HIV, where there is a calibration of the workflow. Again, there is no topping up resources. Putting the HIV test kits, the hepatitis test kits here within the ART centers, and training all the healthcare staff provided within the system, having the immunization department come into play and take a key role in terms of distributing systems and supplies. So here you see the results of almost around 200,000 patients who have been offered or who are on antiretroviral. We have a total number of around 220,000 patients on antiretroviral therapy in the state. So almost around 98% of them have been, 95% of them have been screened, and 98% of them are negative on screening. And you see the tremendous work that the state has done in terms of getting the vaccinations. So vaccines were provided at site there by the immunization staff nurse there or the ART center, whoever were available every day. And you see the startling again, 94% of them at least had received 1 dose. So this is the reach that we are seeing if we really, in spirit, try to look at how better to integrate systems with simple calibration of workflows. And these patients included key populations, pregnant women, females, everybody are part of this. So the reach is really there when you try to strike a balance where we introduce our interventions. There was no vaccine hesitancy. Remember, this was in 2022, the state had started this intervention just out of the big human crisis of COVID. The state had really taken efforts in terms of the information, education, and communication gadgets, really reaching them to curb the vaccine hesitancy for hepatitis. So you see that within 90 days, 100,000 doses of vaccine was given to all patients who had come on that. So this again is a moment to celebrate and see that if things can work out together, it gives you a rippling effect. And you see from the, that multiple partners are involved. There is a continuous and consistent delivery, and things are continuing even today without that much pressure on the system. So there is a scale up with fidelity that actually happened here. And this continues in all the 54 ART centers. And I have not given the treatment cascade for this because everybody knows all patients, majority of them, more than 95% of them are on tenofovir-based regimen. So there is nothing much, people will continue to be on same regimen. So the treatment coverage looks a bit easy for patients with co-infected hepatitis B. Coming to the story within the same group, what's happening with hepatitis C. So again, screening was offered to almost 220,000 patients there. And you see among 274 are positive, that is less than 1% of them are positive for hepatitis C. And just to give you, bringing back the perspective from the hilly northeastern terrain and Andhra Pradesh here, the difference in epidemic is that this is more of a heterosexual driven epidemic. So there is very few or very less pivot interventions or pivots identified. So that's why possibly you see a very lower rate of Hep C in these population groups. Yes, there is a challenge in terms of accessing the viral load or genotype assays that are part of the program, but you have only 50% of them actually getting the test done, 50% on treatment, but however, whoever were on treatment were able to continue. So here there is a lot of work of coordination that needs to be done here. And we didn't stop there. The state wanted to actually drive this to a subgranular level, not just at the district medical college level or at an urban setting. Now there are certain patients who really feel difficult to come to the district level. So the decentralization went in terms of camps at those most vulnerable sites where pregnant women were there, where women were mostly accessing services, and where you had key populations who are not really willing to come to the ART centers. As part of the program, we have link ART centers there. So at those sites, the camps were conducted, and you see that actually had supported in terms of providing a person-centered care, and we are moving to where the patients are. And with all these, the lessons learned, it's critical that we have a stakeholder and a community engagement as the fulcrum. And integration of vaccination screening, hepatitis is mostly possible in these ART settings. And standardization of practice, calibrating the workflows is really important. And hepatitis C management among key populations through integrated models that you see in Northeast could be looked in for amplification. And the challenge is, again, access to Hep C diagnostics and treatment, timely access to investigations for disease monitoring is also a bit of challenge that we need to work on. And way forward is to amplify this comprehensive programming in areas where most needed, and also to have the rapid point of care, maybe multiplex testing, integrated into the NACP programming. And last, I end with this intervention where we are advancing viral hepatitis in Georgia country, where CDC supports this, and we see an elimination target reduction in chronic hepatitis C to less than 67% there. And I acknowledge the National AIDS Control Organization, the National Viral Hepatitis Control Program, both at the state and the national level, the communities and the people living with HIV, the state AIDS control societies of AP, Manipur, Mizoram, and Nagaland, PATH, and Share India for their valuable contributions to this presentation. And thank you for your patient listening.
Thank you so much, Ramesh. It is a very succinct and I would say rich in data. So we hope for more exchange afterwards. So with pleasure, I'd like to introduce Dr. Kumaraswamy, who will talk about clinical trials in addressing the challenges in hepatitis elimination. He's the director of the Chennai Antiviral Research and Treatment Clinical Research Site. Over to you.
Right. Good morning. At this time, I'd like to thank Professor Shanmugam, a legend in the field of gastroenterology. Good morning, sir. And my good friend, Dr. Vivek, and everyone from Chennai Liver Foundation for inviting me, and also congratulations to the team for putting up this nice event. So little changing the focus. We have been talking about a lot on elimination, public health and everything. I just want to tell you, I'm an infectious disease clinician and a clinical trialist involved in clinical drug development. Cure is very different from elimination, right? Cure will facilitate elimination. So if you don't have a cure, it's hard to eliminate. Now today, you can eliminate hepatitis C because we set the foundation to cure, by doing all those trials. So today, just for one up time, I'm going to stick only to hepatitis B cure, because hepatitis C, we have cured, still a lot of challenges, with the newer medication. Just for one up time, I'll stick only with the hepatitis B because that's a lot to, talk about that. So today, someone who comes with the hepatitis B, we have a first-line wonderful treatment. We use a lot of pegylated interferon, 48-week duration, very expensive, a lot of adverse effects. We have very good, simplified medications. We call endacavir, tenofovir, alafenamide, and TDF, which are very good drugs. But these are all lifelong drugs. And also, we do have certain criteria whom we are going to, choose them. Someone who has got a use on pregnancy, what are the drugs which you can choose? Today we choose on tenofovir. Someone who has got a renal issues, TAF, which is a drug which we choose. And of course, endacavir is a very old drug, but now there are a lot of resistance profile coming up on this. Now, again, we have recommendations, and based on that, in certain comorbid conditions, we can choose what would be the best. And again, you'll hear from the next speakers. All these drugs are currently available in resource-limited settings, thanks to the generic drug manufacturers. It's been available, it's been affordable even through the programs. Only if you find these hepatitis B individuals, then you'll be able to, prescribe these medications. Now, again, having said this, have you cured hepatitis B? Quick answer is no. So what are the goals of cure and why you should cure? So if you don't cure, with the current first line of therapy, we're not going to cure. We are able to suppress the virus, but still the virus will be hiding, which I'm going to talk to you soon. And it also can cause the liver disease progression, and also it can lead to, transplant necessity and death. And also, if you don't cure them, you cannot be able to prevent HCC development, and also you will not be able to talk about all the elimination principles you are talking about, vertical transmission, horizontal. So if you don't cure them, you're not going to eliminate completely. And also, if you're not going to cure them, you cannot improve the quality of life. And if you're not going to cure them, they have to take pills lifelong. So again, we need a cure, to limit the pill burden. And of course, the earlier speakers are talking about stigma integrating with the HIV. Again, if someone takes any pills lifelong, that's a stigma. So again, if you don't cure, they have to live with the guilt of stigma. So again, why we are not able to cure? This is a very complex principle. It took decades and decades for us to understand the pathogenesis of this. Such a difficult virus. A lot of my work last 30 years on HIV, we struggle hard. Today we got some wonderful medications. Still we are not able to cure. Hepatitis C, we did trials. We quickly cured. We thought we'll never cure hepatitis C, but we cured. But in hepatitis B, we're still struggling. We're not able to cure. That's because of this difficult pathogenesis. So this is a hepatitis B. It is a DNA virus. It uses a receptor called NTCP, enters. So this is our own liver cell called hepatitis B. It uses endozyme, it engulfs, uncoats, and get into the nucleus of the hepatocytes. And there, it causes a process, what is called CCC DNA. So reservoirs development is what is called concomitant closed circular DNA, which gets integrated into the human system. And there are various replication pathways like transcription and translation. At this time, it shuts out hepatitis surface antigen, but also there is another pathway where it gets packaged up and use an enzyme called reverse transcriptase, where we use all of our drugs called TAF and tenofovir at this time to inhibit this enzyme. And if we don't succeed, it replicates again, and again the new variants are being produced. So again, while we have been doing this process, where this virus can also get integrated into the host genome. Because of these two pathways, one is the development of CCC DNA, and another one because of the integration into the host genome. Today, we are not able to cure hepatitis B. I'm not sure whether we'll be able to cure hepatitis B because of this, unless we develop newer strategies in terms of therapies. Now, coming to the cure, there are a lot of definitions. When I started work in hepatitis B, we used to have a definition, what is called partial cure. So what is that is, you got some medications like, interferon we used, which suppresses the virus replication, not too much. We didn't use for a long time, but we are able to, stop the drug, reduce inflammation, normalize the ALT, but on the other hand, they are being lifelong hepatitis B surface antigen positive. So now today, we have much better drugs, but again, this is all lifelong therapy. And using that, we call it what is called functional cure. But on the other hand, they have to be taken lifelong, and we are able to reduce inflammations and normalize, liver function tests. But on the other hand, we are also working on how we can, get rid of this hepatitis surface antigen, and at least after 6 months, which I'm going to show you some little data on that. But on the other hand, while doing all this, still it gets into the CCC DNA, and at this time, cannot call it as a complete cure. We can call it as a remission, not cure. This is functional cure, what we have been using on. But on the other hand, what we research has been currently working on is how we can completely cure this, and thereby you can also get rid of this CCC DNA out of the liver. But still, hepatitis B integration still will continue to have that. This is what is called the complete cure, which I just have time and show some of the drugs which we have been working on that. The final one, the one which will really facilitate to eliminate hepatitis B is sterilizing cure. We are nowhere near that, but again, a lot of trials currently going on. So what we are doing is that this is what is called functional cure, but still, hepatitis surface antigen still can be there, but we are trying to get rid of at least after 6 months. If we don't get rid of hepatitis C surface antigen, what will happen is, it's a very nice study. What they have shown in that is, patients who had hepatitis surface antigen continuously there versus there is a clearance. If you see this, if they have hepatitis surface antigen, these are the patients who had hepatitis B viral load suppressed, not detected, using this antiviral therapy, where they can continue to have, liver damage continue to happen because of the surface antigen. So if you don't get rid of this, you'll continue to, damage the liver, despite if you have a viral, suppression on this. So again, this has been put in this particular bar chart of taking all the clinical trials done in the research-rich settings, where if you use tenofovir, 92% of them can have got suppressed viral load, hepatitis B, but only around 3.4% will have a elimination of surface antigen. But if you use etraverin, only 2%. And again, if you're using, in different countries, in Germany, they have seen, 94% virological suppression, but only around 2.8% get rid of the surface antigen. That means we are nowhere near complete cure to facilitate you to elimination. But on the other hand, we can give a good quality of life, but still it can cause damage to the, livers. So again, surface antigen loss is just anything from 2 to 5%, over a period of 10 years, based on different trials using nucleotide analogs. So, but what we measure today is all these biomarkers. These are the biomarkers where we can tell the patient, hey, you're doing well, your liver symptoms are normal, you don't have a hepatitis B viral load, but on the other hand, they still can cause problems to the liver. So in future markers, what we are trying to use it in our clinical trials to measure is whether someone is being cured is the quantitatively measuring the surface antigen, and as well as looking into those integrated and transcribed in a cccDNA. Only if we can do this and say that they don't have it, then we can say that they're completely been cured of this. Now coming to the core talk of this meeting, here is, what are the barriers to hepatitis B cure? Earlier I was walking through the pathogenesis. Today, because of the reservoirs development of this covalently closed circular DNA in the hepatocytes, with the current therapy, we are not able to cure this virus. And also in one step recently we found is it also get integrated in the hepatitis B DNA. So we may need multiple therapies. One drug cannot cure this virus. Like in HIV, we use 3 different drugs. In hepatitis B, unless you drew 2 or 3 different pathways, we will not be able to cure this virus, and because of this complex life cycle. And over the top, the immunologists have shown there is dysfunctional T cell response and insufficient B cell response, and as well as inefficient innate response. And this is another hurdle to cure this virus out. But on the other hand, you just throw a window of opportunity. Similarly, in hepatitis C, we use multiple drugs when you're not able to cure in the beginning. So in hepatitis B, we have a window of opportunities to use multiple drugs like entry inhibitors under development, targeting cccDNA, targeting RNA, inhibiting polymerase, targeting hepatitis surface antigen elimination, and as well as inhibiting the capsid assembly. Multiple drugs currently under development. I will run out of time to show all those, but I quickly browse through. These are the various therapies now under development. Might be for next 10 years, there will be a lot of drugs will come up, and might be one day we'll be able to cure this. So just one at a time, I'll just quickly go through, but show one particular molecule which has been very promising called bepirovirsen, which we are about to involved in this clinical trial here in Chennai. So this is a trial called BeClear, which already they have been shown about the hepatitis surface antigen clearance after 6 months, even after stopping this nucleotide analog of tenofovir or TAF along with this. And for these reasons, now US FDA has closely monitored this and have given this manufacturer GSK some type of a fast track designation for this molecule. This is something which will add to our one of those drugs to manage hepatitis B soon. But on the other hand, still it is not enough. We need much more other molecules. Now the new one under development is called siRNA, which is a very interesting molecule, very recently got published, which is called salmisurone. Again, for this crowd, I will not go into the very details, but I like to tell you that there is a positive response on hepatitis surface antigen loss after 6 months of therapy when they have been stopping the background nucleotide analog. This is what's been seen in this particular thing. Again, this particular molecule alone is not enough. Again, we may need a combination of therapies. We've got a different drugs now currently under development. There's a new trial just being developed using multiple of these, using entry inhibitors, drugs which suppress the viral antigen burden, like how we have been doing this in siRNA, and as well as in antisense oligonucleotides, and also by boosting this immune response, either by giving interferon or some of those TLR7 agonists. I'd like to show just one study before I stop my talk called March study, which has been currently ongoing, and the data was very recently presented in one of the liver meeting, where they used multiple drugs. They used an entry inhibitor, they used a target of oligoside antisense drug, and as well as they also boost the immune response using pegylated interferon. And again, it is a very large trial, still ongoing. The initial results are already been now presented, showed very promising, especially on getting rid of this hepatitis surface antigen. So with many of the molecules what we use, we're able to suppress the viral load, but on the other hand, hard to get rid of the hepatitis surface antigen. So again, there are a lot of challenges in whatever we have been developing, but some of the obstacles, we're trying to get rid of this. So there are rates of functional cure are improving, but still been very been optimal. So the seroreversion can occur and may increase over a period of time, but again, the durability has been an issue. Pegylated interferon, we used a lot in an integral component of many regimens and antiviral therapies alone will not provide this. So we want to get rid of interferon out, but on the other hand, after seeing all these different integrations, we may have to bring this along with our antiviral drugs. And again, we may have to use both oral drugs and parenteral. Again, in a public health program, when you have been talking about elimination, it might be very difficult and might be challenging. Again, which combination you use best? Again, we struggle this in HIV, what to give this, 1 drug, 2 drugs, or you start with 2 drugs or 3 drugs, finally end up in a combination therapy. Similarly, now in hepatitis B, we have been working on, are you going to use sequentially or parallelly, or use together on this? Again, patient selection will be a challenging. One size, again, doesn't fit for everybody. But whatever we are going to do is going to be expensive. It's not going to be cheaper. So again, we may have to invest more and more, for these molecules if we are going to eliminate hepatitis B, out. I think that is my last slide. Again, we have been talking about elimination. I've been hearing yesterday for some time and today, again, still 75% of the hepatitis B, they live in lower and middle income countries. And we have been trying to get all this tenofovir and TAF in our region. Again, we have a long way to go. So again, before we talk about cure and when you have the drugs, what we have to do is we have a wonderful WHO guideline recently been revised. I was also part of this guidelines committee. So one of the new things what we have done is aggressively manage people on hepatitis B DNA even after low level viral load. This is something what we all can do that find everybody so that the infectiousness level go down, the transmission rate will also go down. And also yesterday there has been talk about elimination of mother-to-child hepatitis B transmission, and also in the new guidelines we also added giving tenofovir prophylaxis to pregnant women even if they don't fit into the criteria for treatment, even if they have been HBs agent, antigen been positive. It's something what should be implemented. We also need to, educate many of our obstetricians into that, because these are the individuals, good to them. Again, what is required to make a hepatitis cure globally? Again, we need investments for clinical trials, particularly for lower and middle income countries, because the magnitude of infection is so high in resource-limited setting. Again, one size doesn't fit all. We all have failed miserably in developing newer molecules, but on the other hand, we will succeed one day. We need strong community engagement. I think this Liver Foundation did a wonderful thing of bringing a lot of community partners into this meeting. It's something they want. They need to get involved so that they will spread this message in the community, how they can participate in clinical trials. Thereby, we improve our science. And simplified test and treat guidelines. Yesterday, you spoke a lot about this. Also, we had discussion this morning on decentralized care into the communities, tackling stigma and discrimination. Only if you do all those, we'll be able to make hepatitis B cure reality. At this time, I'll stop with this my slide. So I'm from a center called VHS Infectious Disease Center, where we are known for taking care of people with HIV, Hep B, Hep C, and clinical trials. We also do a lot of hepatitis B trials. In the past, we did a lot on hepatitis C. At this time, it's also been discussing with Dr. Vivek. We look forward for collaboration with Chennai Liver Foundation, mainly in the field of doing some clinical trials. Again, thank you so much, and happy to take questions if there's an opportunity. Thank you so much.
Thank you so much, and hopefully we'll have a bit of time for questions in a minute. So I'm going to move on, topical and really important hepatitis B, but I'm going to move on swiftly to Ms. Mila Mastat, and it's global access to generic hepatitis B and C treatment, opportunities for India.
Good morning, everyone. Namaste. It is really a pleasure to be here and to contribute to discussions which are of high importance to India and also to all of us. And today I will be talking about access to hepatitis B and C treatments in low and middle income countries through Medicines Patent Pool, or we call MPP, including in India. Just trying to figure out how it works. Yeah, green. Yeah, this is just to give you a flavor of what I'm going to cover in my talk. And I must admit that usually before diving into patenting and licensing, which is a little bit kind of a might look like a complex issue, I provide a little bit of a background what generics are needed for. What would it have been if it were not for access to generics? What role generic manufacturers are playing in access to medicines? And since we are in India, and India is a hub, India plays such an important, such a unique and incredible role in improving access to medicines worldwide. I think, honestly, there is no need to jump into that, and if you allow me, I will go just straight to the point. And a little bit about Medicines Patent Pool, or MPP. We are a public health organization created back in 2010 by UNITAID with the support of the World Health Organization and UN General Assembly, with a specific purpose, which is to improve access to essential medicines in low and middle income countries and health technologies through voluntary licensing and technology transfer. And in a second, I'll explain like in more detail what is that. Initially, we worked and initially were established with the idea to improve access only in HIV medicines back in 2010. And then, since the model worked really well in HIV, we expanded gradually the model to viral hepatitis and then TB and then non-communicable diseases, biologics and COVID-19, basically to all essential medicines which are recommended by WHO or have a strong potential to be on the list of essential medicines of the WHO. And we are fully funded by UNITAID. UNITAID is our biggest funder, and for some directions of our work, we are also funded by the Swiss, German, French, Japanese, Canadian governments, and by WIPO. WIPO is, as you know, a World Intellectual Property Organization. Here is just a graphic representation of how we work. This is our model, and we are in the middle of this model in the blue circle. However, I must say that we are not alone in this blue circle. So the way we start licensing medicine or working on improving access to medicines is the following. So first, together with the World Health Organization, together with governments and with communities on the ground, communities in countries, we identify medicines which are essential for their health, essential for their lives, and medicines which are needed in those countries. And then we look into those medicines from the perspective if licensing would change anything, if licensing would improve access to those medicines in low and middle income countries. And if the answer to those two questions is yes, then we approach patent holders or big pharmaceutical companies, which are also called originators, to negotiate license agreements with them. And we try to negotiate those license agreements on most public health-oriented terms and conditions, meaning that with one goal in mind, so that more countries and more people in those countries get access to the needed medicines. That's what it means by most public health-oriented terms and conditions. As soon as it is done, as soon as we sign a license agreement with patent holders, then we sign sub-license agreements with generic manufacturers. Or first we issue an expression of interest for generic manufacturers to apply and then signs license agreements with us. And then what happens actually, generic manufacturers compete with each other. And the reason for that competition is because we try to license as many generic manufacturers as possible, or as many as necessary, to create generic competition so that the price go further down. And that is basically how people in low and middle income countries get access to quality assured, affordable generic medicines. And important to mention that quality is ensured by WHO prequalification or FDA approval or approval by other stringent regulatory authorities. And yeah, we are not alone in this model, as I said. So we have 22 partnerships with innovators. So you can see here names of innovators, like I said, patent holders like big pharmaceutical companies like Novartis, AbbVie, Gilead, MSD, and others. And then in each disease area, we have products for which we have licenses. In other words, those products are generics or they could be generics if they are in development. I think now we don't have time to get into each product in each disease area. You will get the slides, you will have a look, and if you have any questions, please reach out to me, reach out to my colleagues. Just to note that the longest list is, of course, in HIV, because we have been working in HIV the longest, since 2010. And also today we will zoom in the viral hepatitis medicines. Of course, our model would not have worked if it were not for generic manufacturers. And we work with a wide network of generic manufacturers, 56 manufacturers and product developers, and they are based in all WHO regions. And you can see names like in the column to the right. I think you won't be surprised if I mention that half of the generic manufacturers are based in India. They're Indian generic manufacturers. And I think you can see familiar names in the column to the left. So 28 generic manufacturers are partners of MPP. And thanks to these collaborations with innovators or with patent holders, with generic manufacturers, with governments, with communities, with civil society, procurement agencies, UN organizations, international organizations, we have achieved some significant impact. And this is just to give you a flavor, just to give you a few figures of our impact. For example, by the end of 2023, more than 40 billion packs of treatments have been supplied to 148 countries. In other words, 148 countries have been benefiting from voluntary licensing through MPP, and thanks to all the collaborations that I mentioned. And global health community managed to save now more than $2 billion through MPP licenses, and the projected savings are more than $4 billion by 2030. And yeah, quickly about access to hepatitis B and C treatments. I think Dr. Kumarasamy already mentioned the WHO recommended treatment for viral hepatitis B, entecavir and tenofovir, TDF. So I won't be getting into details here. It is just to say that those treatments recommended by WHO for treating hepatitis D, entecavir, tenofovir, TDF, they are now off patent, meaning that all low and middle income countries should be able to have access to generic treatments. And then there is another variation of TDF, tenofovir alafenamide. This drug was approved in 2016. We call it also TAF 25 milligram, just as TDF. It is also recommended for HIV and for HPV. And it has potential to have a cost lower than TDF. It is recommended by WHO for treating HBV. And Gilead and MPP, we have a license which is covering 117 countries. And when I say license is covering X number of countries, it means that those countries are able to procure generic quality assured medicines through MPP licensees. And that is actually started to happen. MPP licensees supplied TAF 25 milligram or tenofovir alafenamide 25 milligram to 18 countries. And India have procured by September 2024 more than 1 million packs of tenofovir for treating hepatitis B, tenofovir alafenamide, TAF 25 milligram. Then we have another license for treating hepatitis C. This is daclatasvir. The license enables combination of daclatasvir and sofosbuvir. This is a pan-genotypic combination recommended by the WHO, also included in the WHO list of essential medicines. And with BMS, we have a license. We signed it back in 2015. Initially, the license covered 112 countries. Then it was expanded to 39 more countries and covered 152 countries in total. And then, since BMS withdrew the patent, I think it was in 2021, it means now that basically all low and middle income countries should be able, except Russia, because they have bilateral agreements, should be able to procure generic daclatasvir. Until recently, the price from Global Fund procurements from MPP licensees per treatment course was $72. And I think in April, in Portugal, the new benchmark price for Daxof combination was announced $60 per treatment course. And we now, for example, know that also there are a number of countries which are procuring Daxof combination at even lower price. And these two maps demonstrate the uptake of DAC and Daxof combination. For example, 4.5 million packs of daclatasvir standalone have been supplied by MPP licensees to 38 countries. And more than 500,000 packs of Daxof combination have been supplied to 27 countries. And among those are also upper middle income countries and some high income countries. In India, the uptake is by end of September 2024, 3.6 million packs of daclatasvir and also Daxof combination. And India is actually leading not only on manufacturing DAC and Daxof combination, but also on procuring. And another license that we have for treating hepatitis C is the license for glecaprevir pibrentasvir, known as GP combination. GP is recommended by WHO, by EASL, ASLD, and other scientific society as a first-line treatment, also as a second-line treatment. It has the shortest treatment duration, 8 weeks, including in cirrhotic patients. It is safe to use in patients with kidney insufficiency. This license covers 96 countries. India is not in the territory so far. WHO announced pre-qualification of GP in 2022, so that generic versions are quality assured, and generic GP is under development. And another frontier that we are working on is a long-acting technologies. In 2021, MPP signed license agreement with Tandem Namo and University of Liverpool for the development of long-acting platform technology. And this platform technology can be used for two disease areas, for tuberculosis and hepatitis C. And in hepatitis C, we are looking specifically on long-acting GP. And these medicines are intended to be delivered in a single injection, a single shot, to achieve the desired effect. So this is basically it, and there are some take-home messages and something for us also to discuss. So there is no doubt that price, quality, and volumes are crucial for access. And Indian manufacturers have proved to have a capacity to produce high-quality medicines in big volumes and at low prices. So these elements are present. We have them. Then we can see that quality-assured generic medicines for treating hepatitis B and C are widely available thanks to voluntary licensing, including to licensing through MPP. And thanks to generic competition, the prices dropped down significantly. We can see also the uptake of hepatitis B and hepatitis C treatments is slower, or even much slower than HIV, and I think Geetan mentioned it yesterday as well. And India is paving the way. India is leading on manufacturing of hepatitis B and C treatments, and also India is leading in procuring those treatments for people and supplying people with the needed essential medicines. And that plays a really big role in further price reductions for both hepatitis B and C treatments, not only in India, but also in other low and middle income countries. Because it was already discussed like yesterday, so the bigger the volumes are, the lower the prices go. Oral GP, as we can see, and we heard from a number of countries, a number of stakeholders, that oral GP represents an important opportunity. And that is actually one of the reasons why oral GP is recommended by WHO, and it is in the WHO list of essential medicines. And of course, there is a potential for long-acting GP, and that could be also a game changer. And as John mentioned today, government commitments is key, and government commitments is a magic ingredient. And I really like the definition of the magic ingredient. And I think that magic ingredient is actually missing in a number of countries. But however, I think the magic ingredient is present in India. And also yesterday we talked about a lot of innovation, that innovations really play a big role in service delivery, but also what is important, innovations in treatment. So my question in this respect to you, since we are in India and since we are focusing on access to India, and India is a strategic country for access for the whole world. So my question to you, and by the way, I know that probably I'm not supposed to ask questions, but I ask you permission. So my question to all of you, do you think that given that that interest for oral GP in many countries, and given that India is not in the license, so do you think that availability of this option of oral GP would be important for India? Do you think it would be useful to have another option which is recommended by WHO with the shortest treatment duration, which works particularly well in populations with prevalent genotype 3? So over to you. Thank you.
You want a hands up from the audience, or what is it?
Yes, please okay, come up and tell whatever you think that would be beneficial. Thank you.
So the question is, do you think that oral GP for hepatitis C treatment for 8 weeks, because current treatment is 12 weeks, now it's 8 weeks, is useful in India? Raise up your hands if you think that it is useful. This is 8 weeks short regimen only. This oral GP. Raise your hands if you think. This is your independent opinion, so you can raise your hands. Raise up higher so that we can see. This is really an exploratory of what you think. Would a short regimen of 8 weeks be helpful to India? The current regimen is 12 weeks.
Thank you so much. That it's really it's absolutely super helpful to hear and to see, and also to hear what you are thinking. And if some of you want to say anything, to add, please feel free.
Okay, from John. John is interested.
If you allow, Pauline. And
would a long-acting injectable Hep C cure be useful in India? One shot. Yes or no?
Yes.
Okay, I also yes for the region actually, because I work in 11 countries. So I said yes. Yes.
Thank you so much. Thank you. Yeah, Shvinda, sorry. Would you like to say anything?
With the permission of Chair, may I say something? It is actually, I have been on PrEP for the last, I think now, approximately 8 years. I have been using Tenvir EM, which having the TDF combination. Over the last 2 years, I started having some kidney function impairment because of the long usage. I went to TAF now, which is less potent on the kidneys. Why I'm saying so? Because I'm able to use PrEP freely. Had there been no TEF, I would have to kind of drop off the previous combination, So what I want to say here, what a point we want to make here is that when the more treatment options are available to us, that give you much freedom, much kind of, you are much strong, in that point of time to decide that, okay, if not one, maybe second is one which I want to go for. Here, I also want to say that for HCV, and HVV, as said by Dr. Kumaraswamy also, good that now we are using TAF, because that is again useful for the people who are having the kidney issues and other, toxicity related to that. Similarly, I think for GP, I strongly advocate, because, it gives us the other opportunity. Not only for the people who are having the renal impairment, but also we have a very mobile population. You go into border areas, people just go. And if I talk about my key populations, transgender population, we are very mobile. Sometimes we are here, next day we are in a different location. So I think we need to consider all those vulnerability of the people, and definitely if the treatment timing is reduced, if it's suitable for a large number of population, then I think we should all go for it. And just want to say, end by saying that not only that we need to work on two things. One is we also need to work on the demand side, because I have seen that, unfortunately, fortunately in NVSCP, drugs are there, everything is there, but then again from demand side, we see that not much, engagement of key population. So I think that is something which also I want to bring it to all of you. We need to work on the demand side, and of course, I would love to see more focus on the supply side. Thank you very much.
Thank you very much. So we have time for 2 questions. Yes,
so
please.
not a question, just a comment on the same issue. And I was the part of the guideline development group with WHO for hepatitis C guidelines. And we had a good discussion in the GDG meeting on GP also. And we have seen that there is good evidence saying like it's an effective drug. And this is a very effective combination, shorter duration. That's why WHO recommended it in the first line treatment along with soft Velpa, soft Decla. And I do agree and do support it. It should be promoted. It should be there in the option list for the patients in India also.
Thank you. Professor, over to you.
It was a very enjoyable session, and every talk was fascinating. One is a comment. We keep talking of elimination, but the burden of the advanced disease is huge. Every day we see patients with Hep C or Hep B coming up with advanced disease and tumors. So the guy is Hep C negative for 10 years and he's coming with tumors. So therefore, one thing we should all think about is how do we do post-elimination management of Hep C, those who have advanced fibrosis. There is no program, and every day you have listed patients for transplant. So if we develop a program with whatever Chennai Liver Foundation or so, for post-elimination, we just do HCV RNA, but nobody does long-term AFP or fibrosis or maybe screening by CT or this. Part 2 is for G and P. I think it's a great idea if we can get it, because the moment the patient is a failure, it means he will develop a tumor. So you need to have these cirrhosis or advanced fibrosis where the current regimen fails, especially GNO3, to have a long-term policy for that. So I wish we can take these into consideration and plan it out. Thank you.
Hello. Yeah, myself Rama Pandian from Tamil Nadu Network of Positive People. So I've been personally living with HIV last 32 years, and I'm on ART. So my first question is like, people on ART, the vaccination of hepatitis B, what is your advice on this? The second important factor is like people on treatment, whether hepatitis B or C. How you been monitoring for drug adherence, monitoring all those people? So unless otherwise we involve the community, which is not going to be very effective. So since yesterday, I've been listening to all the presenters. All the presentations are very good. So it is basically the medical-oriented driven approach which was there, including the WHO guidelines. So what I've seen missing gap is the meaningful involvement of community engagements. So we should not use as a tokenistic approach as a community people. We should use as a meaningful involvement in any program, unless otherwise it cannot be successful. What we are going to, our goal is eliminate by 2030 viral hepatitis. So without meaningful involvement, it cannot going to be successful. Thank you.
Gitan, before we, is that Gitan?
Yes.
Yes, just before we get, maybe Kumar, you want to answer that question, and
yeah.
maybe John, you want to talk about meaningful involvement.
Yeah, coming to the hepatitis B vaccination in people with HIV, I think you make sure that, we are part of the guidelines, so everybody should be vaccinated. Also, what we are doing is people who have crossed vaccination for more than 10 years, we are also doing their antibody titer. So there are some studies have shown the antibody titer can go down very quickly if the CD4 is very low. But now with the potent antiretroviral therapy, people do well, so we continue to follow them up, but they should be vaccinated. Coming to monitoring people with HIV and hepatitis B, you know very well that treatment, what we use for HIV, particularly tenofovir lamivudine or tenofovir emtricitabine, takes care of hepatitis B. So, of course, we also monitor the liver function tests periodically, for HIV, so that takes care for hepatitis B if we have been developing any chronic active hepatitis. But on the other hand, what programs are not doing is hepatitis B DNA, quantification. I think that's something, should be done, because now we have, as I said, about a lot of newer therapies coming up. And I think, that's something, because it's been very expensive, there are a lot of other groups that are developing point-of-care diagnostics. So once that is done, I think that will be set as part of the guideline. And again, once you have been, patients are changing from first line tenofovir, lamivudine, and dolutegravir to another therapy when they fail first line, we should make sure that they continue either tenofovir or TAF if they are HIV and hepatitis B co-infected. I think that's something, either the part of the second line or part of the third line. If for some reason you can't give tenofovir or TAF for renal issues, then you may have to give, entecavir. Again, it's not very effective. That's something, again, managing such co-infections is a challenge, but now with a simplified therapy is much more better. Also, I agree and echo with you, involving the communities for every place, not just for making policy, but of course we involve them for developing clinical trial protocols, how to design, so that we'll be able to recruit them in certain trials. We have developed certain clinical trial protocols where we're not able to recruit them at all because communities or patients have been totally against in participating in certain trials. I think make sure that involve them upfront from the beginning so that we'll have the best fruit out of that. Thanks.
Yeah. Let me just add on to that quickly, say that the community involvement is important, as you were mentioning, for research to make sure it's patient-centered. Communities, as we've been hearing today and yesterday, can be excellent delivery of services for vaccination, testing, and even for treatment. And they have a critical role in advocacy to bring that personal story in front of policymakers. But when it comes to advocacy, as we don't want to just leave it to the patients who oftentimes are facing stigma or illness in their own right. It really takes a coalition of not just patient organizations, but health officials, professional associations, industry, businesses, and just the civic leaders, religious leaders, et cetera, just to see who wants to be those champions for hepatitis elimination in that area. And it's quite surprising sometimes among that group who really steps out to become that leader. but more often than not, that's the another critical element is that national or local champion that brings together those coalitions and makes elimination possible. Thank you.
Gitan, over to you.
Yeah, thanks.
And then last from, from Path.
Thank you.
Gitan, over
I'll
to
try
you.
to be quick, but this is a subject area which needs further discussion. And I hopefully, there would be some policy-related discussions later. For any disease area, the more the choices are, the better it is. The more affordable it is, the better it is. So that fundamental premise of access to medicine, of course the quality part comes in, is always there. That's what's good for access to medicine. If we are going to talk only here about glyceprevir and preventacivir, I don't know how many people are watching on YouTube. This could be considered as a conflict of interest. I worry about that. Why I say this is because coming from an MPP point, this is from a point of view, you also have Remdesivir as one product that you have license for from 2017. There is no mention of Remdesivir in this. Why? The other part is India is excluded in the GP license. Whether or not exclusion of India is a different story, but has Medicines Patent Pool contacted other manufacturers in other countries to be able to manufacture this and market this? If you haven't, is it because you have only sub-licensees from India? Dolutegravir, as an example, Celtron manufacturers in South Korea and Thailand buys it. So the entire reliance is not on Indian manufacturers, right? So there are multiple manufacturers on this, on those things. But my thing ultimately is better choices. Dr. Sarin talked about failures. We don't know how many people are actually failing in India. If you assume a 94% SVR rate, we're losing 6 patients who are not responding to this. I would add on to what Dr. Sarin was saying, that we should look at GP. Yes, one could be that option, but our whole outlooks should be better options that are available. As I mentioned yesterday, there is existing license on soft valve voxilaprevir. For retreatment, that is an option with an added PI, not an NS5A and a PI. So that this discussion, this needs to go on. This could not be a hands up saying, do you need or you don't need? And I worry if we go in that direction, we would be heading the wrong way, and we would all here be construed as things that, oh, how did you... There are many people who are not in this room who have worked on access to medicines for a long period of time. These people have worked on waiving the phase 3 clinical trials in India, because of which we all and the rest of the countries outside of India got DAAs in 2015. Without those waivers, it would not have been possible. We would have gotten it in 2016 and or 2017. So my saying is, I'm not against any options. I'm not against. But let's prepare, if it's India, let's prepare India for broader access to emerging molecules and molecules that are already in the market. There is no talk in this, I don't think in here, about long-acting cabotegravir for prevention. We're not talking about long-acting lenacapavir. We're not talking about MK-8527, which is going to be an oral. Dr. Kumar, maybe the trials are ongoing. I'm talking from an access point of view, that how are we going to get this? We can have it in the private market, but how are we going to get this as a part of a national programs to have, to get broader access to people who are needing it, not somebody who would walk into Apollo Hospital and get those meds and pay out of their pockets. I mean, that different kind of benefits he was talking about. So I absolutely support having GP definitely as an option, but I will also request the Medicines Patent Pool to start a discussion, on broader access, including Remdesivir. On 23rd of January, the Malaysian Ministry of Health is going to do their, their launch of their trial results, they call it EASE trial results, on soft and remdesivir, comparing 8 weeks to 12 weeks on non-cirrhotic patients. That's a license you have. That's similar 8 weeks.
Sorry, Gitten, you have to wrap up.
Exactly, Pauline. That's why I'm saying we need longer discussions.
Further, yes. Yes, Miller,
very quick
in
comment.
response.
Thank you all for your opinion, and thank you also, Gitan. So the thing is that, like, as I mentioned, we have different licenses for different products, and we are not trying to forget about one and promote the other one. So our goal is like purely public health oriented goal, public health driven. So we are informing the governments, we are informing stakeholders, communities about all products which are available or which could be available, so that people, so that governments, countries have a choice, and based on their need, they make an informed choice. And that's why, like, it's important that we inform on the Daclatacir license, it's important that we inform on the GP license, on the upcoming products in the pipeline. So that's actually what we are meant to do, and we continue doing. And thanks very much. Thank you.
I'm so sorry, we really have to truncate it right now. Sorry to disappoint the two waiting questioners. So please reach out to the panel speakers directly after this. Thank you very much for a wonderful, wonderful session.
Thank you to our chairs and our speakers, requesting our chairs to please present our speakers with a token of our appreciation, if you would do the honors. And requesting Dr. Ward to present a token of our appreciation to the chairs for this session. Thank you so much. A very engaging session. Let's give them a big round of applause, ladies and gentlemen. In the interest of time, we will keep going. We move on to our next session. I'd like to welcome our chairpersons to the stage. I'd like to call upon Dr. B.B. Rewari and Dr. C.E. Eapen. Can we give them a big hand as they make their way to the stage? And calling on our presenter, Dr. S.K. Saran. Also a reminder to those of you who are staying at the hotel to make sure that you check out before we continue. A reminder that those of you staying at the hotel, don't forget to check out. Thank you so much. And now we'll move on to our next session.
So moving on to the next session, which is state of the art lecture, And for this lecture, we have Dr. S.K. Sareen. Dr. S.K. Sareen is a internationally renowned hepatologist who is the director and chancellor of Institute of Liver and Biliary Sciences, New Delhi. It is the only liver university in the world. And it is also a WHO collaborating center, not only on viral hepatitis, but chronic liver diseases. Over to you, Dr. Sareen, for your talk on a very important burning topic, that is navigating hepatitis B management, treat all or select all. Over to you, sir.
Thank you, Dr. Ivari, and thanks, Dr. Vivek, Dr. Shanmugam, for inviting me. I enjoyed my presentations, and I bring greetings from ILBS. And I have no conflict of interest. Sitting there, I changed my slides. We want HBV elimination, and I was looking at 1995 to 2025, the goals, deficiencies, and my main topic. So these are as per the WHO guidelines. 254 million are living with hepatitis B, 12% are children, and Southeast Asia has a huge burden. And we are adding 6,000 new infected patients with viral hepatitis every day. And the liver cancers and deaths due to Hep B are increasing. And India accounts for about 12% of the global burden. And also our aims are very high, but our pace is slow. If we want to achieve by 2030 a reduction in the Hep B and Hep C, and these are very, very difficult targets. So what have we done? Well, just to reinvent and introspect, 13.4% of people with Hep B are diagnosed. Of these, 20% are receiving treatment. That is an abysmally low 3% or so. So, of those who are diagnosed and those who are treated, these are well known to you, makes us feel we are in 1990s. We haven't done anything in 3 decades or so. So this is what we proposed way back in 2014, 21, and 23. So if you have a pool of 296 million that was estimated at that time, free antivirals, cover of insurance, ensure access, ensure compliance, and make them aware of the risk. And if you treat all, the susceptible host can be definitely protected, one by vaccination, and those who have can eliminate or reduce the viral load. What are our challenges? The current guidelines for treating are very restrictive, and the stigma. We also have delays in HBV DNA, expenses are huge, and there is limited retention to cure and treatment. So currently in 2025, we are doing treat select. We say yes to cirrhosis, Hep B reactivation, high DNAs, fibrosis of F2 or above, or liver stiffness of 8 or above, or raised ALT, and we say no to those with normal ALT, immune tolerant group, E positive or E minus also with low DNA, or liver stiffness of F0, F1. Thereby we deny, and this is a 2024 December, we deny treating 9 out of 10 patients with hepatitis B. So how many in this room will say this is a good strategy that you deny treating 9 out of 10? So patients who have normal ALT, stiffness of less than 8, or mild fibrosis or low DNA, are they having disease? So we say they are hepatitis B carrier, and carrier by definition is a person who carries an infection, can transmit the infection, but he is asymptomatic. So is an inactive carrier, is he really healthy or he has a disease? And this study, based on about 1500 odd subjects, showed that people who have normal ALT, who are asymptomatic for more than 1 year, in them a liver biopsy shows F0, F1 fibrosis or F2 fibrosis. 40% of the patients had fibrosis. Well, should we not lower our threshold for treatment is the question. In the same study, those people who were having E negative and they had normal ALT, persistently normal ALT. See this graph on this side, sorry. The graph on this side, you can see 35% of them had a DNA level which is more than 5 logs. Just to tell you that people who have normal ALT E minus, even them 1/3 have DNA which is high and can transmit this DNA. This paper made the basis for seminal changes in several countries. Now 20 years later, you see this paper coming in and it shows the same data. It shows you that in people who have an ALT level which is less than 35 or 25, not to talk about 40, in them you will see that the DNA can be high between 5 to 7 or more logs in about 45% of the patient. Means they are viremic, they are able to transmit, and furthermore, if you see carefully this study of 2024, these are people who have an ALT level of less than 40. Here you can see, just to summarize, 66.7% of patients who had detectable, not high, detectable DNA and normal ALT had significant inflammation, fibrosis, and histological disease. So if 2 in 3 are having the disease, then are we treating or we are ignoring them? Our efforts of 99, we said that the term carrier should be dropped. It took us a lot of time, but now American liver, European and Apostle, none of them uses the term carrier. They would like to say that the new terminology would be that E positive chronic infection or chronic hepatitis. Here there is a disease. E negative with chronic infection or E negative with chronic hepatitis and occult B. So the idea behind with carrier, you are a little laid back, you say don't worry, go home. But with infection or hepatitis, you are a little more involved. So now let me go back that people who are normal ALT, less fibrosis and low DNA, can they transmit the disease? And what happens in their long-term history? This is a very important slide from Korea, which has 98.5% follow-up. In this, they say those people in the red, those who were immune active and were treated, so they were raised ALT or DNA and they were treated, they had a much lower incidence of liver cancer or death compared to those who were immune tolerant, normal ALT and were not treated because they had no fibrosis. Well, and this is a landmark paper by Antonio from Singapore. He said that the child is born and as he grows up, there is a HBV integration and a clonal hepatocyte expansion. So these hepatocytes, they will have an expansion and they will have an immune tolerant state. So very early, if you do liver biopsies in them, the DNA gets integrated. So he termed these patients not as immune tolerant, but high replication, low inflammation stage. And his suggestion was also that not giving them treatment is unfair. Let me see, is the current treatment effective and it is beneficial to them? Well, this study shows from Taiwan that there is, if you are giving tenofovir, there is a reduction. So these are placebo. In them, F3, F4, F5 fibrosis increased over 3 years compared to those who had tenofovir. Similarly, in placebo, the fibrosis progression was almost double than those who were treated. In 3 years, you're talking of life. Then, if you are giving the antiviral therapy, the ALT gets normalized. The ALT gets normalized in 81 compared to those who are not treated. And this normalization can be achieved within a period of 3 years. So are long-term nukes desirable? This study shows you clearly if you are giving long-term nukes, the risk of HCC is decreased from 3 to 1.5. And this seminal paper in NEJM by Yun Fin Liao showed that giving lamivudine compared to placebo decreased the progression of disease. So disease progression decreased, liver cancer decreased. Now, is HbA1c loss, which is part of the functional cure, is it desirable? So, treating long, you lose HbA1c and then the liver cancer risk is about 2.1% compared to not losing the virus. Here, 13.6. If you just suppress DNA, it has come down, but 5.6%. But if you are losing HbA1c, it is much better. Let's say we can't lose HbA1c, at least you decrease the risk of liver cancer. So with all this background in mind, benefits of treating all is that we need to have a strategic shift to get closer to eliminating hepatitis B. And the guidelines, which are now more liberal by WHO in 2024, they still need to improve, and most importantly, what we are talking should be decentralized. Each one of the person here can educate and get every single physician to treat hepatitis B. So these are the Chinese guidelines. See the beauty of this. I'm sure you are aware, if the subject is HbA1c positive, do DNA. If DNA is detectable, treat, no questions asked. Here, if you are HbA1c positive, DNA detectable, and age is above 30, yes. If the age is young, even between 1 and 7 years, you will treat. E positive with chronic infection, there may be questions. With elevated ALT and risk factors, you treat. By and large, their formula is simple: HbA1c positive, DNA positive, treat. Well, what is the advantage of treat all strategy for currently treatment ineligible 9 out of 10? The advantage is you can achieve functional cure, probably DNA loss over time, fibrosis regression for certain, and HCC prevention in non-cirrhotic. 50% of hepatitis B cancers occur in non-cirrhotic. Well, you can also prevent cirrhosis. Resistance to tenofovir is almost negligible. Long-term adherence is low. It is just 75%. Also for vaccination. The new flares will be unlikely. Yes, the cost of formulation, it is much cheaper to treat for 6 months than to do HBV DNA single test. And also the side effects are less with TAF, and I am certain to say psychologically the patient is hugely, I have got something, I have got a treatment, I have got a drug, my virus will go, I will not have a cancer. Believe me, these are, and for World Hepatitis Alliance, this would be a huge change to get the society, the patient population integrated. Yes, I am getting. The HIV, everybody get drug. Everyone is happy. But hepatitis B, the patients are so unhappy, they cry. Well, this is the way the data is from China, 2024 December. They took us, 2014 we propagated treat all, and now what China has done is this. China Registry of Hepatitis B, a hospital based, has more than 400,000 patients and 55 centers. 95% of them have HBV DNA positive. And that is there, they're all included now in the guideline. In fact, if you look at the people who are above the age of 30 years, that is 70% of them, then you will treat, and even younger, you will be treating. And I am happy to say one of my colleagues, Jin Lin Hao, has taken 3 provinces, whole big provinces in China. They started in November of 2024. Every single citizen is being screened in that, and every single citizen, irrespective of fibrosis, HbSAg positive, DNA positive, is getting treated. Well, what are our barriers to achieve the WHO goals, which Pauline would love to know? First is lack of awareness amongst public and policymakers that hepatitis B is a serious problem, but it can be treated. The immunization status of healthcare workers is not known. We did the first study in 2007 of about 1,100 healthcare workers in Delhi. To our utter surprise, nearly 27% never got vaccinated, and they are doctors. And about 30% had only 1 shot or 2 shots, no third shot. And in the remaining 35% of doctors, the the anti-HBS levels had come down. Well, I hope the Chennai Liver Foundation at least can help us, and other liver foundations can help us in this. The next challenge is under treatment of those with a risk of developing complications. They are denied because they are not aware. And this is exemplified by late presentation of liver cancer in 50%. Now, this is a publication on behalf of the Viral Hepatitis Elimination Task Force of APASL, Asian Pacific, which has nearly 200 odd members from different countries. And this is published by George and Chen. And the data is important. It is the mortality to incidence ratio. Means mortality is higher than the incidence. And this has not changed from 2001 to 2020. We are still having people, and this shows the people are coming late to us. Have we achieved a reduction in HbSAg prevalence? Certainly. From 1990, we have come down maybe 31% or so, we have come down. But still, if you look at in the children as well as there is a still lot to be done. So our journey in 30 years is just this much. I think we need to move fast and make changes in our pace. So I would now briefly try and say what are the issues. Benefit is not known, that if I get treated, I get prevented. Adherence may be low. Withdrawal can have complications, especially in advanced disease. They have to be monitored. Side effects, yes, there could be bone decay and others, but these are known with diabetes drugs. They are known with statins. They are known with aspirin that the guys can bleed. So why only make a hue and cry for hepatitis B drugs? Yes, there is a stigma and there can be a cost. For a stigma, we started in 2018 a campaign which is done by Indian Parliament now called Empathy, empowering people against hepatitis, to give voice to people, and there we train a large number of people's doctors. This is a network, and I am sure we will take guidance from World Hepatitis Alliance. And in this, we had one of our ambassadors as Amitabh Bachchan, one of the top Indian actors who was there on World Hepatitis Day, and we have partnership with several organizations, NGOs and others. Well, this was Dr. Rewari there, as you can see, and with all the presidents of different societies. This was the first joint statement on stigmatization and discrimination, which should not be there with hepatitis B. What about the cost? Now, the current policies, there is a huge cost to the patient, direct cost of the treatment and the investigations, the travel cost, the psychological stress. An indirect cost to us, I have to give appointment, he has to give appointment, nurses, doctors, and the hospital care. Every 6 months or a year, the subject comes, so the health cost, nobody has worked. So what this group with Mark Thurs and Humphrey Hodgson, who were there earlier, this group from UK and in Gambia, they published with Minde that treat all versus targeted strategies in Lancet, which one is more cost effective. Let's look at the cost of the drug. Please see very carefully the laboratory test and hospital admissions. Using the EASL guidelines, what you are doing is lab tests are taking away all your money. Hospital admissions is taking, but what about the drug? This is the only cost. But if you use the treat all strategy, your money, same or maybe less, goes just for giving the drug and getting the virus out. So let us be wise not by just doing tests. Let us be wise by giving and delivering the drug and making them better. This is the cost difference if you use the EASL guidelines versus treat all, the difference, but the advantage is the quality of life and the years of life saved. Here you don't, here you add. What do you want? Years of life saved with a almost comparable cost, because the cost is of the drug. And this we wrote in another Lancet brief note this year. Treat B or treat all. Time for a broader vision on hepatitis B elimination. Why I'm saying you? Because every day, every single patient I get pained, because every single death of a patient with hepatitis B anywhere in the world should be a wake-up call and a reminder that policies for hepatitis B control are imperfect and the decision on treatment has been delayed. I am sure you would feel from a doctor's heart, a liver cancer comes, the guy doesn't know. And yesterday I was telling Dr. Rewari, I have a 21-year-old boy who has come with a large 13-centimeter liver cancer. It pains us to say that we are a failure, and we are, because we are still stuck up by who to treat, who not to treat. But this 21-year-old does not know what are your policies. He only says, I have hepatitis B and liver cancer. And that is the reality that every single patient would ask you, doctors, policymakers, politicians, what are your policies? How could I get hepatitis B and liver cancer? Well, we treat all with HIV. We treat everybody with Hep C or TB. Why say no to hepatitis B? In my opinion, and I want all of you to say and maybe vote, all HBsAg positive should be assessed once for disease stage, HBV DNA positivity, and treat all. Assess yearly. China has started and we have not. And therefore, before I go further for my last two slides, I would like those who are in favor of treat all, please raise hands. Well, fair number, and the chairs also. Okay, we may have some discussion, but at least the mindset should be clear. Now there are two questions, and I put it together, although there are very many senior doctors, but I put two questions. How many of you are immunized against hepatitis B? Raise hands. So what is your anti-HBS? All right. So vaccination is not equivalent to immunization. I just wanted to give this message, and the public health, and I see Giten here, public health people, physicians, you are the team leaders, should lead by example. Your anti-HBS should be more than 100. Bank should be rich. And we would like Chennai Foundation and other to screen all the physicians across or healthcare workers across India. What is your anti-HBS level before you touch your next patient? Thank you for your kind attention.
Thank you, Dr. Thank you, Dr. Serene, for a very powerful presentation with the evidence on why not to move to treat all. Over the years, we know that guidelines have been changing as the evidence emerges, and we have seen this in HIV, CD4 cutoff of 200 to now treat all in 2016. It took almost 12 years to move to treat all for HIV. For hepatitis B, yes, you have presented evidence, and this evidence, many of these were discussed in the WHO guideline development group also, where there was a lot of debate on treat all, but they stopped short of treat all, but the guidelines which have changed will make more than 60 to 70% people eligible. I think there are more evidences which need to be considered, and in my opinion, but I'll open it to the House, that there is definitely a case you have a virus, you must tackle it. But I'll open it for discussion from the audience, comments. Dr. Shanmugam.
I'll have to tell my story before I put up a question. I was affected with hepatitis B way back in 1980s. And then at that time only interferon was available. I took it full course with a lot of side effects, continued my work as a surgeon, and then I continued, the lemivudine came. I took it for about more than 5 to 6 years, and then I took, my enzymes gone up again. So I had to go and visit my son in England. At that time I visited Mutimer, Dr. Mutimer in Birmingham Hospital. He's a pathologist. I consulted him. He said, you have got a resistance to entecavir. So what should I do? Now adifovir has come. You combine adifovir and entecavir. I took it for another 5 years, entecavir and adifovir. And by the time about the 12 years over, and then I checked up, my liver has gone for cirrhosis. And then another 2 years I've been on medication. And then when I was regular checkup, I had a small tumor in the liver. Then I consulted Dr. Rila, who has come down to Global Hospital in Chennai, and my son was with him as a liver transplant surgeon. He said, you'll have to go for transplant. It was done. And now I'm okay. HBS is negative. It's about 13 years over. Why I'm telling this, if you treat all these patients with these available medicines, what about the resistance? How many people will be taking regularly or irregularly? Already we have got a name called Indian bug. So we develop resistance, and the most of the people really requiring the treatment, maybe that they will develop a resistance and then their drug doesn't work and we don't have right now any other medicine. And the cost of the newer medicines which is on the pipeline, what Dr. Kumaraswamy just now told, it's all will be very, very, very big burden for us. How are you going to manage this?
Thank you, sir. And it's humbling to know how you, with God's grace, won over your illness, and also you are an example of a success after transplant, and may you have 100 years of healthy life. And, and I can see your commitment to the Chennai Liver Foundation and what you created by self, kind of motivation. The drugs today are very cheap, relatively inexpensive. They are part of the national program which we got. So 2018 onwards, we had proposed that all the hepatitis B testing and treatment should be free of cost. I know sometimes the only Hep C drugs are there, but we can work, and the national program is committed for providing diagnosis and treatment. The resistance level to tenofovir is almost negligible, but we do see. But that would be maybe 1 in maybe 10,000 or so. The resistance is less than 1%. Side effects, yes. Compliance, yes. But these are true for insulin, these are true for blood pressure medicines or statins or so. In a larger perspective, if you see 98 out of 100 get benefit, any such policy should be considered as useful. And therefore, looking into what your resistance and your thoughts, we can still debate and consider. Yes.
Yes, Dr. Sareen, actually your presentation was really eye-opening for us. We enjoyed your presentation. So my question is, actually we give universal vaccination for healthcare workers, but we are not doing mandatory HPSAG testing before that. So that also makes the population vulnerable for missed out population who are infected. So actually at our institute, at National Institute of Siddha, for all the employees as part of the annual health checkup, we did the HPSAG before giving hepatitis B vaccination, and we found that out of 420 employees, 4 of them turned out to be HPSAG positive. So if we were to give vaccination without testing, we would have missed out on those 4 people. So is it not necessary that we do a HPSAG testing before vaccinating, especially in the healthcare workers sector?
I totally endorse 3 things in healthcare workers. Anti-core and HBsAg both should be done. Not only HBsAg, anti-core as well. Number 2, those who are HBsAg negative and anti-core positive, a vaccination will work like an anamnestic reaction, and it will be like a therapeutic vaccine. The occult hepatitis B can be cleared, and we showed it about 25 years ago. Anti-core positive, DNA negative, but he has a DNA which is very low. You give a vaccine and it clears. So that is the second part. Third, anti-HBs in a healthcare worker should be done, but before that, you should also see, and a yearly program is perfect. But you must see if he is improving or he is stationary. So everybody who has an anti-HBs after the last dose should be monitored. Healthcare workers should have very good anti-HBs titers. And thank you and compliments.
Thank you, sir.
Dr. Sareen, thanks for a very nice talk. But I think we'll need trials in specific groups before we expand to treat all. Immune tolerant people, the resistance rates that we know for tenofovir may not apply when we treat immune tolerant people whose viral loads are about 1,000 to 10,000 folds higher than the groups in which trials have been done. Secondly, in people whose viral loads are low, we will need to have trials to show that if they are given antivirals, clinical outcomes change. We all talk about integration of DNA, but we really need to keep in mind that none of the drugs that we have available don't do anything to the integrated DNA. Integrated DNA, if that is the cause of cancer, does not get affected one wee bit by giving tenofovir, entecavir, or any of the drugs that we are even trying to develop, except things like antisense that are being developed. So I think once we have not shown that there is benefit, and once we have not shown that there is no risk of increased resistance in immune tolerant, there are challenges in using the policy of treat all. Thank you.
Yeah, Rakesh, I know you have a very critical analysis of things as always, and I appreciate. First, these drugs don't work on HBV DNA or the CCC DNA, but yes, at least they will become not a transmissible person. So if I have DNA, and we showed it, and I forgot to show the vaccination failures. So if the mother has HBV DNA even less than 100,000, means 3 logs, the transmission rate to the baby is 26%. So I am totally against the MTCT of 10 log 5 or 4. Even with 3 logs, 26% transmission. Coming back, so if you are not able to clear, at least you make him non-transmittable. As far as the resistance, yes, we should try and see in long-term data, but it may take another few years. We are doing one such trial now, and those with normal ALT, despite efforts, only 82 patients are enrolled. So while we wait for trials, we can always look back and see how many have we benefited. So let's say one part can be research, and where is John? Is John around? No. So we proposed this to the John 10 years ago, a project proposal just costing $24,000, which we never got, and they were very keen, but we couldn't do it. So doing trials in this is not easy, but I agree.
Sir, but saying that 3 log DNA leads to 26% transmission from mother to child, then your results must be extremely unusual. There are umpteen number of studies available to show that with those viral titers, the mother does not transmit infection to the baby.
Well, we can debate on this because these were all done on the tissues, PCR, umbilical cord, but we can debate on that. And there is a Lancet paper from us on that also, but we can debate. Yes.
One last question from Rachel.
Yeah, just more of a comment really. So at the World Hepatitis Alliance, we did an article in the Lancet as well where, we have over 336 members, and representing those members, the biggest and the loudest voice of the community want treat all. They want the access to treat all. So being able to have the choice, because I think what we forget is that it's more than just the clinical decision. So if you can treat all, give the option, because there are other things. People affected by hepatitis B, they stress. It has an impact on their families. There is stigma. And if you have the option to access treatment and have that choice, it changes. It dissipates the stigma. It dissipates the impact within the family relationships. So and that is what came out. When you look at the global guidelines, even the ones from the World Health Organization, the guidelines, there's a caveat in there. If the patient requests a need, you should give them the option to treat because of the impact on their well-being and their mental health. And I think we cannot forget that, and it's really important that patients have the option to choose.
Thank you. I know that guideline part, but many people don't read that part.
It's right at the bottom.
I know it's a very small thing, but very important that you are with us on that. Let the patient have an option. That's all right. But we can say that we can reach out to you. We are there for you. Thank you.
Thank you for comments and from everyone. I think if you look at holistic picture, and I'm happy, and we should be happy that we are making a case progressing towards treating all. We are generating evidence, we are collating evidence what is available, and I'm pretty sure that things are going to change over time. I said, I believe if you have virus, if you have drugs, you must try to tackle it. And you pointed out and we had discussion yesterday on the mental health of people with hepatitis B, big issue. So I think we'll conclude it here. Thank you very much, sir, for your presentation. And we move on to the second talk. Second talk is on policy and advocacy for reducing burden of liver cancer. We know that more than 830,000 people die of liver cancer every year. We know that liver cancer incidence is on rise. There are studies modeling which shows that it may rise by 55% over the years. And we also know that the commonest cause as of now for liver cancer are hepatitis B and C. But before I request Dr. Sareen, there is a study from Institute of Liver and Biliary Sciences done recently in Mohalla clinics, which are kind of primary health care centers, and also analysis of the data from liver cancer patients coming to 11 centers in Delhi, which shows that now NAFLD it has overtaken hepatitis B as common cause of liver cancer. So over to you, Dr. Sareen, for the next talk.
Thank you. People generally don't like to listen to talks at one go, but I thank Vivek for allowing me to do this so that I may be able to leave. And this is a talk which I prepared with great passion because this is what we actually see. Can we have my slides, please, there? Yeah. And this is involving policy and advocacy, in both of which I am poor, and my colleague Manya is smarter, and she helped me. And the clinical part is also there in this involvement. All right. Now, this is our review, 5 years ago, where if you see India here, if you see India, majority of cases and the cause of death was hepatitis B, and other causes including alcohol were considered to be 30% or so. But this was based on data up to 2015 or so. Now please see carefully what has changed over time. Now WHO CC at ILBS has been working for almost now 10 years or so, and this is the publication about which Dr. Rewari was alluding to. Now these are etiological fractions, and you will see that diabetes made in non-cirrhotic half the cases and in cirrhotic 35% of the cases. And hepatitis B is less. So what a huge change. India is the diabetes capital, and here now you see diabetes as #1 cause of liver cancer. Well, this was done later, but earlier publication in Nature Reviews shows you countries where fatty liver as a cause of cancer. And India stands out, other than 1 or 2 countries, with 35% to 39% as liver cancer due to fatty liver disease. So there is a huge change over time. And this is the number which shows you that after China, in India, till 2040, the number of cases are likely to increase. So for us, liver cancer is a huge problem, and thank you for involving us into this presentation. Now the policy and advocacy for reducing. So what we are looking at, is in the prevention, in treatment, detection, linking to care, research and control and risk factors. I am going to make it very enjoyable for you. Well, let's say the primary prevention, where we have HBV vaccination and therapies, lifestyle, antivirals, environmental controls, and I'll go step by step into the primary prevention. Well, vaccination, as everyone knows, reduces the risk of liver cancer, and birth dose, which WHO proposes, is very useful, but also healthcare workers, because many doctors are getting. Tenofo reduces liver cancer better than Anteca, but there can be a debate, but these are meta-analysis. PEG interferon plus nukes, this is the Singapore study by Senghi. HbSAg loss is more and liver cancers are less. So I think combination therapy, and the first publication on this was in 2005 by us, combining lamivudine with PEG. The global strategies currently where we are, you can see that in 2030, you want reduction in mother-baby, but birth dose are not there. Testing, we want this, but we are not there, huge gap. And treatment, as I showed you, what we want is not there. So, the viral hepatitis scenario continues to trouble us. We need to improve that. Now are the important parts. You know all this, but I'll show you some data how weight reduction decreases liver cancer and physical activity, diet, alcohol, and smoking. This paper in our best journal, Hepatology, shows you the effect of metabolic traits. And Ajit is here, who was one of the first, and his paper is most cited, that people who have got one of the 5 or 2 of the 5 or 3 of the 5 metabolic traits, the liver cancer incidence increases. So metabolic trait means you have inflammation in the body. The physical activity decreases. High and moderate decreases. High certainly decreases more, 26%, and moderate decreases 23% the liver cancer risk. So all of you are runners and gymmers, say yes. All of you, none of you, the present here will get a liver cancer. That's correct. All are immunized, not vaccinated. All right. Dietary interventions. Hypocaloric diets, high in trans saturated fats and fructose. So hypercaloric with fats and fructose and red and processed meat, especially the amines and hydrocarbs, they cause tumors. So reduce them. And of course, now we have an Indian hepatoprotective diet, very helpful, Mediterranean fish or omega-3, and not the intermittent fasting, but time-restricted eating. Now coffee, these studies, there are several of them, 2 million odd people, it reduces the risk, and green tea is also reducing, but some people say coffee is better, and 2 cups or 4 cups remains up to you. And the reason is it has something very unusual, chlorogenic acids, caffeine, and catechins. To me, most important, it decreases phosphodiesterase. The PGE, phosphodiesterase E, is inhibited, and which is very helpful for us. Now, alcohol as a cause of liver cancer, it is in Europe, and you can see several areas. Alcohol is the major cause of liver cancer. Half of liver cancers are due to alcohol. We never thought in India it will be, but it is 15% of liver cancers. Why and how? If somebody has hepatitis C and alcohol, and how much is 60 grams or 100 grams, you can see it is almost doubling up. Same is true with hepatitis B. So B and C plus alcohol is a more additional risk of liver cancer. And this is the data from hepatology. If somebody has, please see carefully, if there is only presence of diabetes, risk is 2.4 times. If there is presence of only alcohol, 2.6 times risk of cancer. But if there is a diabetic who is drinking, the risk is 10 times. Is the public aware of this? Diabetes increases risk, alcohol increases, and the two together are deadly. Well, on hepatitis B scenario also, you can see the odds ratio for developing alcohol plus hepatitis B or hepatitis C is increased. Smoking, we never used to connect, but smoking causes one puff, your TNF-alpha, tumor necrosis factor, goes up, and an increased TNF causes liver cancer. So here, those who are former smokers, current smokers, and heavy smokers, you can see that there is an increased risk of liver cancer. So you have to advise your patients, and these are all primary prevention. Well, nowadays you get all these mushrooms, And aflatoxin comes on many of these mushrooms and other products. So, and especially in several parts of East. So please, and the government has to look into, there is no policy in India for aflatoxin B1. Exposure to arsenic and vinyl chloride has decreased, but several other factors, genetic, are there. Now I'll try and go into some pharmacological primary interventions. Please pay attention to this. Aspirin. This is a JAMA paper, very important. Those who have used aspirin only for 90 days, or the New England paper, there is a 30% reduction in liver cancer. I thought these were just 2 studies. I updated till 2024. The data remains same, 25% to 30%, 50% reduction. So aspirin prevents liver cancer. Can you give it? And is it safe in liver patients? Needs to be seen. Statins are everywhere, but for liver cancer, they are reducing by 32 to 50-60% reduction in these very high impact journals. And the effects are seen generally with simvastatin or lipophilic statins and not others. Now there is a huge surge of GLP-1, but I looked into, and this is a Nature review just published, Nature review, which says your drugs which decrease sugar levels, metformin, same is for GLP-1, semaglutide or others, SGLT2 or thio, all of them by one or the other mechanism, they are inhibiting the development of liver cancer. So for diabetic patients, having a hypoglycemic drug, any of these will prevent liver cancer. And this is for all of us as policymakers to encourage the governments to give especially SGLT2 or metformin. Now let's go to secondary prevention. Secondary prevention is where you have a target population who is under surveillance. So whom should we have under surveillance? All cirrhotics. Non-cirrhosis, but those who are Hep B positive or have a family history of liver cancer, Africans, and I would also say South Indians for some extent, anybody with F3 fibrosis and fatty liver disease. Our modalities can be ultrasound, CT, MRI, AFP, PIVCA, AFP3, and some risk stratification. So here we are on the tertiary. In the tertiary, a person has got liver cancer, but after liver cancer, does he have any more time? Yes, to prevent recurrence of this. I'll just take 2 minutes more. So what are our initiatives? FIB4 I would say is important, at least 70% it will help you. If you have ultrasound and elastography, but this can be done even at a primary health center. And we should extend these screening methods for liver fibrosis potentially for all district hospitals. We don't have a referral system or connecting to care, and therefore we need it. We should have awareness campaigns, and also NGOs like Chennai Liver Foundation or maybe 1,000 NGOs should get connected. And yes, funds will come, but we have to generate them. Our advocacy. We are trying at the government level, and today I got a big lecture from Pauline, what all are we supposed to do for the government. And I am committing to Pauline that I will try and work along with my colleagues on the government levels, NGOs and advocacy groups. We don't have data-driven campaigns like in the Korean population, and India needs epidemiological data, and as Rakesh also said, to highlight the burdens and the challenges. We have to have some taxes on alcohol, and the Surgeon General of America, I'm sure you are aware, on January 4th, put alcohol as a carcinogen. So in the US now, and WHO for sure says not a drop. And we also need to have subsidies, and I'm told by Dr. Shanmugam just now, so I changed this slide. He says that hepatitis B vaccines are not being produced in India because they think they are expensive. So we need to work on this. And I would like you to encourage and have similar programs like Empathy, where thousands of patients community network program is there. Before I go further, I want to say at least half a dozen doctors in 2023 were denied admission in surgery or surgical branches. Half a dozen postgraduates were denied. They were said, you take up community medicine or you take up something else. And I fought for them and I succeeded in 2 out of 6. In 4, the institutes denied their admission into the desired surgical branch. So my carry-home message for how you can reduce liver cancer, we have huge campaigns for breast cancer. Everybody, every celebrity joins. Maybe World Health Alliance can provide us with some global celebrity. Like breast cancer, we need an awareness program for liver cancer, where you can say, and maybe Dr. Shanmugam can be one of the stars, how you can beat cancers. We need to scale up vaccination, both birth and adult. We, in my mind, treat all HBV, at least we will reduce. We must support hypoglycemic, lipid-lowering drugs and aspirin, and certainly coffee. We also need to integrate screening into primary care, and this is happening in India. Now every district, every sub-center is now screening for fatty liver. If you are screening for hypertension, diabetes, cancer, liver screening has come up. However, the triple screening policy, which Pauline says we need to get in, we don't have point-of-care diagnostics. We need to have interventions which are acceptable to village and the city, urban, and innovative. And of course, we need to have policies and funds, and for which such meeting like today makes clinicians to come out and think what can be the policies, where we are lacking, and how to reduce the burden of liver cancer. Thank you.
Thank you, Dr. Sareen, again for a very excellent lecture. When we talk of policy change, we know that advocacy works, and we have seen that it has worked in other areas. And it is important that it comes from multiple areas, not only Liver Foundation, Liver Institutes, it comes from other NGOs, it comes from IMA, it comes from API, it comes from other associations, but most importantly comes from community. We have seen the effect of community engagement in HIV program. So we need to have similar engagement on advocacy from community on. And thanks for guiding and how can it change into policy. So since we are short of time, we'll just have 2 comments. We already see 2 people there. And after that, we'll close this session.
Very quickly, I would like to congratulate Dr. Sareen and for bringing up the issue around stigma discrimination in the health workforce, doctors who are infected or pre-service or medical students or paramedical students that are infected. This is an ongoing debate in many countries. And because health workforce is really precious. We have seen this during the pandemic. In some countries in the Western Pacific region, in Cambodia, for example, we found 6% hepatitis B among in-service healthcare providers at every level. In the Pacific Islands, 1 in 3 healthcare providers were infected with hepatitis B. Not because it's just mother-to-child transmission, vaccination rates were very low. So people were just infected, you know, during mother-to-child. But these are this is a reality of health workforce today. But you have to protect them because they still have a lot of productivity. In Papua New Guinea, 50% of in a screening of the healthcare workers in one of the provinces, 50% of the healthcare workers were infected with hepatitis B. And when we discuss with them, they say, you know, death in healthcare workers was very high because of hepatitis B. So we have all this situation now that, because vaccination programs and timely birth dose it's still very challenging in very many countries, especially in the Southeast Asia region. As you can see, our overall timely birth dose in this region is still hovering around 50–60%. It's not good enough. We're still missing so many children, and if we in many of our countries we still have major stockouts of the timely birth dose vaccine. So this is still a critical issue, and how do we make sure that every baby gets their timely birth dose? Because that is the one most important prevention of hepatitis B infection, especially when the mother is hepatitis B positive. Thank you.
You want to answer or should I? Okay, the question I have is, my son asked me before I came for this conference, he said, I'm going for a liver conference. He said, Daddy, I have fatty liver. What do you advise? And I said, see, everybody is saying fatty liver is nothing to worry. This is what we have been told. And so now you said there's something called surveillance of fatty liver. Now what do I go and tell my son? If you give me the advice, I'll advise him, and maybe the same advice will hold good for all the others.
Thank you for bringing this, and I know it's a long answer for your worries, but fatty liver is 1 in 3 in India. It means 10% or more fat, the liver weight is having fat, and this predates diabetes by 15 years, blood pressure, heart disease, and is the single most large cause for all cancers, including breast cancer, prostate cancer, colon cancers. And the Lancet 2024 tells that if you have fat and fibrosis in liver cancer is 1.8 times, 80% more. But extrahepatic malignancies are 10.2 fold higher. So the first thing, it is an important thing. Don't say he has it, I have it, so what? The approach of so what is changed, that it is a fire alarm to be extinguished. Number 2, what should your son do? Simple thing, height minus 100 is the weight. If he is 170, his weight should be 70. If parents have diabetes or metabolic risk factor, and this is what Ajit's study showed, and this is a global most sought after study, is that if the parents have, and Ajit, for your information, in the new Nature Review guidelines, this part is included, in alcohol also. If the parents have diabetes or blood pressure or anything, the children are more predisposed, and there is a walking gene, they will get it 20 years earlier or so. So your son will be what you and your wife are, and his children will be what he and his wife is. So let him be aware that this happens, and how to get treated is his own. All right? Thank you.
I know there are a number of hands there, but I have been asked by organizers to close the session. Sorry, you can have interaction with him. Sorry, Kaushalya and Kerry, we have to close it. We can talk over the lunch. He's here, and then we can talk over. We'll just come to you after getting down, and then you can talk. So
Thank you so much. Thank you to all of our speakers. Can we give them a big round of applause? And yes, they're available offline if you'd like to chat with them a little bit more. I request our chairpersons to please do the honors and present a memento to Dr. S.K. Saran.
May I request Dr. Shanmugam and Rachel to please join us as organizer. Rachel, may we request you to join us?
I also request Dr. Sarin to do the honors and present a token of our appreciation to our chairs for this session. Thank you so much. We'll now move on to our next session, leveraging communication technology for knowledge and awareness. Please welcome our chairpersons on stage with a round of applause, Mr. Carrie James and Dr. Lokesh. And can we also have a round of applause and welcome our speakers, Dr. Prantar Chakrabarti, Dr. Santosh Jacob, and Dr. Ganesh Kumar Parasuraman.
Not sure if I'm supposed to wait till the music stops. All right, hello. Hello, everyone, and welcome to this session, Leveraging Communication Technologies for Knowledge and Awareness. My name is Carrie James. I'm Chief Executive of the World Hepatitis Alliance, and my co-chair will introduce himself.
Hello, everyone. I'm Dr. Lokesh. I'm the scientist here at ICMR National Institute of Epidemiology, and glad to be here, and my sincere thanks to the organizers for giving me this opportunity. Let's move on to the session.
Great. Okay, I can do the first. We want me to do the first? So we have three fantastic speakers today. So first we have Dr. Chakrabarti, who's going to be talking about harnessing technology to strengthen public health systems. Please.
Thank you. And I also have a question with the permission of the chairs. How many of you were there between 8:30 and 9:30 in the morning? Please raise your hands. You can go for a cup of coffee, right? Because I'll be discussing the same things. And Dr. Ganesh is sitting there. He told you what the problems are. Because I have a flight to catch, he will take it up later, right? So this is how vaccines are transported in India. This is not a river, but yes, akin to a river. And this is how ICMR did during COVID-19, right? So drones were used, and you'd say simple, isn't it? So technology is there. We have replaced this human with the drones, and we are getting the vaccines. Now, public health care, public health delivery has its own nuances. And I'll just give you a helicopter kind of view, because it is a combination of resources, organization, financing, and management. And you know, if you look at doctors, they abhor going into management, right? They say, I'll do my clinics, not there. But all these pillars should culminate in delivery of health services to the people, right? Who are paying the taxes or who are the citizens. Now, strengthening of health system, you know, it opens a lot of avenues, but the most important which have been defined by World Health Organization are, we discussed about it in the morning, access, coverage, quality, and efficiency, right? So if you have access and coverage, but you don't have quality or efficiency, you're again down below. So this I have taken from the Ministry of Health websites. This is roughly our pyramid, and it looks very good. But remember, we have 1.4 billion people, right? So there are in lakhs, means for people who are not from India, 100,000. Now you have to remember that if you look at the numbers, right? And I'll show you. So this is our primary health. We keep on changing the names. You know, they also look better, but also certain facets are added. So as of 16th, we had 175,751 functional Ayushman Arogya Mandirs, which include sub-centers, primary health centers, urban primary health centers, Ayush clinics, means non-Western medicine, and other clinics. Now, if you look at this number, and if you say divide 1.4 billion, it appears that there is one center for every 8,000 people, right? So then why do you need to strengthen? But do numbers tell you the story? You imagine the breadth of India, and then you imagine the density, right? So we are churning out 125,000 medical graduates every year. The state where you are, it actually has a better doctor to population ratio than what World Health Organization says. But does that tell you the complete story? There is a need for innovation because you have inequitable access, shortage of medical professionals at the place where they're needed, and you need to address, we are at the junction. So you still have those communicable diseases, and you have whatever you're discussing today in terms of non-communicable also. You have to improve the efficiency, the reach, and the quality of care. And health cannot be outsourced, right? We talk a lot about the private sector, but there are certain things which cannot be outsourced. Now let me tell you about the digital health cycle. It was described by Dr. Ganesh in the morning, but the most important thing here is you have to identify the problem and then take a solution, evaluate it, implement it. And we call it fancy names like implementation research, but most of the ideas suffer from a 20-40 syndrome. Means the decisions are taken at 20 degrees, but they have to be implemented at 40 degrees Celsius, and there it fails, right? So we are trying to go from disease to health, because we just heard that should you treat all, should you treat select, by treating are we not doing harm? Our goal is not just to partition a high risk status for a specific disease, but you say you have a risk, like 10 times risk of developing liver cancer. Do you know when it will come? Do you know when you should be vigilant? And that likely timing actually can save you a lot of resources. So technology is there. There's another talk on AI. So I'm not entering AI. I'm only talking about NI, that is natural intelligence. If the data comes in, you can do medical forecasting, right? So you have to leverage data analytics, real-time data collection. And as we say in information communication technology, if you do not have data, garbage in, garbage out, gold in, gold out. Early detection, and you respond. Sometimes everything is there, but no one discusses the elephant in the room, right? And then, like he said, like for certain things, you have a very limited budget. Your data and not the whims of a particular politician or bureaucrat should determine how the resources are there. Now, what kind of data do you require, right? This is where, obviously, the newer technologies come in. We still see in so many corporate hospitals that the doctor writes a prescription, it is scanned and kept, right? So this is useless as a data, because sometimes it is not even human readable. Another person cannot read the handwriting, and it is not machine readable, not machine understandable. So the first thing is, whenever you're generating data, the best is obviously if it's the form of a chat. I speak with another person, that gets transcribed, voice to text, and then using either short language models or large language models. In fact, we have implemented it, and the demo is available. It develops into a medical record, but remember that the large language models can also hallucinate and has catastrophic forgetting too. But this is a third generation healthcare system. Scanned prescriptions, some chits here and there, some laboratory reports being carried in the pocket of the patient, they do not mean meaningful data. It has to be machine readable and machine understandable. And electronic health records are only part of the story. You need data from the genome of the person, from proteome of the person, metabolome of the person. But now what we understand, and this was aptly represented by Professor Sareen, is the exposome, right? So metabolome has gone, now it's exposome, which measures all the exposures. And remember, it's not the external, it is also my internal, whatever inflammation I'm having. And you talk of any disease, oral disease, cancer, lung disease, CNS, skin, it means physical, biological, chemical, environment, and my humanistic exposure, which includes my socioeconomic milieu, my lifestyle, and my mental status, my psychological state. Obviously, a human brain would not be able to process all this. So technology already has certain solutions. You can look at the big data. You go to any big data conference nowadays, 30 to 40% of the papers are on healthcare. But if you look at yourself as an Indian, what benefit are you getting in terms of prevention or even cure, right? So exposome means a lot of data. Telemedicine and remote patient monitoring, it does not mean a mere video call. A lot of meaningful data has to go there, and then at the point of care, certain parameters should go there, and then you should know what is happening. If you have seen 1,000 patients at a telemedicine center, you should learn your lessons from that. And like hepatitis B or C, it's a chronic disease management. So this is what is required. Blockchain has been there for almost more than 15 years now, and we say it is secure, there is efficient data sharing, you don't need server to server, it can talk, and people are becoming rich by using cryptos and all that. It can enhance privacy also. So there are a number of publications on how blockchain can be used for medical records. The most important thing is if a person is able to say good morning and good evening every day, then that person should communicate their problems either to the healthcare provider or to a system by using chatbots. It can be simple SMS, it can be personalized support, and it can be early intervention, where the patterns tell no. This person can be managed at the point of care, this person needs to travel, or maybe some specialist needs to travel to give it. In the morning, you heard from AIIMS Rishikesh how they are using drones for medical delivery. Some of the Indian pharma companies are also experimenting with drug delivery, vaccine delivery I have already shown. So there are so many apps. Now, if you want improvement in your lifestyle, you have to develop apps which give the data very clearly. You cannot make a person stop smoking saying that if you stop smoking, there is less chance of developing lung cancer. You have to tell them that if you stop smoking, what will happen in the next 7 days, what will happen in 1 month. So it's about the nudge, the positive reinforcement. And the citizens should have accessible information, personalized guidance. Every person is different, and depending on their behavior, and then you can have mass engaging campaigns. You saw how Amitabh Bachchan played a role. So obviously those celebrities do matter, but most of the people nowadays also have wearable devices, right? And most of the public health data today is not published by academic institutions. Apple as an organization is publishing all of it because unknowingly or knowingly you have given your consent, they are looking at it, they are looking at falls, they are looking at steps, blood pressure and all those things. Important thing is personalized insights and proactive care. You can go on recording that this person is lazy. You give a nudge, come on, start walking. What if the person doesn't walk? You have to do something else, right? And here, Health may not be outsourced, but the role of public-private partnerships in driving the technology adoption should be there. And profits cannot lead to this only. You have to mobilize the resources, but they have to be sustainable, right? So you spend a lot of money, you use drones, and then you see that the cost is 10 times. That does not sustain. And obviously, you have to overcome infrastructure and connectivity challenges, especially in rural area, in terms of investing in building robust digital infrastructure. If they do not have a robust internet connectivity, then whatever you do on the cloud, it will not work, right? Connectivity and accessibility. So it's not a question whether everyone should have a smartphone, not required. But the panchayats can at least have a tablet, and you know, suppose you're looking at maternal child health, how many pregnancies usually occur in a period. You can have that many devices, right? Most important thing here is, and you know, Nexus has brought it out, Horari has written it well, that you have to ensure data privacy and security. Though in a study it has been shown that Indians are 10 to 15 times more open to get their health data shared with others, but you need data protection. We also have our own Data Protection Act. There are certain ethical considerations that in the name of surveillance, you cannot do certain things, and you have to be clear about that. And whatever you do, you have to have the user's consent. If they don't understand, you give them the information. And if you have to support all this, machines will be there, right? But what about the human resources? You have to build a skilled workforce, and that doesn't mean you need engineers, right? You need people who are willing to do it, like they volunteered for people during COVID vaccination using CoWIN app. And in India, you know, if we have to copy all the so-called disease care systems in the world, it will not be sustainable. So we have to integrate whatever we have. We look at it at the way we understand it, see if it works or doesn't work before crying foul, calling it pseudoscience, and leverage technology to understand whether it works or not. And whether we accept it or not, here's the data. There is significant regional disparity as far as digital literacy is concerned. So, you know, rural-urban divide, you look at the internet access, you look at the broadband, accessibility, training and support. So someone in a city school has been exposed to it. What happens to the child going to a village school? And you have to have an inclusive design. It has to be human-centric. Just because you have a technology and you bulldoze it, it never works. So this is the ICMR's iDrone initiative. I've just shown it as a case study, delivering TB sputum samples and DOTS medication. 130 hours flight time, 65 healthcare centers connected, and 22,000 medical essentials have been delivered. These are going on for 3 years, but these are still pilot studies. The lessons learned and best practices are humans should be at the center, right? If an engineer thinks that, okay, I have developed this software for the banking industry, I'll make certain changes, change the fields, and I'll use it in healthcare. That never works. Data-driven decision-making. Now, if the data is corrupt, then your decision will also be corrupt. And it is not a static thing that everything is written in stone. You have to iterate and reiterate, and there has to be continuous improvement. You have to align the technology solutions with the UN Sustainable Development Goals like health for all, equity, inclusivity, sustainable development. Obviously, if you are, increasing your carbon credits, you're burning a lot of things and greenhouse gases, then also it's a problem. Now, does the India's public healthcare system support a culture of innovation? During my MBBS days, community medicine department, it was said that those who didn't want to do anything or did not get anything, they went into community medicine. That mindset has to change. We have to realize that public health is most important. It's a ground field for research and development, for knowledge sharing, and to empower our future citizens. And we have to take the government and the bureaucrats together. There should be clear regulations. If you think that something is illegal, then you spell it out. Do not keep gray areas and then suddenly you say no. But if someone is using your apps, is taking whatever you're saying seriously, what is the incentive? Can you give them one extra leave every month or say every quarter if they walk 10,000 steps a day? We have to think about these things. Engaging with local communities to drive user acceptance and trust, right? People might be literate, though most of us today are not, but still they are knowledgeable and they accept it. This has been shown during COVID. So you need community involvement. I've given the picture where you have a digitally literate panchayat in Kerala, right? And there are cultural sensitivities. So you cannot be ethnocentric. You, being brought up in the city, think, oh, this person is not accepting, he or she is an idiot. No. You look at the social values of how they have been brought up. You have to deliver an empathy map, and whatever you do has to be accountable and transparent.
Sorry, can I just ask you to...
Yeah, I'm just wrapping up. This is my last. So, we already have the digital mission ecosystem. Does anyone remember these 2 episodes? Anyone? Boeing 737 MAX. State-of-the-art technology. The technology was such that the pilots could see that the planes were crashing, nosediving. They couldn't do anything. It led to loss of lives, right? So, as I always say, just because you have a technology, you do not fall in love with the solution. You fall in love with the problem, then develop the solution, and I think we will be able to strengthen our public healthcare system. Thank you.
Thank you, Dr. Pranthar, for your excellent presentation. Yeah, please be seated, sir. So as Dr. Pranthar has to leave to catch up with his flight, so if there are any questions specific to his talk, I request audience to come forward. Okay. Thank you. If there are no questions. Thank you. With this, I request, now I invite Dr. Santosh Jacob, who is the Director, Orthopedics and Sports Injury Management from Bevel Hospital, to deliver his talk on social media as a tool to tackle public health challenges. I request him to go ahead and kindly stick on to the timeline. Thank you.
Hi, very good afternoon to all of you. I know I'm sitting amongst a lot of liver doctors, NGOs, and a lot of people who are actually interested in improving the health of the public. So most of you must be wondering, yeah, you have an idea why an orthopedic surgeon and a sports surgeon is standing here in front of you. So Dr. Vivek told me that that I have to help a group of people who are really interested to spread information and awareness about liver disease and teach them as to how we can spread knowledge about hepatitis on social media. So I have a unique characteristic where if you are from Tamil Nadu, there is a very good, or you speak Tamil, there is a very good possibility that you would have either seen me on TV or on social media. So for the last 3 years, I have been spreading information and awareness, not just about orthopedics, but about nutrition, health, wellness, weight loss, and muscle mass in social media. And the one thing which I have identified to be the common trait which each and every person who leads a company or works in a company refuses to follow or accept is to accept that in order to spread awareness about something which actually interests you at some point, you need to be a personal brand. You cannot use your company to spread health awareness as well as you do. And the reasons are here. So again, if you are somebody who speaks Tamil, you know the three people here. The first one is Dr. Paul. The second one is Dr. Arun, who's a pediatrician. And the third one is I. So together, we are from the same state of Tamil Nadu, and we have 10 million followers in the Tamil language amongst us. So all the concepts about how you can spread information on liver disease, hepatitis, are going to come from the concepts I have taken from the three of us. The first rule is people listen to a face, not a logo. So if there are any neurologists here, you know that there is an area of the face known as the fusiform face area, which helps us to recognize instantly by seeing if the person who is saying something to us appears trustworthy or not. We have evolved over thousands of years in order to use a person's face, expressions, and eyes in order to decide if we are going to spend any time listening to them. So if any of you think that you can use a logo or an AI-based software in order to create trust, this generation is not going to trust you. Maybe the generations who have grown up trusting devices or logos might. So how do you make somebody trust a face? So you have to show your authority. So how do you show your authority? So you show your authority by consistently succeeding where others struggle. So one of the reasons you have to pay a little bit of attention to what I say is, on three platforms which are there, YouTube, which is a search engine and a long format, I have around 350K followers. On Instagram, I say Instagram louder because the people who are from 18 to 44 today are on Instagram. So if you are not focusing on Instagram as a platform of social media in order to promote anything what you do, including any awareness that you want to spread, you're making a mistake. Facebook, I have around 654K followers. How it splits is, if you are saying anything on YouTube, people who have a problem search for what you have said. YouTube is a search engine. Then comes Instagram. Instagram is something which people who do not have something to do at that moment go to spend time. So Instagram is a platform where people who do not search for anything for specific, you can gain their attention. So for liver disease, Instagram is perfect for prevention. Then there is Facebook. Facebook is for those who are above 40 to 80. So if you want to reach that age group, Facebook is the game. By the way, I'm 45, so again, with the face, now, you've established your authority, right? The next thing is you have to humanize your expertise. All of us try to fantasize and we say a lot of stories about our successes, but very few of us take time to write down stories about our failures. You have to understand that people do not care about your successes. They care about how horrible you were before you succeeded. Because everybody, when they see a successful person, they put themselves in that person. So every time you talk about stories, well-crafted stories of your failure, right? Well-crafted stories of your failure, automatically you get people to look at your successes, okay? That's extremely important. The third point is, now as doctors or as leaders or as somebody who has authority, right? We do not, it's hard for us to believe that people actually engage with us and talk to us, not because of who we are or what we have achieved, but in spite of that, because they like us, right? So one of the reasons why I feel people who have to get on social media, people who have all the characters which a community will trust, they do not get on it because they feel that nobody actually around them can like them because they have that kind of an authority, and so they have to force people to listen to them. Let me tell you one thing. Social media is so true that even if you are the CEO of a company, even if you are the MD of, even if you are Elon Musk, right? Somebody who works as housekeeping for you can actually make a fake online profile and he can ask you to buzz off. Yeah? So the only way for you to actually understand what the community or the society you're serving thinks of you really is by getting into social media and projecting your face. It's honest. Now, rule 2. It's easier. Why should you show your face and build a brand, especially if you want to spread liver disease? Spread information about liver disease. It's because it's always easier to show people that you can trust one human rather than a business run by a group of them. Let me tell you why, right? The reason is cognitive simplification, right? Cognitive simplification. What is it? It's easier for people to compartmentalize a person who runs a company, saying he has these traits, these traits, these traits. Okay, he is like me, she is like me, I trust this person, so I trust any business or any information or any awareness or any product that this person brings. So in order to do this, it's very simple. You have to choose values you practice every day to consistently showcase. So you showcase your values and craft stories truthfully about your failure. Then, part B of the second one, right? You have to show people why you are your business and why you are in your business. For example, right? Whenever there is a Tesla car which burns up or runs over somebody, Elon Musk explains. Have you ever noticed that? It's easier for people to trust Elon Musk because they have an opinion of whoever he is already in their mind. So they, depending on what he says or how he says it, the matter is either solved or resolved. So establish why you are in your business in order to spread awareness or cut misinformation. Part C. People who are in leadership or who are running organizations forget that the people who want to get to know them the most are the young people who are working for them because they see you as idols, right? They want to be like you and so they are working with you for you. If you are a personal brand on social media and you are being honest about who you are on social media, your team is the one who is greatly benefited because they are very happy that they are working for somebody they want to be like. Rule number 3. This is a little confusing and I am going to be done in exactly 3 minutes, so just pay attention. The currency to spread awareness about hepatitis, you can add this, is attention, right? Attention which is exchanged for information. There, you have to know that it is not necessarily information about the liver. It just has to be accurate information. This transforms into long-term influence. So if any of you want to have the power where you can make a video or a series of videos about hepatitis and be noticed, you have to follow these rules. So how to achieve part 3, right? You have to understand that the objective is to exchange their attention for something meaningful. So you will have to do research about finding what is the problem that the people you are trying to spread awareness to are facing, and you have to solve it. So draw in people by addressing what really matters to them. That's not enough, you know. Like, I became really popular in 2021. Like, I had around 15,000 followers, and I made a long video on broiler chicken, right? On how a lot of information about broiler chicken is wrong. And I got viral. Yes, I got popular. But then I realized that one video is not enough. People will stay. See, they notice you when you solve one problem which they had, or you're solving a few problems which they had. But if you actually want to create true long-term influence, you have to make people stay. And you know, when people stay if what you say is immediately relevant. The word immediately is enough, is important. It has to be immediately relevant and valuable. Now, you've done these two, right? Consistent attention has to be not negative. In the health industry, it's not like the entertainment industry, right? One strike is enough to destroy your reputation. So remember, consistent attention, which is positive and accurate, positive and accurate, positive and accurate, only transforms into long-term influence. See, the rules are the same, whether it is talking about technology, talking about health, talking about nutrition, hepatitis, liver failure, any surgery. Depends on, you've decided whether to listen or to trust or read up as soon as you saw the person standing there. Human beings are that simple. And when it comes to social media, all you can see are micro expressions on a person's face. And we've all been taught that micro expressions are the truest way to identify a person, identify whether a person is really trustworthy or not, right? So I would like to end by saying you have to collaborate and network, which is a moot point because that's what we are all here doing. My final point is you have to remember that everybody says authenticity, authenticity, authenticity. What is authenticity? Authenticity is something which attracts attention, right? So I don't see that you can say that authenticity has A, B, C, D, E, F, G, H. No, no, no. So you can actually see authentic people, right? You can see authentic people because they attract attention, not because they are perfect at all. I've seen authentic people have the greatest faults anybody could ever have. But you know, one common characteristic I've seen, they're pretty persistent. They make perfect meaningless by being persistent. Because people don't want to see perfect people, right? Anybody who's struggling with social media doesn't want to see a perfect person get 3 million followers. No, 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 no. They want to see somebody with faults, somebody who's as screwed up as them, get 3 million followers. So just remember, authenticity attracts attention because you guys want to spread awareness, because people do not want to see perfect leaders. They want to see persistent ones with real, relatable faults. And they also want to see them struggle and succeed. Thank you very much. I hope this has been useful, and I hope you guys understand that you guys trying to spread information through logos, right, is not going to work on human beings. All right. Thanks a lot.
Thank you so much valuable information there. So thank you for taking the time today to share it with us. I think all of it resonated with me, but I think the bit about being immediately relevant is so important, because I think a lot of times in public health and health promotion, we tell people what we think they need to know, you know what I mean? And then when we tell them that and they don't change their behavior, we're like, well, what's wrong with them? Do you know what I mean? It's their problem, while we're not understanding what's important to them and framing the message and what's important to them, whether that be family, whether that be long-term health, whether that be prosperity. So it's so important to have that immediate relevance. So thank you so much for bringing that out. Yes. Yes.
Yeah, Santosh, brilliant. Thank you very much. This is one question. Of course, I know you finished off saying, no, don't do the logo, i.e., logo is not going to give you anything. But the organizations like World Hepatitis Alliance, the members of WHO are here, and lots of NGOs are here, with multiple faces, right? So Carrie is the chief executive of the World Hepatitis Alliance.
Who's
right?
the best looking one?
All right. Okay.
Hey man, human beings are visual creatures, right? Stop trying to change the rules, man. We will all look at Deepika Padukone, right? Not at like the director of the movie. So if you're choosing a face, it has to be good looking also.
No, when I say choose, so you're suggesting that the alliance just uses one face all the time for all their promotions? Is that what you're saying?
Consistently, a few faces at least.
Right.
And you have to do research on whether those faces appear trustworthy to the population or not, because depending upon the age group, the trustworthiness changes. 15 to 25-year-olds trust different colors, different faces. 25 to 40 is different. 40 to 60 is different. What I'm saying is, it's way easier than liver surgery, right? But it's not as easy as cooking a meal. Somehow it's got lost somewhere that it's pretty easy. No. The amount of research which goes into it is very, very high. That's why, like, I am a nobody, right? I am a doctor with a post-graduation with 2 decades of experience who can just speak a few languages, 3 of them really well. I have 5 times as much followers as a hospital which has like 60,000 investment in it. You have to understand, logos will always lose to faces.
Thank you. Thanks.
Welcome.
Santosh.
Welcome.
Great. Thank you very much. Well, since we're doing questions, please.
Yeah. So it's a slightly extension of the first person's questions. So what we are trying to understand is the same person's face could be used for multiple issues. Is that fine?
So see, so if you are an organization, right, you represent something, yeah? So there has to be a person who actually believes in what the organization represents, right, who also likes to talk, who has to be inherently a part of the organization. You can't just get a random actor who doesn't really believe in the organization to come and to do it. But the point here is, instead of confusing the audience who watch by having just no relation, at least have a uniform, at least have a cap, have a face where there is some uniformity, that people know that, okay, if it is from this color or it is like this is the company which is speaking and these are the faces. They have to be able to associate a face with past experiences of whether when they have listened to that face, have they been benefited or not. That's the primary reason why anybody would listen to doctors, because medicine is one of the most boring things on earth, right? We do it because we love it. I do it because I love it crazily, right? But it's not the same for others. We always think it's so damn important for me. Why the hell don't they understand it? Yeah, because you're an idiot, man. You like crazy things, right? You like putting arthroscopies inside. You're excited when the meniscus heals. Nobody cares. You have to know I have to know what you want. If I don't know that, my brain is of no value to anybody. Not to me also. So it's just that you have to understand that the reason why somebody has achieved so much on social media is because they're putting in a lot of hard work and science based on it. It's just that I want all of you to know that it's possible for you, being a full-time, I work 14 hours a day, right? And yet I provide information for 3 million people in Tamil every month. I make reels every day. I make YouTube videos, 4 videos every week. And I have a team. You guys have to know, If you've been doing it for 3 years, after that it becomes very, 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 very easy compared to what it was for you 4 years ago. But it's still much harder for the others who are just starting. So start now. Because otherwise what will happen, let me tell you, there's going to be a young 30-year-old liver surgeon who comes and takes all your practice away. There is going to be a young 30-year-old CEO who comes and takes all your business away. I am training a few of them already. What are you guys doing? Watch out.
Thank you.
Great, thank you very much. Well, all right, one more, and then we really need to move on.
Okay, there were 3 sequenced things you said: YouTube, Facebook, Instagram, and Facebook.
Yes, sir.
Now, my question is, I mean, to save time, should the Liver Foundation select successful YouTube providers like you and feed you with the correct information so that you can, the YouTube people can share the information to a wider audience than otherwise?
Yeah, so that works, but then the words of Seneca come to my mind, right? The teacher of Emperor Nero. He said, whatever is alien to time and blood is never really yours in the first place. So all of you who are actually trying to take, instead of becoming the person who is trustworthy, if you're trying to take help of those who have established trust, then yeah, you can do it. It's advantageous for guys like us, but I'm trying to tell you to do it the other way around. That's my point. Because unless you establish trust, you'll always be dependent on somebody. You'll always be dependent on somebody. I was not planning to say this line, but I am going to say this. Social media is a language. Children who are born now are being taught that at 1 or 2 or 3, and they're learning to communicate, they're learning to trust, they're learning to learn, and they're learning to absorb from social media. We do not understand that social media is a language. We do not understand the alphabets, we do not understand the words, we do not understand what is happening. Figure it out. Figure it out, otherwise one day, trust me, somebody will find a way to take it all away.
Great. Thank you very much. This is a great thing to end on, so thank you. Thank you so much. So our final speaker today, we'll welcome back to the podium Dr. Ganesh Kumar from ICMR, the National Institute of Epidemiology. He's going to talk about professional development through learning management systems.
Thanks, Chas. As I said, that it is a continuation of how to communicate individuals, and I'm going to talk about that, like related to any public health program, how you are going to skill your workforce, that too at a scale. The previous 2 speakers mentioned about that the technology usage for a larger scale, be it in terms of communication. Now, what I am going to talk about is that in a structured program wise, how we are going to transfer the skill, more than a training, transfer the skill at a scale for that. We all know these are the 6 important pillars of the WHO health system pillars. One of the important pillar is the health workforce. And what we are trying to do in any kind of like a program is that this particular health workforce is going to govern, this health workforce is going to provide the delivery of health services, and this particular health workforce is going to manage your work program. And of this particular health workforce is going to decide to increase the coverage and access, increase the quality of the delivery of that particular program for an effective program delivery to achieve its goals. But fundamentally, how we are training this particular health workforce so that they have sufficient skills to do these kind of activities into a structured umbrella called a program. Okay. When I reviewed the public health action to eliminate viral hepatitis as a well thought through the 10 important actions and 5 important pillars of that, the 2 important strategic direction, which is to deliver high quality evidence based people centric services and as well as optimizing systems, all depends upon one important part, which is capacity building as a crucial to deliver this high quality and optimizing the systems. The main question lies is that how we are going to do that and where we are actually standing. Training for skilling. We always imagine such a kind of a trainer for all of us and in our program who is going to improvise the skill of our health workforce to do that, be it in terms of a program manager or an epidemiologist or a kind of like a health workforce as a nurses. But we can't do this for a scale. We can't do this for each and everyone, and that is not going to be possible to do that. This is the scale of the health workforce in India where we are. We have 1.3 million doctors. We have 2.1 million nurses who are registered in India. When we wanted to train this number of scale of individuals, then our traditional synchronous learning, which is classroom training, may not be sufficient. There's two important challenges. One is that you need to have high quality trainers with such much numbers to do the training of that. When we are going to bet upon high quality training, which is not going to be possible for that. It's very difficult to increase the trainers, that to high quality trainers. We can't just design a program and say that after 1 week they will become on high quality trainers. It is superbly impossible. Whereas we can pick some kind of like a high quality trainers where we need to use different medium to reach out this particular scale. How to do that? I take the examples from the educational industry where this health tech is somehow majorly influenced. I don't want to name the two industries, that's why I blurred it. The one is for school education, where you could see there are nearly 10 crore downloads in the Android Play Store, which I am trying to understand 50% of them are active users. That particular platform has disrupted the education industry, school education industry, where they brought in high quality trainers with high quality training materials and used the mobile based platform. I wanted to clearly say this. The second platform is mainly used, which is at the below, again I blurred it purposefully, it is used for the medical postgraduate entrance examination called NEET examination, National Eligibility Entrance Test. And you could see there are nearly 10 lakh downloads. These are all trained doctors who are downloading it, where they are going to that particular platform to get trained for the postgraduate entrance training, okay, postgraduate entrance test training. This is the kind of market, or this is the kind of usage, which is, when I say market, it is pertaining to usage. Now, are we developing the same way in our public health skilling? We need to question us. Definitely not, we know that. The main question when I am trying to say is that how we are going to scale this particular training. The answer what we are getting from the elsewhere industry where it is successfully happening is that they are using e-learning platforms. They are using mobile-based training. When I say mobile-based training, I wanted to throw one important figure. The total number of computers sold in the past 1 year in India is 5 million. The total number of mobile phones sold in India is 162 million in India in the past 1 year. You see this number. We are working hard to generate or to create platforms for learning on computer or mobile platform. We need to think about it. The previous two examples which I mentioned are predominantly mobile-based platform learning tool, operates fantastically on your mobile phone. You all know Spotify, you all know Netflix. The maximum number of usage of Netflix, which is movie watching, happens on your mobile phone. The maximum amount of watching. This is the statistics which have been releasing. Spotify, it's an audio, fine, but I'm just talking about that. The current generation, when I say the current generation, means the generation which are productive, active, and as well as trying to make some amount of change in your day-to-day program are all mobile users. Now, we need to really move into that. We need to optimize all our training, quality training on a mobile platform. This is one important thing we all need to understand, which is not been happening. And that's why this particular word called self-learning, multiple times questions have been raised again and again that self-learning is not a best way of learning. It's all classroom training, and in-person training matters a lot, but you can't scale it. That's one important problem. You can't scale it. The scale which you wanted to see, which we wanted to achieve, is very, very high. You can't do classroom training, and that too good quality. That's why we wanted to get into an asynchronous learning. And the main advantages means the learners are at their convenience, it's flexible, and it is some blending can happen with a kind of forum interaction, but it is more personalized learning because they have their own decision in order to switch over whatever they wanted to learn across that particular platform, like how Netflix works. Okay, right. This is one thing which I often quote an example in terms of like an online learning. This is a movie snapshot from a movie called Three Idiots, where the two actors, one actor is a trained doctor, will try to educate the other actor who is a lay person how to deliver a baby, that to an assisted delivery. They use an YouTube, they use a web camera to do that. I am trying to see this, that can the real world skilling can happen on this or not. To be very frank, I go through those educational videos for school education and as well as that particular professional education. It is already there, and they were demonstrating it, and it is also seamless. When I interact with one of my dental friend, when I keep on asking that particular question, can we able to do some kind of like an skilling through one kind of online? For example, be in terms of extraction or be in terms of like an alignment, where aligners are becoming popular, and they were saying majority of them are only online, it is asynchronous. When I search the evidence, whether we do have sufficient evidence, the effectiveness of the e-learning program for capacity building of healthcare professionals, this systematic review came published in 2024, and I see that it is highly effective, which is asynchronous e-learning, which is self-learning. But what we lack is that we don't have sufficient research or sufficient understanding of that particular learner who is our end user. We need to talk to them, we need to understand them, what platform they are using, do they have internet, or there is the possibility they can make these courses downloadable and make it offline. Whenever there is no internet, they can watch it. We need to think about all those things, which is not at all happening. We need to get into the direction. Technology per se, I always try to simplify that in technology should be a solution for a problem, that too simpler. So I end with this particular slide, that this particular platform which we've been launched along with Chennai Labour Foundation, ICMR, NIE, we're trying to adopt some of the first principles, that it should be mobile based, it should be seamless, and as well as it can be downloaded, so they could learn the materials and the concepts on epidemiology, management, follow-up, prevention, and as well as the prevention of hepatocellular carcinoma, all those things to be brought into that. We are trying to achieve the scale to train 10,000 healthcare professionals in the forthcoming years. Thank you very much.
Thank you so much. So questions, comments, please.
Sir, along with the learning management systems available, even in ICMR NIE, they have introduced ACASI and CAPACI kind of methods for qualitative researchers, or to get to even add up to the existing LMS modules. So will it work if it was attached along with the LMS, to get the feedback of that particular LMS rather than, because HIV and hepatitis is the area where stigma and discrimination is attached to it. We can address those issues by using the advanced technologies. They can help it in either way. So what is your comment on that?
Do you like cooking?
Yes.
If you want to know how to cook a dish, where will you refer? YouTube. Okay? We learn the recipe, the method, how we do through YouTubes. Why I am trying to take this particular example here is that qualitative research or any kind of tools which we wanted to learn can be very well taught through this kind of asynchronous e-learning platforms. We tried to do that with the existing government-owned platforms. In a way, it has found to be very successful. One of our popular example is that basic course on biomedical research from ICMR National Institute of Epidemiology. We have reached more than, I think, nearly 5 lakh, that comes around 0.5 million researchers in this country. So my stake is that, like, we need to really move into this particular platform. Whatever the kind of skilling which we wanted to do, the question is that can we do it at scale or not? Sorry if I answered your question correctly.
Okay.
Thank you.
I think the presentation, taking both the first one and this one together, I mean, your focus has been greatly on the professional side. And will the same technology, what you're saying, work at the community level where many people are, especially at this point in time, do not have all the access to or the capability of managing this type of thing?
Thanks for that question, sir. I travel for our work with into the villages. Marakanam is one particular village which is in Viluppuram district, which is in the coastal part of Tamil Nadu. I visited the Anganwadi center and I asked her that, how will you treat a severe acute malnutrition child and how will you assess it? I asked that Anganwadi worker. Then Anganwadi worker has this WhatsApp group among themselves. She has one video, she picked that particular video which is available offline. Despite in Marakanam, it's very well internet connectivity is available. Nearly the internet connectivity is more than 65% in our country. She made that available and she told that I refer this particular video into it. So the accessibility part of it is almost we have been addressed. Ideally speaking, technology is going more empowerment towards a healthcare worker to do this particular accessibility. So I don't see that as an hurdle for that. Currently we are having a very good smartphone which is working very well. Maybe around, say, like it cost, say, $100 or 10,000 rupees in Indian rupees. It's much cheaper. It's 5G connect mobile phones, smartphones are available much cheaper in India. And among the entire world, data is much cheaper in India only. So we get unlimited 5G connectivity across in India when you are going to pay 300 rupees per month, which is less than $4 per month. Yes.
Wow, that's really good. So I think we're come to the end of our time, but I would like to invite everyone to come by the World Hepatitis Alliance stand in the lunchroom where we have information about our Community Impact Program, which is an e-learning program specifically designed for civil society organizations. And it includes not only modules about hepatitis, but also other related health conditions like liver cancer, but also there's modules on communication skills. How can we communicate our messages better? How can we generate the change in behavior that we really want? So we're just next door. We also have information about hepatitis and liver cancer and how we can leverage liver cancer and the cancer movement for hepatitis, and also around integration with HIV. So please do come and see us. But now I'll just pass over to my co-chair to close the session.
We have come to the end of this session, and my sincere thanks and appreciations to all the dynamic presenters here for sharing their knowledge and experience with all the audience. And let's conclude this session, and we're back to the organizers to take it forward. Thank you.
Thank you so much. That was actually a very, very interesting session. I think 2 of our presenters have left, but we'll still give them all a big round of applause, a lot of audience interaction. And I'm guessing everybody will be on Instagram immediately after all of that encouragement. I'd like to request our chairs to do the honors and present Dr. Ganesh Kumar Parasuraman with a token of our appreciation. If you would please do the honors. And I request Dr. Ganesh to do the honors and present our chairs with a token of our appreciation. Thank you so much, and thank you to our wonderful audience. We'll take a quick lunch break of a half an hour, and we'll see everybody back here at 3 p.m. Thank you so much. Ladies and gentlemen, we're all set to begin with our next session, requesting everyone to kindly enter the main hall, settle down, take your seats and make yourselves comfortable as we are starting in the next few minutes. Thank you so much.
Easier, yeah.
Welcome back, ladies and gentlemen. I hope that everybody's phones are on silent mode. We'll dive right into our panel discussion. I'd like to call on stage our moderator, Dr. Rakesh Agarwal, former director, JIPMA. He chairs WHO's Southeast Asia region's Immunization Technical Advisory Group, and he will be moderating this panel discussion. I'd like to invite our panelists, Dr. Bibi Rewari, Dr. Polin Chan, Ms. Rachel Halford, Dr. John Ward, Dr. Reshu Agarwal, and Mr. Giten Kwaraikpam.
Good afternoon, everyone. Welcome to this panel discussion on India's path to hepatitis elimination, challenges and future directions. May I have my slides, please? We are still with, yeah, there is Giten, who's missing. Pauline, she'll join us, don't worry. So let's get started. So let me, you already know all the panelists, so that's one job less for me. And we have tried to structure the panel discussion. We'll go for about 30 minutes. In between, we'll have some stops where we would interact with the audience, and then at the end, we will have time for interaction with the audience for your questions. So let's start with if our aim really is, let me go back, for hepatitis elimination, first we need to understand the disease burden, what is already being done, what are the challenges, and how do we deal with those. So let's start with the burden. So Dr. Rewari, what is the burden of viral hepatitis in India? I know we've talked about it in the last 2 days, but I think it will be useful to hear about it from you now again before we go on to the path to elimination.
Thank you, organizers, and Dr. Rakesh Agarwal. Can we have the next slide, please? So, India is in seroprevalence of hepatitis B in India is 0.85%. That places in the low epidemic. And seroprevalence of HCV is 0.29%. But having said that, it is a national average. If we talk about hepatitis B and C both, there are at least 10 states which are above this prevalence, average prevalence of 0.85 and 0.29. And if we talk of hepatitis C in particular, We know that it has a problem of people injecting drug users. So there are big numbers, 1.6% prevalence in Mizoram, Punjab, we know. But what was surprising, and I mentioned it yesterday, Haryana has got the third highest prevalence and it doesn't have much of injecting drug use. So it is attributable more to unsafe injection. A thing which we have been saying that it is not a problem. Now we have 95% safe injection, but the actual practice in rural India is not like that. We need to keep that in mind when we talk of the prevalence. When we talk of certain high-risk groups, and you can see on the screen, the prevalence of hepatitis B is quite high among MSM, long-distance truckers, single male migrants, prison inmates, going to 1.89%. And not very surprising, most people will know it, that people who injecting drug have got 33% prevalence, but in some of the states, it is even 50% to 60%. Also, the prevalence is higher in MSM, long-distance truckers, and prison inmates. This is one area where the reach is difficult, and reaching out to people and interventions are also difficult. Estimated, we have almost 3 crore people with hepatitis B and 5.5, that is 55 lakh with HVC. That is the data from Global Hepatitis Report. But I am told that some efforts have been started by Viral Hepatitis Control Program to have the actual burden. Thank you.
So, knowing the burden, let's try to see what is already being done, what has been done, and where we are. And I'll request Dr. Reshu Agarwal to update us about what is the current status.
Yeah, thanks, Dr. Rakesh. Basically, as we all know, that the National Viral Hepatitis Control Program was actually launched in 2018 with very clear goal and with very clear objectives. I can move to the next slide. And the way this program is designed, that it's not a vertical program, it's totally integrated into the National Health Mission. It works under the overall umbrella of National Health Mission. And it really focuses on prevention, diagnosis, management, and capacity building. At the same time, this program really leverages the existing health programs very well. So it really works in very close collaboration with RMNCH program, which is really a key stakeholder if we talk about the hepatitis elimination. So anyways, program cannot work, especially the vertical transmission piece and also the immunization piece. So those two pieces are very critical for HBV elimination, and that's where program is really closely working with these two programs. The other piece is around the National AIDS Control Program. So we all know that the National AIDS Control Program in India is quite robust. It's a very strong response, working for last 25 years in the country. So program is really optimizing the existence of the National AIDS Control Program, especially for the prevention aspects and HCV. So there are targeted intervention sites under the National AIDS Control Program, which work very closely with the key populations, the FSWs, MSMs, PWIDs, and so that's where program has really made very good cross linkages in terms of bilateral screening as well as linkages to the treatment if people need treatment either for hepatitis or for HIV. So there are these kind of bilateral linkages which are available. Currently, in fact, I would want to mention that with National AIDS Control Program, 2 very big campaigns were launched. One was the integrated health camps for screening for HIV, hepatitis, syphilis, and TB among the key populations, and this drive was especially done in the northeastern states in a camp approach. The other piece was the ISHT campaign, which also meant integrated screening for HIV, hepatitis, TB, and syphilis in the closed and prison setting. So those 2 pieces were really great examples where both the program and the machinery came together to really work on the closed settings. The other piece is around the blood safety, and so there is a program in the ministry on the safe blood. So, and this used to be part of the NACP earlier, but now it's a separate program. So program is really closely working on this piece also. And then on the surveillance piece, I have a specific slide, but on the surveillance piece also, it is utilizing the existing structure. The way this program is actually framed is they have the national level structures, they have state level structures, but what I want to mention on this slide is the penetration of the program at the grassroots level. So at the lower level, you see because it is embedded into the NHM. So that's where I think the National Viral Hepatitis Program has the privilege of really getting into the roots, especially at the peripheral level or the ground level, at some center level, primary health care center level, and the health and wellness center or the Ayushman Mandirs. So in terms of the progress which has been made so far, and this has been discussed by Dr. Dhiman yesterday, so there are like 978 treatment centers right now, which includes the model treatment centers as well as the treatment centers. And these are widespread across the 711 districts. So there is a good coverage of the treatment across the country. In terms of training, around 4,900 master trainers have been trained, and the expectation is that these people would go down and, because the program also works on the cascade models for the training, so the expectation is that these people would go down and train the workforce in the periphery as well. In terms of the testing, almost 91.5 million tests for HBV and HCV have been performed, and around 300,000 patients are receiving treatment. This is data as on December 23 published in the annual report. Also, I just want to talk about the birth dose coverage. So I think the overall coverage for the HBV vaccination is around 93%, but when it comes to the birth dose, there are some gaps there, and this data is again old data which is like available with the Southeast Asia estimates. So as per that data, 63% is the reported coverage. I know there are some reporting issues, and there are like, especially with the private sector piece, which we discussed yesterday. So those are the pieces we really need to like fine-tune when we really discuss further. So this, I think I've already discussed that how the program is really utilizing the existing systems which are available, the existing infrastructure which is available. So program has really taken a very sustainable approach, and if you see the overall, the cost which is required to run this program is comparatively very low as compared to some of the other national health programs. So that's where I think when we talk about, because usually with other national health programs, we talk about the sustainability issues, and when these programs are vertical, that how long will these programs run in the vertical modality, who will fund them, how will the funds be coming. So the way this program has been designed is like, it's really a very sustainable way, a very integrated approach. I know it's an unfinished agenda. There is lots to be done.
I'll cut you short here because we have many other, a lot of ground to cover, so I'll stop here. So there is a program. The program is expanding. It has depth in terms of the fact that it reaches to the peripheral level, and we have some positive things. So so there is also a surveillance program where, let me say that there is a exercise on for estimation of burden, incidence and mortality, and a survey of HBV prevalence in under 5s, because that's what's going to decide some policies, so that's also underway. So with that, so let me go to Dr. Riwari. So Dr. Riwari, knowing the burden that you told us and where we are already, what do you think are the particular challenges of hepatitis elimination in India?
The program was launched in 2018 for C and 2019 for B, and came in COVID. So we had some issues in rollout of the program, but 35 million people with B and C and 300,000 on treatment is not acceptable. Efforts are being made to scale it up significantly. People have been trained, facilities have been upgraded to 800 facilities, but we still have challenges. We have limited availability of data for advocacy, program action. We also have limited funding, though government has committed any amount of funding that is required for program will be made available. Moving to another challenge is basically majority of people living with hepatitis are not aware. There is very poor awareness in the public, even among healthcare providers, and that is a challenge. Birth dose coverage we have just seen, it is 56%, which is not acceptable. I will not say suboptimal, I say it's inadequate. So we really need to scale up birth dose coverage if we are really wanting to prevent new infections and prevent the transmission. Community engagement, which has been a pillar of our HIV program in the country, is very limited. We have some community organization here, but their advocacy and the momentum which was gained in the HIV program is not seen even now. And of course, the challenge remains in terms of scaling up. We need to scale up fast, and for scaling up fast and increasing coverage, I would say immediately there is a need to update the guidelines. That is a challenge.
Let me act as a devil's advocate and say that 2018 we start program for one virus, 2019 against the other,
and then 2020 to 2022 go in COVID. Do you think that has been a major dampener, and has there been a progress after COVID pandemic finished?
Yes, that was a challenge because there were some issues with the supply chain also at that time, availability. And also this was a decentralized program, unlike HIV program, where states were given the responsibility of procurement, supply chain, even the sample transportation for DNA RNA testing.
And the same staff was busy with COVID everywhere,
So
including immunization.
That was a
So-
big challenge, but I see that there is a momentum after that, definitely.
Okay, so Giten, now I think let me leave these two people who are here working in India. You are not in India, but I know that you have links in India and you've been working in some parts of India, especially the Northeast, particularly in special populations. Do you think there are some additional challenges that Dr. Riwari has not mentioned?
I think Dr. Riwari has more or less covered the challenges. I think some of these points are interrelated. I would just like to link those a little bit here. One of the things that's not mentioned here is the geographical and the topography of India. Although there are 978 centers, maybe those are not enough and located in areas where it's easier for patients to walk in and to get it done.
Yeah.
The other part, along with...
This is what you are referring to?
Correct.
Yeah, okay.
So the other part that is linked to that is the community engagement. We always talk about integration, we always talk about synergies with other programs, but you have a very 22 decades old HIV program which is well grounded. The viral hepatitis program also has community components. So the opportunity to tap the HIV program to set out activities which are under the national program, I think that's a challenge. It's more of a policy and a coordination challenge at the Ministry of Health and Family Welfare level. So that is one of the things that needs to be sorted. Another thing is, in Dr. Reshu's slide, is that structure of management. So you have the central structure, you have the state structure. Now, we also talk about limited funding. There is a steering committee there, both at the state and at the central level. These, according to my understanding, reading the documents from the program, is to provide programmatic and also financial allocation related guidances to the program, both at the center and the state. You're having limited awareness. Who is advising where investments is supposed to go in at the ground level, at the treatment, where is it? So interaction by the community or by other groups, stakeholders, with those management units, I think to me is a challenge. And I have not seen, neither from the center or from the state, any document or any minutes of a discussion that had happened. So overall, I think it's all interlinked onto one another. And if we are to challenge these challenges and make improvements on this, then we would have to again make sure that some of this are clubbed together and then addressed. Also, the data challenge is very much there. I'm sure Pauline is aware. Indonesia, Thailand. Indonesia has a very open dashboard. We know exactly where the cascade is. They update it regularly on a monthly basis. So we can see that going on, what's happening in Indonesia and where are people missing. That data challenge, both at the center and at the state level, that continues to exist here. Thank you.
Okay, thank you, Giten. So you primarily mentioned the number of clinics is possibly too few for the size of the country per unit population. You also refer to community engagement, you refer to funding, and you refer to lack of data. So let's go now to Pauline. Pauline, you are in the regional office. You look after 11 countries in the region. What are your thoughts to hepatitis elimination in India as compared to the other countries in the region?
I think India does have the similar kind of challenges, but just at a very, very big scale compared to other smaller countries. I mean, in the Southeast Asia region, it's 1.4 billion people, and our smallest one is few 100,000 people. That's in Maldives and Sri Lanka. But I want to follow up on some thoughts on really the challenges of elimination here in India. There is a balance between the vertical programming that is driven by vertical programs, national programs, which is needed because in such a big country, you need dedicated, focused expertise in trying to drive a national hepatitis program or national immunization program. But there's also the balance on the horizontality of service delivery and bringing at state level and sub-state level on trying to use the existing programs, the hypertension program, diabetes, the NCD, the cancer programs, TB program at the state level. They all have roles in hepatitis delivery, at least even in screening out. Because at the end, it is about that one lifetime screen out for a person wherever they live. And it is better than a lifetime of treatment. And the other thing is Hep C as an elimination, a cure. It is possible in India, but why are we not getting there? The government is willing to do it. The drugs are there, the test kits are there, they're willing to do it. But we are just not testing or reaching enough. And we need to bring in innovations such as the hepatitis C self-testing. Or as Kon Manipur has shown, it is possible
We'll come to
vaccinate.
solutions later. Let's just talk about the problems right now.
Okay.
Yeah.
But what I would say, there are two things that India can move forward very quickly. And that's the challenge is, the first thing is triple elimination. It's about coordination. Coordination at the state level. West Bengal is a typical where the government has championed coordination to get it done. West Bengal is the leading state for triple elimination. But we need to do it at other states. We need to do it at the national so that all the programs are talking the same and moving the same direction as triple elimination. This is about mother and child. It's not political. It's the well-being of mother and child. The next is where the states can is try to get on the elimination agenda for B and C because it's also doable. Karnataka, Andhra, southern states, Gujarat, West Bengal, why not? The health systems are really good. India is heterogeneous and the capacity are available in many, many states. Lastly, I want to talk about the challenges of, sometimes we talk about lingo, we talk about integration, and no, our programs cannot integrate. No, we are not asking programs to integrate. We're not asking national programs to integrate. We're asking them to converge. We're asking them to deliver integrated services. That means giving them a value-added package of service. If you screen for syphilis, why not HIV? Why not B? Why not C? If you're testing TB patients because they're going to take hepatotoxic drugs, why don't you screen out hepatitis B and C? If they're diabetes, hypertension, they're 40 years and above, they have never had a hepatitis B vaccine before. They probably receive unsafe injections somewhere in the rural areas. Why not screen them out for B and C? These are very, as someone said, recalibration of the patient flow. It just is about rethinking and redesigning, not more.
Okay, we'll move on.
Thank you.
So now it's to you, ladies and gentlemen. Any one of you wishes to add, but newer points. We don't want the same points repeated, and let's try and keep it short.
Actually, the biggest challenge is there is no separate public health component for hepatitis program so far. And of course, we can leverage the services as far as screening is concerned. But for the treatment aspect, we cannot leverage the services from other programs like National AIDS Control Program, or because we don't have a follow-up setup, we couldn't be able to track the cases. These are all the areas where we are lagging.
Perfectly
as well
fine.
as we are not involving the civil society organizations exclusively for National Viral Hepatitis Program. Thank you.
Thank you. Yeah.
So do we have any idea about the ongoing transmission rates in the community, and specifically from non-medical facilities like barber shops, etc.?
we are right now looking at elimination. Yes, there is need for data. Very specific data would be very difficult. I can tell you that that kind of data would not be available for most countries in the world. If you say barber shops and what is the rate of transmission, that's going to be extremely difficult. Any other issues? Yes, sir.
Thank you, sir. Sir, we are listing out the challenges at various levels. I think there are specific ways of strategies in HIV programs and TB programs, like through an operation research. They're identifying solutions for each and every challenges that the program implementation facing. I think such component should be given importance. That's my first observation. Second is, do we think reinfection is a challenge? Are we ready to address that also? Thank you, sir.
Thank you. Yes, ma'am.
Testing increasing actually for HIV positive people are in 17 lakhs are taking ART medications. So how many people are actually healthcare workers? You are preventing them. You are saying them this much of number of people are infected. So in front of us, there is a number of people are there. So we are not actually, how many in West Bengal vaccinated, how many in Jharkhand vaccinated, how many people are actually tested before vaccinated. So these things are actually for not come up.
You need better data.
Yeah,
that's
better
what
data.
Dr. Giten said.
Yes, yeah.
Yes, ma'am.
Yeah, so very quick point is with regard to the national program. It is good that we have under NVSCP the mentioning of key populations. The guidelines talk about reaching out to the key population, but one submission I would like to make that as compared to HIV program, which is, we know that very well established program, in NVSCP, we need to say it to our states, we need to guide them, we need to do the capacity building, how to do it. Because just mentioning will not lead to the change. I think we need to work on it, and I think that is the way, forward. That's what it was.
So I think one thing that is coming across, and that's what Dr. Reshu tried to say. At the top, there are vertical programs, but they all deliver through the same horizontal process. We cannot expect the vertical programs, each of us, to be reached at the peripheral level by 10 different programs. We have multiple diseases, we have tuberculosis, we have filariasis, we have leprosy. So all those programs are there, but they cannot each individually reach. So if NACO is reaching those key populations, then they'll have to do the peripheral part of it. So let's go. Sorry?
It's about the person-centered.
Yeah, the care will have to be person-centered, and then everything has to, assimilate again. That's possibly not happening, and we need to do that. So, having heard from India and this area.
I have one question. Yeah.
Sir.
Yeah, as we have narrated that challenges behind this elimination. So, how will you address because as data is not up to the mark, surveillance to be enhanced. So, if any state government is notification has been done for reporting of hepatitis, so I have seen that private institutions, because majority of the patients are also in the tertiary care hospital, including private institutions. In spite of notification by the state government, additional chief secretary, health, like that, if it is notifiable disease, then why private institutions or corporate hospitals who are responsible for treatment of Hep C, Hep B, but they don't report. So in the policy, some punishment or a law should be fixed for those institutions who have not reported, in spite of government has told to report it.
These are difficult.
Because a global target of NTP was what? 2030. Still NTP to be done by 2025. NTP Ministry of Health has been doing a lot of exercise. For malaria elimination, target is 2030. Sri Lanka has achieved that goal. But, so efforts are being made, but there is a lack of commitment from private institutions also. Take example of Rajasthan, Tripura. This is notifiable disease. But line listing of the patients from institutions, they are not providing. They say that no, I have not seen the notification.
Sir, I'll stop you here. You made your point.
So
that
challenges you have emphasized
that reporting
on
does not occur.
challenges.
Reporting does not occur, right?
So
That's
from
it.
private institutions, it's also
Fine. No,
happening.
that's okay. We can say this in one
Because
sentence.
government
and stop there,
institutions,
yeah.
you cannot say the lack of commitment. This framework has been well developed by the Ministry of Health. Okay. Now, there is a gap. Okay, we need to strengthen the government system.
Sir, we'll come to solutions. We'll come to solutions. Yeah. Sir, last one, because otherwise, the clock here shows that we are already 27 minutes into the discussion out of 60.
Data can be collected, but we find the biggest challenge is the availability of vaccine itself. There have been news articles, and again, private sector is almost hungry for it. We don't get it.
Yeah. So, John, having heard from people within the region, let me go to people who have more international lookout. How do you see these challenges as compared to other parts of the world? We'll come to the solutions separately, but let's first look at the challenges.
These are common challenges. These are the challenges faced in every country I'm familiar with that's seeking to advance progress toward elimination. I know we brought it up several times already, but this issue of good data is a big issue around the world. Number one, because of the long latency period, you really have surveillance challenges to identify acute infections, particularly for hepatitis C, where you don't even have a marker for acute infections. Oftentimes mortality is not ascribed to the cause of that liver cirrhosis or liver cancer, et cetera. And then most countries are really challenged to track the number of people being tested and treated. Vaccine coverage is probably the most reliable data out there, but it has some issues, as all public health surveillance does. But really looking hard at ways of improving data by looking at existing systems, like what other surveys for HIV or other conditions are going on, whereby you could use those specimens for hepatitis B and hepatitis C testing to get a better idea from a survey with good methods is clearly there. The other area to look at is standard practice that benefits multiple, just good medicine. Looking at your blood banking to make sure that you're following all the recommendations. Transfusion-associated infection has long been an interest of mine, and I've noted that in this region, about half the countries still only use SBSAG screening.
We are trying to focus on India today.
Okay, well, I don't know about India,
yeah.
and I don't know if this is true, but I would say I would like to really make sure that you've eliminated transfusion-associated hepatitis B and HCV. As I showed in my presentation, unsafe health care continues to be an issue there. That's a risk for multiple infections. You need to continue to focus on that. Then the other common problem is the lack of good harm reduction services for people who inject drugs, and how to get those communities properly served is a common problem in all but on very few countries. So that's something that really needs attention. And then this testing and linkage to care issue. That said, countries solve these problems. I mean, you have Egypt is hardly a high-income country. It has a large population. Now, granted, it had a much higher prevalence than India does, and so there's maybe a more powerful motivation to do something, but they put together all those elements that I showed in my presentation. I don't need to repeat them here. Rwanda, even a lower-income country, got money from the Global Fund and put together, again, a broad-based testing program, simplified treatment for hepatitis C, and got people into care and treatment. And there are other examples, Morocco, Mexico, Brazil, Thailand, as I showed you, has just made the movement there. So these are solvable problems. Now, you have to find the solutions that and tailor them to fit that particular situation in that country and health system. So in the case, many of these countries had a very top-down health system. Like in the case of Egypt, they have a national health system, whereas here in India, it's more state-driven. And so you really have to approach it more on a state-by-state level. And so you really have to really get all the right stakeholders around the table. And that's why there's a role for clinicians, for health officials, for community and for industry all coming together. And you really need somebody to be that coalescing force that brings those people together. And as I mentioned in the discussion earlier, that can be a clinician, that could be a community leader, that can be a health official, but we need to find that. In the case of hepatitis B, and I got to go over and visit the ID clinic of Dr. Kumar, we really need to do some real research to develop good models of care for hepatitis B with existing treatments while we're looking for these functional cures. So I think there's a real opportunity for operational research. And with India, with your great capacity for product production and distribution and your excellent talent in medical research, I think you could really play a very key role in research for that could improve the strategies and technologies for hepatitis B and C. But just increasing that awareness so that people feel like this is, there's a real obligation to do something. And I think on all these countries that tend to work really well, they have made it a routine service. They have normalized delivery of hepatitis B and hepatitis C, where it's regarded as just good medicine to screen people for hepatitis B and hepatitis C. So you sort of get away from this pure key population or this selecting people, but they realize that no one should be dying of hepatitis B or hepatitis C without an effort of good care. So I think really striving to make it a general routine service for testing and linkage to care.
Dr. Halford, how do you think about challenges? We'll come back to you for solutions later, but if you want to add anything about challenges.
So challenges in terms of, are we going straight to challenges? Okay. So, I think in terms of people with lived experience, the biggest, what people want, and what we see across the world is equitable access to healthcare, absolutely. But what that means is, it means that it needs to be decentralized. And what more importantly, I guess, is before you decentralize, is for the community to be at the center of the solution. So when we're talking about in India, because I think something that wasn't mentioned earlier in the challenges was access to treatment. So fantastic, there is free treatment, but many people with such a rural diversity across India cannot access it. So if you're going to offer health equity, you have to then change the way you deliver it. And this is the same across the world. If I think about Africa, people cannot, they don't even can't get access to testing either, but they can't get access to treatment. And particularly, a personal view, but we hear it from people across the world, if you're going to offer testing, you have to offer treatment, and they has to be accessible. I think that something that didn't come out earlier as well is stigma. And that's about changing the conversation. That's about national campaigns to raise awareness, to change the conversation. And also, one of the challenges that was in there was community engagement. You need to fund them. It can't just be integration into existing services. Community had the answer. We've seen that over the last days. If we look at Manipur and we look at Cone, look at what they've done in that area. You have a fantastic model. So I think globally what we see is patients who are frustrated, who in small cohorts have gone out, have done programs of work, have been really effective, but they're not recognized and they're not funded. They have to go to another global fund or something to get the funding to do it. Put the people with lived experience. So when we're talking about the states, so we've got the vertical, but actually it's going to be delivered horizontal. When the states are discussing their action plans, because they're going to have an action plan, they need to put the people with lived experience, the community organizations, at the meetings with them and share the data with them and share the resource with them if you truly want to eliminate. And that is across the world, that's what we see. Include me. Right. People say, include me, make me part of the solution, and not in a kind of bit-piece way, in a meaningful way. You have an incredible resource in the people with lived experience.
Thank you. Giten, I'm going to jump over you because we need to go to the solutions.
Thanks.
So, Rachel, while you are at that,
Yeah.
Do you want to add anything? Okay, you want to say something, Gitan, about, yeah, so how do we differ from other Southeast Asian countries?
Right, so there are, I'm so sorry, there's going to be so less time. We see the clock here, but there are so many opportunities. There are so many opportunities. The very existence of this program is an opportunity to address these challenges. I request all the community groups and the civil society organizations to at least open the National Viral Hepatitis Control Program website and see how many treatment centers or model treatment centers do you have in your settings, okay? One, it will be, you know, all of them will not be functioning. Do an access audit. Share this information that you have all of this, but we went to these ABC hospitals. They had this good ones, you know, the art of receiving and giving feedback. This ABC, they were doing it, or these services were not available in those hospitals. At least have a look at that. The website doesn't offer much information, but at least you can start doing that, number one. Number two, this also includes now, the program includes at least vaccination of all the high-risk categories. And as I said, all the high-risk groups are the same as in the HIV program, except the addition of family members of people living with hepatitis B or who are surface antigen positive, as we call. So that is the only extension. Please start reaching out to those people, state nodal officers. There are some state nodal officers. Please liaison with them. If you're from the same place, please talk to them. We want to start doing this. The community groups are being provided screening kits, both for hepatitis B surface antigen and for hepatitis C antibody. Please take it from them and start using it to the people that you are working with, making sure that whoever is positive to those are linked to the proper program for proper diagnosis and onto linkages onto treatment. There are many, many things. India has a history with hepatitis C. I don't know how many of you would recall in terms of access to medicine. In India, when India became TRIPS compliant in 2005, a hepatitis C medicine was the first, and B, was the first one to be patented. Do you recall that? Pegylated interferon. That was the first drug in India for viral hepatitis that was ever patented in this country, right? So we have to continue this fight. After that, it has been a long fight to get to where we are. There are program implementation plans that are being developed. Ask your state nodal officers and as larger civil society groups, where is the program implementation plan? We don't need to know the fine details, but at least know if, as Rachel said, if organizations are not funded, it is not going to happen. We talk about limited funding here. HIV program do give...
Get in short. We have limited time, yeah.
Yeah, when you
no,
have...
I know, you are really emotional about all this.
Yeah,
that's very good, but we'll have to keep it short because...
Sorry, I'm just finishing. So when you have me in the panel, this is the problem. I can't keep time. But I do good as a chair. Just
no, but
joking.
when Gitan runs a program and we go, he doesn't give us extra time. So I'm paying him back in his coin. Yeah.
Yep, so please, look at those program implementation plan and check and see where we can participate. Please see this as an opportunity. There are good community organizations who are doing good amount of viral hepatitis work with some funding, without some funding, okay? So not everything we need needs funding. We have already existing support systems to make some of the system work. Let's collaborate. Vivek's organ, if we can do same-day test and treat in Manipur, why not in Chennai? Why not in Mumbai?
Guillotine.
Sorry. So
we go back to.
I'm happy to answer questions outside. Catch me. We'll continue.
Yes, we'll do that. So, Rachel, you did talk about how we can deal with those challenges to some extent. You want to add more about what we could do to deal with these challenges?
Just a couple of things. One of the things I want to say is I want to be asked for some caution around, there's a lot of talk about integration. Integration's fantastic, but it isn't the way out. And I think if you think about it, I was speaking to some patient organisations yesterday. So if you're talking about integration with HIV, the HIV organisations aren't necessarily going to open up with warm arms because they don't believe that they have the resource to deliver Hep C or Hep B as well. So actually, if you're going to ask for integration, you're going to have to put some resource in there. You're going to have to do some proactive negotiations and communications with it. So when we were talking about how do you deal with these challenges, I think there's some really important things. There is involve the community organisations. You're talking about these plans that already exist. Why weren't the community in them in the first place? So that it should be led down from the government, and the government should be saying to each of the states, this is what we expect of you. So there needs to be accountability, number one. Number two, decentralisation. At the moment, the only way anyone can access treatment is they have to go to a hospital. You don't need that today. Hep C cures are really simple and really easy. We've heard yesterday, today, echo, telemedicines. Let's get into the 21st century here. There are much simpler ways. We have rural clinics, which are incredible. You could have somebody in a rural clinic. They don't need to travel 6 hours to the hospital. When it comes to the slums, there could be a bus. You could have an on-site, travel with your clinic. There are some really easy, simple solutions. Do not expect someone who lives in a slum, who gets 1 day's work a week, to choose to go to a hospital rather than do their day's work because they're not going to eat. You guys know that. I've heard it from here. So...
Yeah, those are good suggestions.
Yeah.
I'll have to move to John because we have limited time.
Well, I think this summit is a great start to do more. We had a great presentations, really identifying really effective programs and key partnerships, and that I think it's really a matter of scale up here. You have the in-country production of diagnostics, vaccines, and treatments. You have pilot programs showing how these services can be broadly implemented, and now it's just a question of scale up. And so that's really turning toward the national commitment for hepatitis elimination that then I think would stimulate more state-level commitment as well. Some of that needs to be data-driven for the health benefits of elimination. There's also an economic case to be made with lost productivity when you don't eliminate hepatitis. So I think you can make that message. And then there's the human element. And then there's a little bit of at least from the U.S., I know every social, political situation is different in every country, but I think we really need to band together representing the diversity of partners concerned about hepatitis elimination in India, and really express a call for action to the national government and just really lay out, what we're concerned about, what are the opportunities here in India, and now it's time to seize on them. And I would really like to sort of test that out here with the panelists and with the people in the audience to see if that would be beneficial. As a coalition, we prepared calls to action for Europe and for Asia, and I'm happy to, to draft one to circulate, and so everybody feel like it properly represents their view, and we can send a stronger message.
John, we'll need to move on to the other participants.
Call to action.
So,
I would like to hear your comments. Thank you very much.
Thank you. Yeah.
So these are some of the key shifts which are required to overcome these challenges. Most important is greater public awareness, because that not only limits our testing and detection, but it also creates stigma and discrimination. You heard today, Dr. Sareen, 6 doctors with hepatitis B were denied admission by medical college, by healthcare providers. So that is that we require more public awareness. We require more IEC campaigns. We see some of the campaigns mentioned like East and all, but as a general I don't see many campaigns around hepatitis.
You'll have to be
I'm
brief.
going to
because we need to leave time for the audience.
Yes. We need increased access to B and C testing, decentralization. We know that there has been linkage losses, delay in getting the reports, particularly with the scale of molecular testing in COVID. We need to have more, reduce the time for the reporting, and we need to basically strengthen community and civil society, definitely. Hepatitis birth dose, 56% again is very low, and we have now techniques like Uniject where we don't need a cold chain, so that can be easily scaled up to Ashas. Can we move to the next?
Sorry.
So we need to think of the decentralization of testing and treatment, which has already started happening, I will say, in India, but task shifting to non-specialists, still people want to go to a hepatologist for hepatitis C treatment, which is not required, and it is hepatitis C hepatologists who have to give up this to the training and build the capacity of healthcare providers. SCV self-testing, point of care, viral load technologies, these are certain things which need to be really scaled up, and as was already mentioned, we really need to have when we talk of diagnostics, we need to have triple test kits. We already have dual test kits for HIV, syphilis. We need to include hepatitis B into that. We have, next please. We have tried to build capacities from WHO, but these need to go down further. National Viral Hepatitis Control Program has trained 4,900 people, which is a big number, but we need to do more. We talk of awareness and advocacy. We had WHO, the Goodwill Ambassador Amitabh Bachchan, but I will say that we failed to utilize him. So we need to really bring people in and utilize them for increasing the awareness and use the partnership value. Thank you.
So Giten, how can Treat Asia help India?
So I'll try to be quick. So we have been working very closely with some community organizations here, especially in terms of actual implementation. So you will find the same model which I was talking about, the same day hepatitis C test and treatment among people who inject drugs. As we know, globally, community-led, that's the first example, driven completely by people who inject drugs. There is another model that happens in Egypt and all, that's a different another story, but this is something which we can reach out, and then we can, if we want to collaborate, then that's an opportunity, number one. Number two, please link with research. Please read documents. Unless you know the system and the technicalities, we will never be able to challenge the system. The funding scenario is not good. So if we don't have, it's not like those 20 years ago of HIV, it's no longer that. So we have to know the system, we have to know the technicalities. We write quite a bit, along with some of our faculties here, quite a bit of articles. Community organizations lead that. They do the work, all their names are there. Please write up opportunities, write up manuscripts, not in form of full articles, but there are many categories that you can write on based on your work, based on what you are doing. Please look out for all of those. We'll be happy to do that. We do not provide at the moment direct funding, but any sort of technical assistance, we'll be happy to provide to anybody. Thank you.
I suppose what he said about Treat Asia applies to many other non-governmental organizations. They would also be happy to do that, I suppose. So with that, I'm sorry. So Reshu, I know I'm coming to you at the end, but Dr. Reshu, what do you think? Do you want to add anything to what Dr. Riwari said? Or anything that you think yourself? What do you think we need to do?
No, I think most of the things have been said and have been discussed since yesterday. I think a lot of solutions have come up. I really tried to sort of put it in the WHO framework, and as per our global health sector strategies, there are 5 strategic directions which are given. So one is you need to deliver high quality evidence-based services, and that's where I think, I also try to look into the opportunities what is available in the country and where we need to move in. So I think we really have good integrated system as being is acknowledged by everyone. It's up to the primary health level, but then I think that the real implementation, we need to implement with fidelity. I think that's something which is lagging behind. And that's where I think in the point 2, I would say the sub-national and sub-national leadership really plays a very critical role. We need to really come up with that. And in India, health is a state subject. So unless, and then we are talking about the breadth of the country. So obviously here each district is like one country in some of the other continents. So I think we need that kind of a sub-national approach and sub-national leadership, given the kind of diverse epidemiologies, diverse culture, diverse health systems which we have. Without that, I think we would not be able to achieve anything. The other piece which I wanted to highlight was the private sector engagement. And we do acknowledge that in India, nearly 60 to 70% of the healthcare is actually delivered in private sector. And that's where in hepatitis care, the engagement with the private sector really becomes very, very critical. And that has to be like more concrete in terms of sensitization of the private sector on the rational practices, as well as like some sort of licensing between the government program and the private sector in terms of sharing the resources and sharing the data. So that piece is really very critical. Then the data, I think there are like robust data systems which are available in the country. And as you said, like, especially WHO is actually supporting the national program in doing the estimation exercises, because what we have is the prevalence, but in terms of percentages. But when you really like apply it to the population level, we really don't know the absolute burden of the disease, of the incidence, of the mortality, of the morbidity. So that's something which we need to really understand, so that we have really clear-cut goal posts, like where we are, where we need to go in terms of the absolute numbers. So that is something which is in progress, and perhaps like we really had a good exercise with the national program on this, and that's work in progress. So hopefully like we will have like the national numbers available soon. So I'm hoping for that, and perhaps like that would pave way for use of data for decision. So that is something which needs to be really strengthened. The other piece is around the community, and from HIV we know that we really have a very robust community, a very robust engagement, and it's possible. We really know the how part, but then with hepatitis, I think we are lagging behind, and we really need to have this more concrete involvement with the community in terms of sensitization, awareness, advocacy, and seeking the feedback. So that mechanism perhaps needs to be strengthened, because we don't have very concrete mechanisms. There are like mechanisms where like siloed feedbacks or ad hoc feedbacks are coming, but then like there is a systematic way or of structured feedback from community is not currently like working, and perhaps like forums like this could really give a good platform for that. And the last is foster innovations. That's where I think we need to really advance on the research agenda and really.
Okay, I'll stop you there. So we have 6 minutes and 50 seconds. Audience. Any other solutions
Dr.
you wish to
Rakesh, with your permission, I missed out on one thing which is very important, and I seek your permission. We have always said political commitment. The kind of political commitment we saw in HIV with National AIDS Council, with 31 ministries headed by Prime Minister, we don't see in hepatitis. TB coming into Independence Day speech of Prime Minister. HPV vaccination coming into budget. That is one thing which we say when we say political commitment is there, but I think it is inadequate.
Okay. I'll start with the lady. Sorry, I didn't see who came first to the mic, but yeah, you first.
We are saying integration, but the thing is like the state subject in the health. But the nationally it is not come through, then the states cannot do anything about it. I experienced this when we are advocating for pap smear test for women living with HIV. So nationally, there should be integration, then only the state will implement it. That has not happened at all. The thing is, like Tamil Nadu, we have a pap smear test available in accessible for women living with HIV. Where is other states for women living with HIV? Similarly, we wanted for the Hep C test should be done for people, then vaccinized for positive people. So we talked to the department. They're saying that we don't have a testing kit available. So then, where they're coming from? So those things and all actually we have to look at it, and we have to actually solve those problems. Then only we can able to implement in the states.
Yeah. Whosoever was first amongst you.
So it's heartening to listen to the word community engagement, stakeholder engagement from all the panelists over here. But what I would like to reflect over here is like currently considering the existing program scenario, how do we actually involve communities into the program delivery, into the service delivery is still a big question. There is still a huge level of mistrust. Okay, not only with the community, private sector is a big thing. So there is huge mistrust between the private sector, but then within the communities as well. So I think there is a question, how can we create some simplified models of care of engaging community and demonstrate them, and then to open up the program's mind.
The Manipur model. the communities will also have to take a lead. We'll go to the next one.
And quite simply, just ask them. Just go out there and ask them. Just get a group of people together and ask them what they want, because then that starts to change the conversation. You know, we're not separate weirdos because we had Hep C or Hep B. We're just human beings. Just ask us.
Right, Rachel. Means this need to be like from the both sides. Right now, program is functioning mostly like a standalone, like very vertical, just from the service delivery provision point of view, and that's it. Yeah.
Let me answer. I think Gitain said that. People from the community have to come forward to engage. He said, you look up where the centers are, give a feedback to the program. Once you start giving feedback which is useful to the program will also engage. Let's not expect the person sitting in Delhi to engage with people in every place. I think it has to start locally. See, for the country, the program is vertical. But for people, it has to be horizontal. And that's, I think, something that's what Dr. Reshu was also trying to emphasize. Sir.
Okay, thank you. So I just want to make only 2 points. We are talking about hepatitis, awareness generation, demand generation is very important. Everywhere, every stakeholder and the experts have said in the forum for last 2 days. But when we go into the budgeting, there is no budget for advocacy activities, any stakeholder engagement, any other awareness meetings with the actual users. Even in HIV, that is totally cut down. We know what happened in 2014 after the budget cut. Totally all these advocacy, awareness, stakeholder meeting gone away. Second, sir knows very well because I have been arguing for last 10 years. All donor politicians or policymakers more focused on the treatment, not on the prevention. So your prevention gets very demerits factors, so you don't factor it, or you are not bothered about, for example, there's a 1 million populations or there is no infections. We are only worrying about like 20,000. Yes, we are right. We have to treat them, but we have to safeguard those who are not infected also. So prevention, even HIV or hepatitis, the prevention aspect is not there. Even hepatitis program is totally a hospital-based driven program, a treatment-centric program, not even gone into the community, whatever we are discussing. It has not gone to the community engagement or a stakeholder engagement or a CSO engagement in India. So we need to focus the prevention aspects.
Sir, 1 minute. That's the time left. So go ahead.
If I may, on the prevention side.
I'll come to it. I'll come to each of you and give you a...
Yeah. So I have a small doubt. So now we have recent advancements in a lot of point-of-care tests. So do we have any integrated point-of-care tests which test for both HIV and hepatitis viruses? If yes, what is the experience using it in the field? If not, should we develop one to improve the accessibility to testing of hepatitis viruses?
You mean one test which will look for all the 3 viruses together?
Yes.
Okay. Sir, last one. We have only 30 seconds.
I think for community engagement, one concept of peer educator. Peer educator means those patients who have been cured by the antiviral drugs of hepatitis C. And there is a provision of recruitment of peer educator from the community for motivation of other vulnerable groups. So I think many states have been recruited peer supporter and incentivize them, and that have been provisioned in the PIP of NHM of all states. And regarding preventive aspects, Dr. Saab said that I think there is a budget for community level orientations to the healthcare workers, including outreach campaign activity.
Okay,
so,
I think we'll, yeah,
this can
so
be
sir,
taken.
your question about community engagement, how do we start? Peer educators are already a part of the program. And prevention, we forget. The country has a childhood hepatitis B vaccination program. That's prevention. The country provides for all the blood bank testing of all the donated units of blood. That is prevention. So I don't think that we can say that actually prevention is doing much, much better than treatment. That's why the emphasis on treatment. So now I'll go to all of you, and please one sentence that you want to say, because we are done with the time. Bolin. I can't help it. Organizers, will you give us 30 more minutes? I started with 30 because we are fine with 15. No. Okay, go ahead.
Okay. I just wanted to remind everyone that we are just barely 5 years to SDGs. So actually, between now to 2030, there's still opportunity to accelerate and intensify. That means it's you. You are the champions. We are calling you to action. Why is it important? Because governments, the national government will ask the states to report back on your SDG achievements. Hepatitis elimination, triple elimination is an SDG achievement. It's the lowest hanging fruit. And we can do it. And it's not just only World Hepatitis Day, remember. We have the World Cancer Day coming up in February the 4th. In March is the World Immunization Week.
I can see Dr. Shanmugam pointing
Scale
out
up testing, but test the right people. That is important. We don't know out of 91 million, how many were basically actually the high-risk people. That is one. And it does not mean that only high-risk groups. It means high-risk areas, prevalence, district-wise, state-wise, that kind of. And secondly, of course, decentralized treatment to non-specialist task shifting is important. And delay the time between the diagnosis and initiation. We saw 2 days, 3 days, it doesn't happen in the field. Yes, West Bengal showed 2 days, but it's not across the country. There are challenges in DNA, RNA testing, but we need to address those so that we don't lose people on the way.
Dr. Eshu?
I think it would be, from my side, person-centered integrated care as well as prevention aspects and subnational approach.
Dr. John Ward.
Well, while thanking the Chennai Liver Foundation for getting us together, I want to recognize the increased feeling on my part of solidarity of purpose with people coming together to share perspectives. I feel a lot closer and a greater sense of understanding about what needs to be done. And I just want this summit to be a starting point toward building more momentum to overcome the problems with the solutions outlined. And I think we can do that, and I'm ready to do my part as a global coalition to be part of that effort. Thank you.
Perfect. And I think for patients, I would first and foremost it's incredible, we're talking about challenges, but my goodness, India's in a really good place. You have so much potential. I don't think I've been anywhere where it is so exciting because it's like being on the cusp of something fantastic. It can be done. Please put the patient in the center. Decentralize on every part of the care pathway. Have a patient, fund the patient organisations, fund the whole pathway, and have some accountability, because if you don't, and it's states making their own minds up, there's going to be inequity across the different states. So accountability from the top, patient at the centre, fund them, reduce stigma, fantastic opportunity. And thank you to Chennai for this summit. I agree, totally. It's been amazing.
Dr. Giten?
Thank you. We have made progress. We have challenges. We've focused quite a bit on this subject today. If we want to challenge those challenges, we have to know the system, we have to know the technicalities. To all our civil society and community groups who are here, physicians will do their part, program people will do their part. Let's understand the technicalities and the policies and procedures. Please start opening the documents and challenge the system using those documents and information that you have on the ground. I'll be always available anytime to assist you in any way possible. I hardly sleep.
Now my 60 seconds, if the organizers will allow me. So we started off in 2017, 18, 19, as you heard, and then came COVID. I don't know whether we realize how much expenditure the government did on health sector in COVID. This was unprecedented. If you see 200 crores or 2 billion doses of vaccine administered, multiply that with the cost of vaccine and equal cost of administration, and forget about testing, patient care, the government did spend a lot, and obviously the other programs suffered. So that's when you realize that there are opportunity costs. We can look at the situation as glass half empty or as glass half full. I tend to look at it as glass half full, having been in India all my life. For all programs, what we have achieved in 6-7 years is what we have achieved here. I'm sure all those who are in the field of HIV, if you go back and see what happened in the first 5 years of HIV program, because I'm removing 2 or 3 years of COVID, I personally feel that we have done actually much more than what we had done at that time. We have the cheap drugs, that's the advantage. That's why people don't come for hepatitis C to the public sector. It is so cheap that they can go to the private sector and get treatment, and many more are getting treatment there. We have a setup, we have a peripheral reach, we have tests, we have the inclination, we have the commitment, and we have at least some funding. We are a large country, we are an elephant, we are not like a whale. Elephants are slow, they take time to move, but eventually when they move, things happen. Of course, we'll have to be looking at cost effectiveness. Money is a problem. We all seem to forget that we are actually a low middle income country. Everybody in cities like Chennai, Mumbai, Delhi expects that if there is a fire in their house, they should get a fire engine and ambulance in 3 minutes, as happens in New York or Los Angeles. But remember, we are not that resourceful. Task shifting, community engagement will have to happen. And I think they are happening. So we heard some examples, it's the implementation problems, but I think in time we will reach there. I think let's end on a positive note. Thanks to all my panelists and thanks to people in the audience who participated. Thank you.
A big thank you to our panelists and our moderator. Requesting Dr. Rakesh to do the honors and start with Dr. Ward and Ms. Halford. We have a special one for you this time. This is for And calling upon Dr. Vivek to do the honors and present our moderator with a token of our appreciation. Also calling Dr. Shanmugam to please join us on stage for a picture. We now quickly move on to our next session, a generation free from HBV, eliminating mother-to-child transmission in India. We're hoping to keep this as quick as possible and requesting our moderators and our speakers to stick to the scheduling. Inviting our moderators on stage, we have Dr. C.E. Eapen, Professor and Head, Department of Hepatology, Christian Medical College. He has published extensively on viral hepatitis, liver disorders in pregnancy, and chronic liver disease. Can we give him a big round of applause? We also have with us Yuhui Chan, who leads strategic planning and operations for the Global Hepatitis Program at CHAI, and she's been involved in global hepatitis elimination efforts since 2018. I'd also like to invite our speakers to join us on stage. Let's hear it for Dr. Vinay Kumar, Dr. Asha Hegde, Dr. Tanvi Khera, and Dr. Pallav Bhattacharya. Can we have you on stage, please?
Good afternoon, everyone. Nice to be here today, and thank you to the organizers for having us. So now we're moving forward to the next session to discuss moving forward a generation free from Hep B, elimination of vertical transmission of hepatitis B in India. There are a lot of things we can debate on in this room, as proven by what we've seen over the last couple of days, but I'm sure there are two things that we can all agree on, and that is firstly, that no child should be born with HIV, syphilis, and Hep B, given that it's now feasible to virtually eliminate these life-threatening diseases in infants and young children using simple and affordable interventions, while also assuring the health of the mother. Is a wasted opportunity for a pregnant woman to attend a health facility at an ANC, get screened for HIV, and not be screened and treated for syphilis and Hep B. So to borrow from what the speaker from the last session so aptly described, that creating a generation free from Hep B requires rethinking and redesigning the system to leverage effective tools that we already have. So without further ado, let me introduce the first speaker, Dr. Vinay Kumar, who's the Joint Director of Immunization and State Immunization Officer in Tamil Nadu State. He has 14 years experience with World Bank-supported Tamil Nadu Health Systems Project and National Health Mission, and leads the Universal Immunization Program in Tamil Nadu since 2020.
So good evening, everyone, and I sincerely thank the organizers for giving this opportunity to have a session on to talk about immunization as one of the pillar of viral hepatitis elimination. Without taking much of time, I just go to the presentation over here. I just drafted my presentation in the following ideas. There is introduction, what I need just say about immunization in India, and then what is about immunization, what we are doing in Tamil Nadu, and then about impact of immunization in India as well as global and in Tamil Nadu, and what are the national viral hepatitis control program, and what is immunization's perspective on the national viral hepatitis control program. And then I'm just discussing about what is the positive feedbacks for me to implement this immunization as one of the pillar for viral hepatitis elimination program, and finally coming on to the summary of it. And of course, you know that immunization is one of the most cost-effective health investments. And these are all other things and all history. There is no smallpox in the world. We eradicated. And in 1978, we started the expanded program of immunization for 6 diseases. And later it was expanded to 1985, we expanded to further diseases also. And the global perspective of vaccination is, just we can look at the most important slides over here. There is 30 years of experience with immunization in 1990 to 2019. The global impact of vaccination has reduced deaths due to 4 diseases, mainly diphtheria, measles, and rotavirus, and HIP. So you can see the reduction of deaths globally is about 86.9 million deaths in 204 countries. And there is a decline of more than 21.2 deaths per live births. And absolute number reduction, we can see the maximum in China, Ethiopia, Pakistan, and Bangladesh. And India has about 1 to 3 million deaths avoided due to vaccination. And next, just to summarize what is happening in immunization in India, we started in 1948, although it started as tuberculosis BCG vaccination, and right now told about 1985, we started the expanded program of immunization. The entire cohort of immunization stands with the annual target of more than 2.6 crore infants and 3 crore pregnant women. We are targeting immunization every year. And we are vaccinating with 11 vaccines against 12 vaccine preventable diseases with 13 antigens. And we have more than 1.3 crore sessions being happening every year in India for these immunization activities. And also we have more than 30,000 cold chain points acting as a immunization sessions for us. And next milestones, I just highlighted the milestones over here. One is about smallpox free, of course everyone know that. And we have the polio immunization days in 1995, we started the immunization day as polio immunization days. 30 years down the line, we eradicated polio. 2014, we got the certificate of Southeast Asia region eradicated for polio. And of course, Tamil Nadu is now reporting cases from 2004 onwards. And again, the most other important activity through vaccination we did is maternal neonatal transmission were eliminated. Again, coming to the major events in immunization, COVID and UVIN. COVID we started in 2021 and UVIN is a new system of digital platform for anti-immunization activities pan-India. And this is a roadmap of immunization where hepatitis B has been targeted over here. Although there are many vaccines being introduced in the system, I just highlighted the points of hepatitis B introduction in 2002, later updated to the national wide in 2010, and then pentavalent is introduced in 2011. So with this, we are able to cover the birth dose immunization of a child at birth, 6 weeks, 10 weeks, and 14 weeks. And this is a shift over vaccines with DPT hepatitis B to pentavalent. And the main aim of objective of universal immunization program is to at least 90% of full immunization coverage for an infant to free from the VPDs, vaccine preventable diseases. As this is the impact of vaccination, what India has done till date. The major 3 diseases, smallpox, polio, and neonatal tetanus. The smallpox cases we can see in 1974, there are 1,88,000 cases. Whereas in 1977, it's completely eradicated and we don't have no report of case smallpox due to vaccination. Coming to the second disease of polio, we had 2 lakh cases in 1978 when polio vaccine was introduced. And now polio free in India is 2014 and Tamil Nadu is 2004. And neonatal tetanus, we have few cases of neonatal tetanus and we're 99% towards the elimination target. So this is the immunization efforts, what we have seen globally and India. We can see the hepatitis B coverage is about 91% in 2024. That is unique reports, that is WHO, UNICEF estimates of national immunization coverage. I'll track down the data from the WHO website also. We can see that there are 3 data sources for the immunization activities from 2017 to 2013, which very well says that hepatitis B within given 24 hours of birth is about 63% as said by the previous speaker. It is 63% in 23 within 24 hours. Beyond 24 hours, it is 87%. But it is not use of hepatitis B elimination here. And coming to the consideration of 2014 to 2023, the percentage is increasing to 86%. This is an HMIS data. There is integrated IHP portal data. I admit that there are limitations in this data because it's HMIS data is a number data. It is not a line list data. Again, coming to the third dose of pentavalent, it is about 91% as per the unique reports. And also we can see that gradual increase in the immunization reports from 2017 to 2023. Again, the same limitations of being an HMIS data. Incidentally, in Tamil Nadu, we follow this data also been recorded in the PICMI, the state in portal of pregnancy, infant and cohort monitoring data, whichever line is data, which is near equal to the data of 91%. We have 88% coverage in the PICMI portal. So this system of health system in Tamil Nadu, I run through because of I've been already informed about the timeline, so just running through slides. So we, Tamil Nadu government, in Tamil Nadu we have the 3-day system and we the Director of Public Health and Preventive Medicine, we have this immunization division with us and we are working on these immunization activities. So these are programs being implemented under Universal Immunization Program, Universal Immunization Program. We are targeting the 0-dose children and the special immunization program including the pulse polio and COVID and hepatitis B, again EVIN and UVIN. I'll explain EVIN is Electronic Vaccine Intelligence Network and UVIN is a process for digital platform for immunization. So it's all been repeated again. Just a point to say 11 vaccines, 12 diseases, again having 13 antigens with us. And of course, India is the largest manufacturing country in the world. And the target for Tamil Nadu is about 3,000 cold chain points. And we have 13,000 vaccinators with us for vaccinating the immunization activities with 1.4 vaccine doses per year and 6.75 lakh sessions. And we have beneficiaries about 9 lakh newborns and 9.1 lakh pregnant mothers after the abortion wastage. So these are the vaccines we're giving under immunization programs: 11 vaccines, 12 diseases, 13 antigens. And this is scheduled, and at birth 3 doses, 6 weeks, 10 weeks, all those things, and given highlighted the doses given for hepatitis B pertaining to this conference. Hepatitis B birth dose within 24 hours, and then followed with 6-week pentavalent, pentavalent 2 and pentavalent 3 at 6 weeks, 10 weeks and 14 weeks. So literally say an infant gets 20 doses of vaccine in his first year, and another addition of 4 doses by the end of second year. So this I compared the reports of immunization with perspective to Tamil Nadu state. I will compare the NFHS 5 data along with the HMIS data which we have. We can see the HMIS, the yellow color reflects the NFHS data 2019-20, which is NFHS 5, which is about 97% is of BCG, and hepatitis B is not being covered under NFHS, so I am not compared over here with NFHS data here. Other parameters and all, we are in line with the NFHS survey, and we are above the target also. And this is the indicator where Government of India is reviewing the immunization division. We have the hepatitis B coverage as one of the predominant review indicator for us in the immunization division of Government of India. And the target is about 95% should be more than, because we admit that even the low birth infants cannot get the hepatitis B 0 dose at birth, because we have more than 12% of low birth weights in the community, and those kids cannot get the hepatitis B vaccination. So the target fixed by Government of Tamil Nadu is about more than 95% with a conscious decision about it. And we are we can look at the data, and it's about we have covering more than 99.38% here. The limitation again is, I already told in the previous presentation in the morning, we have the more than 65% deliveries happening in government sector, whereas 35% happening in the private sector. At present, as sir also discussed during the lunch break, we have a crisis of hepatitis B vaccines available in the private sector, wherein we have the government of Tamil Nadu has been said, because it's our responsibility, and we made a circular to the private institutions to come into the fold of EVIN so that we can give vaccines to them to vaccinate the children within 24 hours. In case if they're not able to come into the system of EVIN, we are asking them to take it to the nearest CHC or PHC, or the PHC staff will vaccinate them in the private hospital. So this again compared, the percentage is about more than 100%, and this is why. And what impact we have done in immunization in Tamil Nadu. Look at the cases of polio in 1981 and deaths in 1981. Just compare two data. So cases and deaths are decreased. So 0 deaths. Again, diphtheria, there are 317 cases and 38 deaths in 1981, and there are nil cases. There are 12 cases in 2016, and then 0 deaths in 2000 from 2000 onwards. Again, measles. Measles have more than, we can see 10,000 cases of measles in the year 1985, and there are measles very less in 2015 onwards. And pertussis, again, there is a decline in all the deaths. So this is the data, secondary data in 2 parts, because IHP poll was not available before 2016. IHP poll is available after 2016. So I designated data into 2 sectors. And this data compares about measles and rubella cases being reported in Tamil Nadu at present because of the fever rash surveillance system in India. Because we are targeting measles rubella elimination by 2026, but now whereas Government of India has extended that deadline, we will be getting another set of deadline for measles rubella elimination. So we are asking all the PH doctors to report fever rash surveillance. So we have an increased number of measles and rubella. And I, as a public person, we send a clear message to all the doctors that if there is a measles or rubella case, please report. Do not hide the case. With hiding the case, you cannot eliminate any diseases. And diphtheria and pertussis, you can see the decline in the case in 2024. It's only 3 cases of diphtheria positive and pertussis 0 positive. And of course, this has been already dealt in previous sessions. I just run through the slides. Again, National Viral Levels Control Program is being dealt in elaborate yesterday also and today also. I just want to highlight the perspective scope of immunization in the scope of immunization as a part of viral hepatitis program. So the strategy 1 talks about the preventive and promotive interventions with focus on preventive aspects, which Professor Agrawal also said about the immunization activities being happening. And next is about the key components. Again, the components about immunization hepatitis B, birth dose, high risk groups and healthcare workers. At present, we are doing the birth dose and healthcare workers, and high risk groups yet to be started. These are the activities already explained in the morning. So additional groups is about high risk groups. We got the approval from Government of India for 38 lakhs towards the vaccination of high risk groups, and the program will be rolled out soon. So these are the vaccines available. Just to have an idea about what are the vaccines available approved by the Central Standard Drug Control of Government of India. We have more than 5 vaccines available in the open market, and is available in the UAP programs also. So what is recommendation of hepatitis B recommendations is about international guidelines. It says about newborn children up to 12 to 18 years of age and adults are higher risk of infection. Whereas our program says about national control program says about birth dose, high risk groups and healthcare workers. Birth dose and healthcare workers we are doing and high risk yet to start. So this is what we have done with hepatitis B vaccine for healthcare workers. We made a request in 2018 to Government of India, and Government of India released 2021. They released about 7.8 lakh doses of 0.5 ml vaccine hepatitis B doses, and we distributed initially to 42 treatment centers because of the program was not much taken off on that time. And later in June 2022, we started, during the period of COVID itself, we started given to all the HODs, all the directors to have this implementation of hepatitis B vaccination. And as per the COVID portal, we have a staff strength of more than 2.2 lakh healthcare workers, which includes outsourcing staff also and the CRA students also. And it's of course open well policy is applicable. And we maintain the vaccination registered and vaccination card. So this is the only thing I just want to mention to the forum is about, we had doses of 7.8 lakh, but the utilization is only 41%. I told you 41% of doses have been utilized by the healthcare workers, and among that is 33% utilized by the first dose. This 41 includes a wastage. So the first dose is about 73, 52 and 25,000 in the first dose, second dose and third dose. The experience what we learned from this hepatitis B vaccination from 2 years run around is only 41% dose utilized. The balance was adjusted with the universal immunization program, not wasting the vaccines. And only 33% have been opted for the first dose vaccination. And among the 33%, 71% got the second dose. And among the first dose, we got only 48% completed the immunization activities. So the feedback what we got, even the willingness of the healthcare workers was very much lagging, because after periodical monthly reviews with the district immunization officers, the output and the progress was not much as expected. And again, absence of previous vaccination records, because when I joined MBBS, I had this hepatitis B vaccination, but if you ask me documentation, I don't have any documentation. The same thing happens in any undergraduates or postgraduates going for the medical college institutions also. And again, lack of awareness among healthcare workers. Even the COVID also, we had some issues. The same thing prevails for this healthcare workers in hepatitis B vaccination also. And of course, lack of community strategies. Even the last speaker was talking about advocacy meetings and funding for the community strategies. No, nothing was available for the community strategies. So I analyzed the situation, how immunization, apart from the universal immunization program, as hepatitis B birth dose 0, 6, and 10 and 14. If you're going to target the healthcare workers in high-risk groups, the challenges and the strengths which will decide about the hepatitis elimination through immunization will be because we have a lot of experience in COVID vaccination. As Sir said, 200 crore vaccines have been given in the span of 1.5 years with available health staff, and the similar happening in Tamil Nadu, about 12.7 crore vaccines have been delivered to the population, eligible population. So it's not a big task for us. We can do the vaccination. And again, vaccines, we had to get it from Government of India. Local purchase vaccines or Tamil Nadu Medical Science Corporation vaccines will not help us because the supply will not be 100% perfect. Again, same human doses which we use for UIP vaccinations, the same manpower can be used even for hepatitis B elimination vaccination also. And again, now we've been supported with EWIN and UWIN. EWIN and UWIN are real game changer for immunization activities, because initially there were paperworks for the vaccine stocks. Right now, even I can sit in Chennai and look at what is the vaccines available in one remote PHC in Nilgiris district, at what temperature the vaccines are being stored. So this is the system what we have at present with EWIN system. And the process is about UWIN. UWIN helps us in following up of a cohort, whether you got the first dose, second dose, 0 dose, first dose, and the 6th-month dose. Weakness, we had to talk about the staff fatigue, really, because after working for so long in COVID and other continuous health programs, both state and the central, there is a staff fatigue. We need to address those staff fatigue. And behavior change, I already told about the behavior change has to come from me. If I am a healthcare worker, I have a lot of risk, I should get vaccinated. And again, the lack of departmental in coordination, which the speaker from TANSAX was also talking about. Even the National Wild Hepatitis Control Program being implemented in the state of Tamil Nadu, there is a little bit coordination activity has to be strengthened in both at all levels. And program oversight to accountable from who has to do this and who has what is the responsibility has to be reviewed on a periodical basis. Because what I learned is periodical reviews only improves the implementation perspectives. And again, opportunities we can say about adaptation or communication strategies. And again, UWIN and EWIN is again a good opportunity for us to utilize these things. And threats coming to think is challenges in the high risk groups, because even there is a representation from many high risk groups that we need to get vaccinated, but I'm just telling that the testing reagents and the vaccines are at present, we have in short supply, and we'll do it immediately as we need to sit for a common sitting, come out with the program, come out with the roadmap for targeting the high-risk groups also. Because we have the fund allotted, but the procurement process yet to start for that. And unlimited supply of vaccines, and then anti-vaccine lobby is a common problem across the states, especially in more literate states like Tamil Nadu and Kerala. And of course, we need to come out with bits, and then documentation, multiple portals. I was talking in the morning session, they were talking about MIS portal for viral hepatitis program, but again, UVIN is there. So we need to think about a system where UVIN could be integrated with the National Viral Hepatitis Control Program with regard to hepatitis B vaccination. Yeah, thank you, and thank you.
Thank you, Dr. Vinay. Thank you. We'll take the questions at the end. May I invite the next speaker, Dr. Asha Hegde, to talk on achieving triple elimination. What will it take for India? Dr. Asha is the Director of HIV, Hepatitis, Syphilis for South Asia in PATH.
Thank you. Good afternoon, everyone. Wishing everyone a happy and a healthy life. And I want to thank the organizer for insisting that I attend this conference physically, which actually gave me the courage to travel. And also thanking the organizer for a very warm hospitality. So this is the contents of my slide. First, about global guidelines. We speak about the framework, about the global guidelines on triple elimination. इसमें नहीं आता है? Does it come on this? So the first pillar of the WHO framework is on primary prevention. So can we prevent the 3 diseases in the young reproductive age group? And to that, what we need to do? Should we do it through social media? Should we do it through for urban population, through PRI, through self-help group? But basically, education and awareness in this young reproductive age group about mother-to-child transmission is very important. And the second pillar talks about family planning and linkage to SRH services. Basically, building the agency of this community to decide if I'm affected by any of these 3 diseases, I should make an informed decision either to continue the pregnancy, or if I do not want to continue the pregnancy, then the system allows me to do so. And the third pillar, it talks about actually elimination of mother-to-child transmission, where we work on the SOPs and guidelines for these 3 diseases. And the fourth pillar is about taking care of the infected child, the family, and the partner services that we provide for the family. In addition to this, the guidelines or the framework also speaks about strengthening the health system. So we should take care about, when we speak about health system, we know that procurement, correct forecasting is very important. Supply chain, smooth supply chain is very important, especially when we talk about early infant diagnosis. And then talk about, can we integrate these 3 diseases when you talk about health system strengthening, so that we can provide a person-centered care for the pregnant women. And then engaging with communities. HIV program has taught us that how important it is to engage with the communities, and so that we can provide services in a stigma-free environment. And the last one they talk about is about human rights. When WHO validation team will come to the country, this is the first thing and the most important thing that they will look into it, is the human rights aspect, both from the provider side, while providing the services, and from the pregnant women side also. So triple elimination guidelines, is it available in India currently? No, it's not available. So ECS guidelines was rolled out in 2015. Then the EVTHS framework was released in NACP 5, where again spoke about the 4 pillars, taking a cue from the WHO. And the first pillar is, of course, which is more important, is the political commitment by the government. And of course, second and third is talking about screen, test, and continuum of care. And the last one, very important one, is the robust surveillance system and the robust M&E framework? And then do we have the estimates, the burden for all the 3 diseases? National Viral Hepatitis Program also rolled out the guidelines and also spoke about birth dose, and this was released in 2007-8. So what is the current status? We know that PPCD program was rolled out in 2001 in India, and today, after 23 years, now they have released the dual elimination guidelines. So still hepatitis is missing in these guidelines. NFHS 4 again said that for vaccination, birth dose vaccination to improve, awareness and education of the pregnant women is very much important. This slide, I want to concentrate on the last line, which is actually speaking about syphilis testing. So 2 things happened. If you see, for the last 2 years, from 57, it went directly to 87. That is a syphilis testing. So one is the dual test kits, which was made available, and second is NACO. Before 2 years, was not taking entire responsibility for the dual elimination. But since last 2 years, taking entire responsibility, and then we see a syphilis increase, which is comparable to HIV. People who have worked in the program know that there was a large gap between HIV and syphilis testing of the pregnant women. So this is just one of the most important lessons. So single point where it can be monitored is very, very important. And this slide, just want to show that even a very evolved program like NACO, and when we speak about validation, we are speaking about triple elimination. But if this is the kind of data that we are going to show, which has got no denominator, what is the point in saying that I have tested so many babies and I've treated so many babies? But how many should I have tested? And how many have I tested? Where is the gap? Are we teaching our facility staff to look at data in this way? Or do we have a cohort data of a case-based line list so that every gap is captured in the line list and I can cover for that gap? This is from NFHS 5, which says that birth dose is 67.4. I know some of the states may have much more improved from that, but this is from the NFHS 5 data. So a lot of work needs to be done for birth dose vaccination of hepatitis B. So what is the potential for India? We know that we can work on zero HIV new infections, especially in children. Then in today's date, if there is even one HIV positive child born, can we look at the data retrospectively and try to understand why did this child become positive? Can we plug the holes after understanding the gap for that? When we talk about congenital syphilis, we may have actually attained less than 50 cases per 1 lakh live birth, but do have the data to prove that. Do have the private sector data. So there's a lot of gap in data documentation in syphilis and probably for hepatitis B also, where we do not have any private sector data of coverage of immunization. So if I have high coverage for ANC registration, then why don't have high coverage for HIV, syphilis, and hepatitis B screening for pregnant women? It is the same entry data. So what is a challenge? There should not have been a challenge over here. So integrated service delivery and an integrated data system is very, very important if we want to talk about triple elimination. We have worked for at least 2 decades for NACP and NHM convergence. It has taken 2 decades and today somewhere it is in the line. Now we need to add 2 more programs into that, viral hepatitis program and the MNCH program. So all the programs need to work in synergy. We may not integrate, we may not convergence, but at least can we have a common SOP in the field so that the pregnant woman is not lost of this opportunity. When you talk about future, then shared vision and political commitment by the government, a common strategy or a common SOP at least, create demand generation and build the agency of the pregnant women and a family, Maybe we can use PRIs over there, leveraging the infrastructure of all three disease verticals, building the capacity of our health force. And we know that unlearning something and teaching something new is very, very difficult. So this would be a difficult task for us. And an integrated reporting format. We heard in the morning how important it is when we create a format that we need to take input from the field staff while even developing a reporting format. And this would be a case-based longitudinal cohort for more than 2 years. So inputs from the field is very, very important over there. Finally, we know that agent, host, and environment is needed for transmission of a disease. Then can we also say that for preventing a transmission or mother-to-child transmission, if the government with a strong political commitment, stakeholders like us who can work as an activist also as a part-time activist, and I'm looking at Pauline at that time, and community where it is pregnant women and the family. If all of us work together in synergy, then it is possible to say that no baby will be born with HIV, syphilis, and hepatitis. Thank you.
Thank you, Dr. Asha. All excellent points. All right, so we have about half an hour left for this session, so let's move on. I'd like to introduce Dr. Tanvi Kara, who is the Senior Program Lead, Product Development Vaccine R&D at AIVI, and she'll be speaking about accelerating hepatitis B birth dose coverage, challenges and opportunities.
All right, good afternoon, everyone. It's sometimes good or bad to be at the last session because there's a lot of repetitions that you might hear from our previous sessions, but I think on the last day, it's also good to have a takeaway. So I have tried to create a slides in a way that it justifies and also condenses the information that you must have heard from various areas. So I come from IAVI, and we have an experience of working with HIV and TB over the last 25 years. So if that learnings can be leveraged in the area of viral hepatitis, I think that will be very crucial. So with that in mind, I would just take a minute to also talk about IAVI and the areas that we work in. And then just pivot it forward to the viral hepatitis and the Hep B zero dose, acceleration of the Hep B zero dose challenges and opportunities. So we at IAVI, our mission is to translate scientific discoveries into affordable, globally accessible public health solutions with a vision where all people have equitable access to innovative vaccines and therapies. We work at the entire value chain of product development, starting from the people that is looking at seroepidemiology and looking at discovery using cutting-edge research across US and India. We also work in the area of translational development that also helps in making these products more, matured. And then we also work in the area of clinical research and definitely the area of global access and policy, where we've all gathered here so as to impart more awareness in the society. But today here, I'm not talking about HIV, but on HPV, because that's the area that we need to really lay some emphasis on. And I think from the aspect of numbers, because numbers is something that we've been thinking about, whether that's crucial. So I think I'm just going to lay some emphasis on the numbers here. So in terms of chronic hepatitis B, it's enough said that it's a major public health problem with a prevalence of 3.8, which is globally, and in Southeast Asia, it's about 3% among general population. We estimated about 296 million people living with chronic HPV infection with an estimated of 0.88 million deaths from hepatocellular carcinoma, cirrhosis, and acute hepatitis. And what is to really focus is that 50 to 80% of these HCC cases globally result from HPV, and making it the 6th most common cancer worldwide. What is quite startling is that the risk for developing chronic HPV infection varies inversely, and this has been very nicely laid by my previous speaker, Dr. Asha, who also mentioned about the, the pregnancy and the mother-to-child transmission. So the risk of developing chronic HPV infection varies inversely with age, and of children infected with HPV at birth, it's 90% of chances that they develop chronic infection. Newborns infected with HPV have a birth rate of 15 to 25% risk of death from liver cancer. And with this background, WHO, along with India, have actually set this target of achieving more than 90% coverage of both birth dose and the hepatitis B vaccine dose infancy. So coming to the rationale, because this is where the whole idea of giving the vaccination at early age is important. Therefore, spending some time on rationale for birth dose is quite critical. And as I just alluded in my previous slide, that newborns have up to 90% risk of chronic infection with risk of dropping, but this remains quite high during infancy. And children between 1 to 5 have approximately 30% risk of acquiring HPV, and those older than 5 years have a risk of about 5 to 10. So that was the area where I mentioned about the inverse deviation about the infection. So mother-to-child transmission of HPV, it occurs primarily at birth through infected blood. The risk of transmission from an infected mother to newborn is about 90%. In utero transmission is rare, and the virus is not transmitted by breastfeeding, so that's postnatal infection. And of course, cesarean section will not really prevent transmission. So with that, hepatitis B vaccination has been the most effective preventive measure, and it gives up to 75 to 95% effectiveness, ideally within the 24 hours of birth. There have been a plethora of studies that have raised knowledge on the late birth dose that has some effectiveness, but do decline progressively in the days at 7 days in preventing. But yet, horizontal transmission is also quite notable in HPV, and therefore it remains beneficial to administer vaccine. So over here is just a snapshot, a bird's eye view of the situation analysis of the different Indian states, and it was also mentioned that the coverage is 67.4 for India. But if you look at the upper panel in red, that's where most of our northeast states, and also quite startling is UP and Maharashtra also fall in that category, where there's less than 50% coverage in these specific states. The data is the NFHS data, the National Family Health Survey, and it does mention about the missed doses, which is 1/3, nearly 8 million children who have missed these doses. And the rural to urban differential is about 26%. The global Hep B dose coverage is about 42%, and 51% is in Southeast Asia. So we're quite good in terms of Southeast Asia because we're at 67.4. And also, a few speakers and Dr. Paulin had already mentioned about some of the countries in Southeast Asia where it has been verified for achieving Hep B control, specifically in Maldives, Sri Lanka, Bangladesh, Bhutan, Nepal, and Thailand. So with that background and knowledge, where in India we, despite an 89% institutional delivery rate, only 2/3 of newborn in India receive the hepatitis B dose. So now I think it's important to understand the challenges, and then I would just bring in some aspects and also the learnings that we have been doing in the space of HIV and TB from IRB, and try to include as well in that. So in terms of challenges, if you bucket it into 3, it comes down to healthcare system, policy and data reporting, and socio-cultural and economical. Within healthcare system, it'll be important to understand the infrastructure and personnel, and also vaccine implementation. Within infrastructure and personnel, there is diversification between private and public setup. There are instances of cold chain maintenance in remote areas, and there's often understanding about the staff absence or their non-availability. For vaccine implementation, there are supply issues in terms of availability of vaccine doses in private sector and inaccessible pockets, as well as there has been a lot of emphasis laid on the combined regimens using Hep B along with other doses, specifically the pentavalent vaccine that we spoke about. In terms of the policy and data reporting, the private sector engagement, where we already mentioned that institutional delivery at private facilities is about 26.2%, but there's limited support from policy standpoint to these private sectors. And of course, there's been a lot also mentioned about data reporting. So the HMIS captures zero-dose coverage. However, there is often mismatch with the NFHS data. And therefore, this actually brings in an opportunity that there needs to be a system for validation of these two reporting mechanisms. In terms of socio-cultural and economical, public awareness and education, as we've been talking about a lot, which in terms leads with the vaccine hesitancy, particularly for vaccinating newborn due to limited knowledge, specifically of the parents, because the kids are too young to administer vaccines. In terms of cultural beliefs and practices, India is quite a large country with different cultural beliefs, so there's vaccine acceptance is quite low, specifically in some communities. So with these challenges, it would be good to divide these challenges and then also look at the opportunities that can help in combating these challenges. So if you look at the 4 different broad areas, which can be community engagement and awareness, collaboration and partnership, innovative approaches, and definitely strengthening healthcare system. So within the community engagement and awareness campaigns involving community and religious leaders, tailoring awareness approaches to cultural context, and very innovative approaches leveraging experiential learning through gamification. This is one of the approaches that we at IAVI have been implementing quite a lot because the field of HIV is evolving. We're just not administering or using conventional vaccine approaches, but we also do a lot with the PLHIVs, and there are trials also in the Africa through our South-South partnerships in terms of administering vaccines within people living with HIV. So these kind of approaches and involving community leaders come quite handy. In terms of innovative approaches, being an advocate for science and technology, there's been a lot that's been worked on the technical innovations for vaccine logistics, specifically on supply, storage, and delivery. Research to identify area-specific so that the implementation gaps can be used to bridge these bottlenecks is also important. And definitely cost-effective surveillance, wherein usage of prediction algorithms or even AI methodologies can be employed. For collaboration and partnerships, I think this has been from the beginning that forge public-private partnerships should be yet accelerated. That also includes policy-based reformations for private entities and NGOs and civil society involvement, particularly for reaching inaccessible areas, should be also laid emphasis on. Coming to the last point on strengthening healthcare system, infrastructure investment, enhanced vaccine distribution, digital health records, particularly to address missed children among migrants, because migrants is another specific population, and it's very difficult to have a tab on them. And lastly, resource allocation is also idle. And yeah, this brings me to the concluding slide. And of course, I want to acknowledge that everything doesn't need to be negative. I think India has done quite a lot in terms of reaching the Hep B birth dose due to increased institutional delivery. But there are certain areas like engaging private sector, civil society organizations, strengthening health systems through digital technology and experiential learning could be a roadmap to reach our goal for hepatitis B elimination. Thank you.
Thank you, Dr. Tanvi. May I now invite Dr. Pallav Bhattacharya to speak on triple elimination in West Bengal. Dr. Pallav is the advisor on the West Bengal State Task Force on Triple Elimination of Vertical Transmission. Dr. Pallav, please.
Thank you. And good evening, all. It's not here on the laptop. There is some issue here, no? Okay, good evening, all. It all began sometimes in late 22 or beginning of 23 with the realization that the state had very high institutional delivery, 99%, along with it, immunization, RI coverage and screening coverage happened to be in a fairly good shape. And that's how we all began. The state realized that it was a fertile soil to go ahead with triple elimination. So essentially, I would be trying to look at the crux of what have been the milestones in the journey and where we are at this point of time, where we are in the process of scale up of the whole initiative, triple elimination initiative, having begun with a pilot in 4 districts. So essentially, we realize that fragmented approaches need to be cemented into a concrete integrated strategy, and for that the gaps were first identified, and then we went ahead in moving ahead with overcoming these challenges. Initially, the most important gap which we understood was data unavailability and programmatic challenges in capturing the whole cohort. So essentially, it was cradled into the lap of MCH. I mean, bringing all the 2 other programs, NACP and NVHCP, together and cradled into maternal and child health program. So as we understand, there is an immense opportunity of integration, considering the fact that the common screening point in the first trimester, ensuring universal triple screening protocols in the first trimester, because all need to be screened. So that was an important issue that we needed to look at. Timely prophylaxis availability and coverage of deliveries of known and direct in labor cases. That was another issue that we needed to look at and integrate. Coordinated governance across the different departments and integrated data systems, because that was a major challenge. There was no integrated data system capable of capturing mother and infant cohort. Of course, the weakest link happened to be syphilis. Training healthcare workers across the system was another issue that we addressed. So why triple elimination? It would be a win-win situation for all the programs involved and also for the maternal child health program itself. Because essentially it will definitely make a dent in maternal morbidity, mortality, as well as infant morbidity and mortality. So why did we go for triple elimination? The established success of the dual elimination strategy was already there for us to piggyback and build on it, and of course strengthen it further, all together, and of course using optimal resources and workforce capabilities, and cost effective it was due to the integrated maternal and newborn healthcare approach. So that was why it was a considered decision of the state to go ahead with triple elimination. So the main 3 thematic areas, as we understand: the service delivery part, the coverage rates I had already mentioned initially as to why it at all came into our thought process, thinking, because of high service coverage rates, I have already mentioned. The integrated diagnostics and commodity availability, the cold chain point availability was highly efficient and functional across all blocks. We already had in 2022 the introduction of the dual kits, as was already being mentioned, and adequate seamless availability of HbSAg screening kits also, which was made very fast through an efficient procurement system. And of course, staff at the higher centers were well capacitated, and leveraging of learnings from defined HIV service coverage cascades and implementation practices for pregnant women and EI, exposed infants that is, was taken care about. So the state has a RCH database named Matrima. So naturally, we utilized Matrima for making it the facilitator for cohort tracking of pregnant women and infants, and the Matrima ID was considered as the unique ID for the whole infant tracking of the mother-infant cohort across all the three, whole of the triple elimination effort. So that is what is important that we need to understand. And of course, as I mentioned, with regards to the governance, the state, it was a considered decision taken by the highest authorities of the state after due advocacy that yes, we need to go ahead with this. And already we have various statements and all coming out from the highest levels of governance of the state, saying that this is something which would make a definite dent and would be a good model for the overall maternal and child health program, as well as the hepatitis and HIV/AIDS programs. So this was essentially the background. I would try to be fast. As you understand, all the stakeholders form part of the state task force, which was created, and you see all of them are mentioned at the top. So we have all of these players all together. So the approach was essentially we initiated with a pilot across 4 districts of the state, and as you see, the districts are spread across the state. It's geographically in the north, middle, and south of Bengal. Of course, there are difficult districts also as part of the whole thing. The approach was initially, as you understand, creating governance structures, which was followed by situational assessment to understand the strengths and opportunities, the designing of a package, followed by prioritization of intervention, and development of details, guidelines, and SOP framework. And of course, the M&E framework, which there was some mention earlier in the day, STEM, it's System for Triple Elimination Monitoring, which is now being developed into a robust portal. As late this month, we go into the complete scale-up across the state. Trainings are completed, and so all districts of the state would now be part of the effort, initiation of the effort. So essentially, after that, there was piloting of the strategy at the select locations, as I mentioned, 4 districts, regular reviews, iteration of materials. There was a statewide scale-up, and as you understand that now we need to go ahead with regular reviews and iterations and validation and path to elimination. That's what we are looking at. Incidentally, there was a poster on display yesterday. Very encouraging results have come in from a under 5 study, under 5 HbSAg prevalence in under 5 in the state that has been done, which shows that we are well on the track to eliminating hepatitis vertical elimination, vertical transmission of hepatitis. And so HIV and syphilis also we would be again looking at it in details to see where we are. So a detailed situational assessment was done by a joint assessment team covering the 4 districts, and based on those gap identifications, this was done. So basically, the significant milestones achieved are these: the establishment of the state task force, situational assessments, where 150 facilities and 37 beneficiaries were part of the whole process. There were this important document, Kolkata Commitment, was signed with all stakeholders in place. It was done through a colloquium consultation where the total intervention was worked upon and a strategy was devised. This was followed by, technical advisory group came into place hand in hand. All the key professional bodies, you understand, API, IAP, this BOGS, that is FOXI, IADVL, all were partners in the whole exercise, and they continue to be partners. Even on the 30th, there is a workshop with them involving all of them. And they are active partners in the whole process. They have come up with material, we'll be showing you that later. The professional bodies have also come up with material to boost triple elimination and as partners of the whole process. So essentially, the SOP framework, job aids, IEC material, training materials, and the STEM tool were worked out from January to March. This was followed by TOTs, followed by down training, followed by official commencement of the pilot from 15th of April 2024, and then this was overall results you'll be coming to see a bit later, and statewide scale-up has happened. So this is something which we can mention. So situational assessment identified these gaps. As I was mentioning you, there was overall coverage was quite good, but gap in screening for all three in the first trimester. The earliest screening, there was a gap. First ANC visit, then itself. Testing issues, some testing issues were there. Limited awareness on syphilis and hepatitis. As you see, the findings that emerged were these. Syphilis was, in fact, the backbencher. Hepatitis B, little ahead, though a young program. And then, of course, HIV/AIDS being a very old program, things were in a better shape. So you understand that downline, knowledge about infant prophylaxis was found to be limited for HIV, 37%, and HBV, 33%, particularly at labor rooms. So there was a big gap in the labor room area where you expect direct in labor cases. So there were gaps in case finding. Defined protocols for syphilis and Hep B were lacking. Syphilis management, again, there was issues with syphilis management with big knowledge gaps and lot of variability. So labor room, there was a big communication gap with the labor rooms from all the arms. And of course, challenges in M&E existed. And governance, as we have been talking, I had talked in the morning also, there was siloed governance, which we have all along been trying to de-silo, and a lot of effort has already gone into it. So because of the HIV program being essentially closeted, the visibility and the complaint from the district was that there was poor visibility and poor understanding as to what is happening. So that has gone now. So with the introduction of this effort, the district is in full sync with what is happening within the HIV AIDS window. So essentially, coordination meetings have been from disease-specific programs. We have viral hepatitis had a standard protocol, as I had mentioned in the morning earlier, that we have set up a district coordination mechanism through regular notifications and mandates, where all the program officers of the district need to sit together in a month for overviewing the viral hepatitis program. So that coordination meeting is now the key meeting, which is looking at triple elimination. And of course, the public health meeting and the public health MIS and the RCH meetings, which are two regular meetings, those two also cover this thing. And co-infections, nobody had any inkling about any co-infection. And of course, as I told you, the data systems were siloed, and very big challenge was the tracking of the mother-infant cohort. So this, is, as you see, this was Kolkata commitment signed and that was at the end of 2023, which clearly expressed the intent of the state to go ahead with triple elimination. So that has political personalities, all key figures from the state, one or two people sitting in the audience here also. You all can recognize Pauline there. So that's it. So anchored by the situational assessment and informed by the discussions, the intervention was designed and executed for all rungs of the health system. So essentially policy changes, very key, because unless policy changes happen, this cannot be pushed forward. So decentralization of syphilis treatment, that's one key area that has been intervened with, and it has gone to the block level. Earlier it was limited to the DSRC level within the HIV/AIDS system. So it has gone to the block level. So mandate for availability of, you understand, benzyl penicillin G, 24 lakhs for syphilis treatment was expanded from 6 to 57 facilities within these 6 months in the pilot district itself. And so it was demystified, the management, all that anxiety about, you understand, anaphylaxis and all that, that could be abated, taken care of, and so that's what has been the progress. Decentralization of deliveries, again expanded to block level, HIV and hepatitis B, unless there are indications with specific obstetric complications. So all screening points, including labor rooms, mandate triple screening. Identification and retest at the first point of contact from the same prick. Identification and retesting of at-risk operationalized. That means a new category of at-risk was created for all 3 diseases. This was to be done, retesting once for other than, hepatitis B and HIV, one additional testing, and syphilis even at the time of the third retesting at the time of delivery. Protocols for treatment and delivery of syphilis reactive pregnant women and managing syphilis exposed infants at SNCUs was streamlined and operationalized, making it as friendly as possible. Prioritization of viral load samples for HIV and HBV viral load for positive pregnant women. This already existed, but it was re-emphasized that all samples would have to be fast-tracked for viral load for HIV and hepatitis B. And the additionality that was put in for HBsAg was for hepatitis B exposed infants at 9 to 12 months of age, post-prophylactic HBsAg testing has been introduced. So this is an add-on over the program that we have now at the moment nationally. So capacity building, as you understand, a huge training exercise was undertaken, and this is now further being bolstered and supported by virtual training and mentoring. So essentially the materials developed, as you see, 9 comprehensive and integrated flows for screening and management of pregnant women and exposed infants has been developed, disseminated across all these 4, and at the moment the replication of all of it and with certain small tweaks is ongoing, would be available by the end of this month for dissemination and supply across the state. So that process is ongoing now. So it would be catering to all entry points, including for screening and management at labor rooms. So a development of record-cum-reporting booklets for comprehensively recording and case reporting of treatment of syphilis reactive pregnant women and direct in labor reporting of reactive pregnant women. These are add-ons. This was not there in the system, so we'll be giving you a glimpse so that they can record, keep track and inform. So one for the labor room and one for syphilis reactive pregnant women across all blocks, because the blocks weren't earlier treating in that big way syphilis. Again, this integrated tool, as we were telling you, system for triple elimination has been developed and operationalized. End-to-end cohort tracking is a part of this. So you see 50 plus new critical indicators across the patient journey are being tracked now, facilitating availability and quality of service delivery. And again, tracking of at-risk women, as we mentioned, based on behavioral factors, at-risk women have been, this category has been added on for retesting. And there were important learnings from this, due to this, because we could then garner cases which otherwise would have been missed. For the governance mechanism, as we consider integrated, as we mentioned earlier also, roles and responsibilities defined for all cadres of staff all along the chain, up to the block and ANC, up to the ANC, antenatal care levels and the ANMs. So state level task force has, I have already mentioned, established, and block review meetings mandated. So all blocks need to review. Monthly reviews of all activities. So this is basically the structure, the holistic governance structure that has been outlined. This is it. So you have the state task force at the top, a state working group which meets every fortnight. State task force was initially meeting every month. Now it has been reduced to 2 to 3 months period, and state working group meets every fortnight till continues to do so. It has participation from, as you understand, all the relevant program departments, and quality assurance has been integrated into this. So NQAS, as we know, National Quality Assurance System. So the state quality assurance team is now a part of the whole exercise of triple elimination, and indicators all have been developed and they are tasked to cover the whole exercise. So essentially, what you get to see is, these are some select metrics, exciting results that you will get to see. So there has been a over 2 times increase in syphilis cases reported during the vis-a-vis the same period last year. So first dose of BPG received, you see in comparison that there has been a marked rise, 89%, 94% of treatment completion for all 3 doses. Partner testing undertaken in 53%. This is the syphilis EMTCT cascade, which was the weakest link, as I was mentioning to you earlier. And all of my colleagues across states would agree that syphilis continues to be a weak link, but this has definitely gained from this effort. So found syphilis reactive, as you see, from this partner testing undertaken, 23. So it's 43% of partners could be brought into the loop. And infants below, you see key achievements, infants linked to SNCU, more than 85%, infants linked to for RPR testing, more than 85%, and infants receiving prophylaxis, more than 85%. And this cascade, mind you, could be tracked for the first time because of this initiative. Otherwise, it was totally in the dark. Nobody had any inkling or any clue as to what was happening around that. So essentially the learnings, end-to-end visibility of key metrics across the cascade, driven by the STEM, from the point of reactivity identification till 6 months of age of the infant. So all of it is now tracked. Strategic interventions and governance has led to increase in case reporting and treatment linkage of syphilis. Streamlining of protocols, essential coordination between labor rooms, DSRC, SNCU, capacity building at all levels has led to concerted focus on management of the exposed infant, which was again a weak link. And more than 40% of partners tested for syphilis were identified to be reactive, underscoring the need, essential need for tracking and testing partners, which again was a weak link. So from hepatitis B EMTCT cascade, as you see, the numbers, pregnant women found HBV positive. As you understand, in the whole exercise, hepatitis B would be the leader, essentially. But we now get to understand that syphilis is not far behind. There is definitely an important presence of syphilis. HIV, of course, it is there, but then its presence is humbler. It's humble. So, as you see, infants receiving hepatitis B birth dose and 93%, and infants receiving HBIG 91%. In these 4 pilot districts over a period from April to Jan 25. So, this is a significant achievement that we could understand that triple elimination would be able to garner. So, this is learning for us also. As for HIV EMTCT, as you see here, the other parameters are mentioned, but in green, where we show the green light is, eligible infants receiving single prophylaxis was 100%, and eligible infants who were supposed to receive dual prophylaxis, it was just above 85%. So, that is again an achievement that we could do, bring about. So, more than 99% of live births among Hep B positive pregnant women, this was an achievement, with more than 90% receiving Hep B birth dose and Hep B IG, driven by the total coordination efforts, cohort tracking of mother to child baby pair introduced, and of course, intense coordination between ICTC, ARTCT, LR, the Treatment Center for Viral Hepatitis established. So, these are essentially, you see, the criteria that we have created for at-risk identification. So, this is just for you to take a look. And importantly, I was mentioning co-infected cases identified 4 in this small period of time over this small 4 small districts, and 1 incidentally had all the 3 co-infections. I mean, 1 was co-infected for all 3.
Palome, I'll request you to wind up. You've run short of
Yeah, I
time.
am close to winding up because this was a big exercise. I thought that I had initially thought of skipping a few more, but then I kept them in the loop. So, this is the SOP. This was version 1. This has been revised to the final SOP now. This is an older picture. So, you see IEC materials developed. Of course, in vernaculars, these are English versions, but then mostly in 3 languages, Bangla, Hindi and Santali also, because that is needed, and Nepali for the state. So, these have been done. So, this is essentially a counseling booklet to aid counseling up to the level of ANMs, because that, as we had been talking about all along, is the point where everything integrates. And they are the key players at the front line who would be instrumental to the success of this effort. And in the blocks, the BPHN is the node. BPHN has been made the nodal person who would be keeping track of all the positive women and children in the block. So, this is within part of the counseling booklet. So, these are some of the job aids, as you see. So, these have QR codes where to improve testing quality, the testing guidelines are embedded, and of course, reporting at the grassroots is part of that. So, these are private sector developments, and of course, Foxy has taking a cue from all this. Foxy has developed the posters. I mean, literally replicated these posters for private sector use within all the major facilities, hospitals in the private sector, and they have circulated that also. And in all their regular meetings, it is part of the thing. What I had mentioned to you is LR form. This is a new addition into the whole health systems setup. This was not there earlier. So, this is the labor room form in triplicate. So, that has been developed. And syphilis reactive pregnant woman, this is the record which is available now in all blocks across the state where they record it. It's in duplicate. It's self-carbon. I mean, nobody has to put a carbon and do all that. It's self-carbon system. So, that has been done. So, this is just a look at how the whole STEM tool is. This is a look at the dashboard. So it basically is a quick look for you as to what it captures. It's illustrative. This again is being further strengthened based on what we are getting to be educated from the grassroots level and from the district level. So we are now on track, moving ahead, and we are on the track to eliminating and ensuring that every child in the coming days is born free, continues to live free, and is forever free. Thank you.
Thank you, Dr. Pallav, for that detailed, exciting data on the steps done in West Bengal. So with that, we'll come to the close of this session on focusing on vertical transmission, prevention of that for hepatitis B. All 4 speakers gave excellent talks, but due to lack of time, we'll probably curtail discussion and we'll close the session. Thank you.
Thank you so much to our chairs. I know it's a very tough job, so let's give our chairs and speakers a big round of applause. And requesting our chairs for this session to present a token of appreciation to our speakers. If you would please do the honors. And now I request Dr. Asha Hegde to do the honors and present a token of appreciation to our chairs for this session. Thank you so much. We now move on to our final session of the day. This one is on hepatocellular carcinoma. I'd like to invite our chairs to please join us on stage. I'd like to call upon Dr. Prem Kumar, Director, Medical Gastroenterology, Madras Medical College. Let's give him a big round of applause. And Dr. P. Piramanayagam, Consultant, Medical Gastroenterology, Apollo Hospital. Welcome, doctors. I'd like to also welcome our speakers for this session, Dr. Murugan, Dr. Ajit Singh Bhadoria, and Dr. Prakash Fernandez.
Good evening. I think we are heading towards the last session of this wonderful meeting. So this will be on hepatocellular carcinoma. HCC, as we commonly short and abbreviate it, is one of the most dreaded complications of hepatitis that we come to manage in the clinical aspect on a day-to-day basis. To elaborate more on this, we have 3 interesting talks that will be looking at the epidemiology, the risk factors, and palliative care. And we have eminent speakers to elaborate on these topics. To deliver the first talk, I would request Dr. Murugan, Senior Consultant, Department of Hepatology at Apollo Hospitals, Chennai. He will be delivering the talk on epidemiology and emerging insights. He has 18 years of clinical experience in the field of liver health. He has been awarded the Best Doctor Award from MGR Medical University, and he also serves as an adjunct professor at Tamil Nadu MGR Medical University. Over to you, sir.
Thank you, Parama. So I'll just be quick because we are really late. Like he mentioned, we are talking about viral elimination, but the complication of somebody who doesn't get viral eradication is hepatocellular carcinoma, which increases the healthcare burden of all countries and the mortality for the patient. So while the public health is trying to eradicate virus, we are treating the existing problems. HCC is an important cancer. The Global Health Registry published a couple of years back has listed it as the 6th most common cancer, but the 3rd most cancer that causes death of patients. So the mortality is quite high in HCC. And the projection is for the next 20 to 30 years, the incidence is going to rise because of the existing burden of chronic hepatitis B with advanced liver disease. This is the projection forward. And hopefully at the end of that, if we're able to have the WHO goal of viral eradication, we can see the numbers coming down. India is still considered low incidence of HCC, maybe partly because of the lack of good data collection. But consistently over the years, it is showing at a lower incidence compared to the rest of the world. The highest is in Asia, Southeast Asia, particularly China. So if you look at liver cancers, HCC forms a large part of it. Some come from bile ducts, some are mixed, and some are metastatic. But the bulk of liver cancers are primary HCC. Around 70% roughly occur in Asia, most of it in China. And the highest incident rates are in Eastern Asia, particularly Mongolia due to peculiarities there, Southeast Asia, and parts of Africa. So if you look at mortality rates, again, it kind of follows the incidence rate, which suggests that HCC inherently has a high mortality. So again, East Asia, North Africa, Southeast Asia have higher mortality from HCC compared to Europe and other countries. As far as India is concerned, like I mentioned, the Global Cancer Observatory, which is a global body that has research in many countries looking at cancer statistics, has listed as an incidence of 2.7 per 100,000, which is considered low. ICMR has a database in India which projects a slightly higher rate and also a higher mortality compared to the world data that is available. So in India, predominantly, the cancer statistics come from the National Cancer Registry Program, part of the ICMR. They do both population and hospital-based surveys and research to come up with the numbers. The Indian Cancer Society also puts out data, and there are independent studies from institutions and hospitals. Again, like we discussed many times, a large part of healthcare in India is driven by the private healthcare, where data is lacking. There's a paucity of data, and I come from a private healthcare, and our data collection is not adequate. So that's where the numbers may not represent the true incidence and mortality. From available data, it kind of mirrors what we see in the rest of the world. HCC in India is more common in men than in women. Some studies show 86%, but roughly it is 2:1. Maybe due to hormonal differences, gender-specific lifestyle changes like more alcohol, more exposure to B and C in men, maybe some of the reasons. And it's also age-specific, and in higher age groups, 60 to 69, the incidence is more common. Again, India is similar to the rest of the world. If you look at the incidence rate, like I mentioned, it is 2.7 per 1,000. ICMR projects slightly higher, maybe 4 to 4.5 per 1,000. Arunachal Pradesh has the highest incidence, predominantly due to viral hepatitis. Then Kerala, Sikkim, Mizoram. And similarly, certain states are lower, like Tripura. So this is a kind of a summary of data that is available, looking at both incidence and mortality. It's a crowded slide, but basically it says that certain pockets in the northeast, particularly Mizoram and Arunachal Pradesh, have a very high incidence and mortality due to HCC. A bulk of the large states, such as Maharashtra, Gujarat, maybe Kerala, etc., are in the middle range, around 4 to 5 incidents, and some states are lower. And male is greater than female. If you look at mortality data from India, it seems to be rising. It's still lower compared to other parts of the world, particularly other parts of Asia, but it seems to be rising. And now estimation is around 4 is cancer-related mortality as per the ICMR. And one more important aspect, this is a group of studies looking at the clinical disease at the time of presentation. Mainly they were looking at extent of disease, vascular spread, metastatic disease. Again, it's a busy slide, but mainly to tell that if you look at the treatment area, when the patient was first diagnosed with HCC, what is the proportion of patients that can undergo curative treatment? It was roughly 10 to 12%. So 80-90% of patients at the time of diagnosis are unable to have curative treatment. This is probably true across the world, but the numbers seem higher in countries like India. Looking at etiology, the yellow bar is earlier, 1990. The red bar is now 2019. This is across the world. Bulk of it comes from viral hepatitis. But the numbers of viral hepatitis, especially B, is coming down. Alcohol and MASLD, which is fatty liver disease, seems to be rising. So that is the trend we are seeing across the world. B and HCC are decreasing across the world. A large part of it is due to vaccination programs, and the Shanghai and other models have demonstrated that with good vaccination programs over a 20-30-year period, the incidence of HCC comes down, especially adolescent childhood HCC. And similar trend has been seen in India as well. And of course, if you have viral control, which is the small graph at the bottom, where they are well-controlled virus, the incidence of HCC comes down. So with these two changes in the world, vaccination and viral treatment, the incidence of HCC seems to be coming down, especially with B, and same with C. If you treat C and maintain SVR, your HCC rates are much lower than patients who have not achieved SVR or who are untreated. So again, the emphasis is link them to care, get the virus cleared, incidence of HCC will come down. The opposite is happening with MASLD. It is an emerging global health problem, obesity and related disorders. And unfortunately, HCC is part of MASLD, even in patients without cirrhosis. And this is the trend that we are seeing worldwide, increasing incidence. There are two interesting studies, I'm almost finished, two interesting studies that I thought I will highlight. One is from ILBS, where they looked at nearly 5,000 to 6,000 patients. And they found that the most common etiology of HCC in India as of 2022 was NAFLD. This is across 4 or 5 major institutions in North India, which was a bit of a surprise to me. I thought still viral hepatitis may be leading, and the trend is not yet caught up, but it looks like it has already caught up. So NAFLD has become the leading cause of HCC in India by 35%. Then is viral hepatitis B and C. Around 27% have no cirrhosis. Presumably, they are mostly Hep B. Some of them may have NASH with HCC. So this trend is already happening in India. And this was another published paper from last year, which looked at a group of studies over the last 30 to 40 years. And what they then noticed was there was a trend of increased viral hepatitis in the north of India, but the trend was declining. There was increased non-viral hepatitis-related cancer in central and south India, and again the trend of non-viral hepatitis is rising. But what came across was there's a great heterogeneity in the data collection and reporting, and as usual, poor data across the country. So I just want to summarize by saying that the current incidence, prevalence, and mortality rates still remain lower compared to the global data, but the rate of change in India seems to be higher than many other countries. Among Indians, the proportion of HCC is higher in males, higher in the northeastern states. There is an emerging hotspot, mainly due to non-viral hepatitis HCC in Gujarat, Maharashtra, Goa, and Kerala. The incidence of HCC related to hepatitis B is on a downtrend compared to alcohol and MSLD in India as across the world. And unfortunately, majority of patients, particularly in India, are diagnosed at a very late stage. I'll stop with this. Thank you.
Thank you, sir. Now we move on to the next topic, risk factors and prevention strategies for hepatocellular carcinoma. The speaker is Dr. Ajit Singh Bhadoria. He's an additional professor, Community and Family Medicine, AIIMS Rishikesh. He has been working in the preventive hepatology and liver disease for the past 12 years and is a nodal officer for NVHCP program at AIIMS Rishikesh and is a member of the WHO Guideline Development Group for Hepatitis B and C and cell testing. Over to Dr. Ajit.
Thank you so much, sir. And thank you, Dr. Murugan, for setting up the stage by telling the burden of hepatocellular carcinoma globally and in India. So I'll be talking about risk factors, mainly about modifiable risk factors, and then what should be the preventive strategies to prevent liver cancer. So this is the slide which tells you about the list of risk factors for liver cancer, and I mentioned the word irritant. So these are all irritants to liver cells, and because of this irritation, this malignancy develops. So initially, most important one is B and C, then comes alcohol and even non-alcoholic fatty liver disease. You are listening from since morning that this is important and coming up as an important risk factor for development of liver cancer. Diabetes, obesities, they are contributing either independently or with non-alcoholic fatty liver disease. Smoking is an independent factor for liver cancer. We have seen in the morning slide from Dr. Sareen. Family history of liver cancer is important risk factor. Then comes some environmental toxins. I'm not going into detail of these, but they are there. We have a few are known and many are unknown. If we talk about preservatives, if we talk about fertilizers, if we talk about fruit and vegetable ripeness, which we eat thinking that they are healthy, they may cause some liver damage if they are harmful. And then there are some certain inherited disorders like hemochromatosis and Wilson's disease, which are rare, but they still causes liver cancer. So the data this is the data about cirrhosis. We know that cirrhosis ends up into liver cancer more commonly, but yes, even in many etiologies, without development of cirrhosis, liver cancer can develop. So if we talk about cirrhosis etiology, alcohol is on the top with 43.2% attributable fraction for alcohol in causing liver cancer, followed by fatty liver, and then comes hepatitis B and hepatitis C. And over the time, we are seeing the reduction in the liver cancer, which is caused by hepatitis B and hepatitis C, as mentioned by my previous speaker also. And this fatty liver and alcohol, they are coming up as more important attributable factors, risk factors for liver cancer. So this was a study which was mentioned by Dr. Murugan also, that this is the data from as much I was involved in this study, there was 13 centers which are identified all over the country, and they're contributing to this data. And you can see that fatty liver is contributing more in both cirrhotic HCCs and non-cirrhotic HCCs. Then comes hepatitis B and hepatitis C, and down in the rows you can see the combination is also very important. When there are more than 2 irritants, hepatitis B with alcohol, we have seen in the morning slides by Dr. Sareen, the odds ratio was 2 for alcohol, was 2 for hepatitis B, but they comes together, the odds ratio goes to 9 times higher chance of development of liver cancer. So a holistic approach is required if you want to prevent liver cancer. If a patient comes to you, test for B, test for C, and also look out for fatty liver and for alcohol consumption. Fatty liver is quite high, the burden is very high, and it is about 38.6% overall in adults and around 35% in children. So childhood obesity, childhood fatty liver, they're also coming up as important risk factors, not only for non-communicable diseases, but also for liver cancer. And the burden is very high in high-risk groups, those who are obese, those who are diabetics, is around 52% in adults and 63% in children. India ranks second for both hepatitis B and hepatitis C in terms of numbers, after China for hepatitis B and after Pakistan for hepatitis C. Alcohol consumption is showing rising trend. If you can see the first graph, the percentage of those who are 15 years plus of age, the annual per capita consumption is doubled from 15% to 31.2%. And in the lower graph, you can see first yellow one is for world, purple is for CRO, and then red one is for India. You can see the 15.9 liters per year consumption among 15 plus years of age of current drinkers was documented in this study. So when we talk about prevention, just to tell you briefly about, there are levels of prevention, primordial, primary, secondary, and tertiary. Primordial is when we want that risk factor should not come. Primary is when risk factor is there, we don't want that disease occur. And then comes secondary prevention and tertiary prevention. Now there are new terminologies like upstream and downstream prevention. Upstream is when you don't want the disease to happen. Anything which is done before the disease starts is upstream prevention. And downstream prevention is then when a disease starts and you want that it should not end up into more severe complications or more mortality, you do some preventions. So I'll be talking about both in the coming slides. So this is, I think, a comprehensive details of preventive strategy which can help preventing not only cirrhosis but also liver cancer. So primordial prevention includes hepatitis B vaccination. I'm not talking about in detail. We have heard a lot about it. Safe blood products, safe injections, safe needles to avoid the transmission of hepatitis B, hepatitis C, to reduce the incidence. Less alcohol use and taking care of MAFLD, NAFLD, or MASLD, whatever you call it, and obesity. And then comes secondary prevention, which says that to make early diagnosis and treatment of all these conditions so that we can start treatment early and avoid the complication of development of cirrhosis or liver cancer. Then comes tertiary prevention, which is more important in tertiary care centers, where the person is suffering from the disease and you want to prevent complications or sequelae of these diseases, like preventing infection, sepsis among those who have serious disease, taking care of lifestyle. Diet frailty is very important. Sarcopenia is coming up as an important risk factor for prognosis in cirrhosis and liver cancer. So a patient should not lose muscle mass. That's important. And then we do primary and secondary prophylaxis for varicose bleeding and also management of complications. SCC screening is important. We use AFP, alpha-fetoprotein levels, and ultrasound to screen for SCC. Early screening is important so that we can pick up the lesion early, and then transplant as needed, and post-transplant management also comes under tertiary prevention. So we talk about hepatitis B, hepatitis C control so that we can take care of or prevent hepatocellular carcinoma also. So I've taken purposefully this slide that we should try to focus on the interventions which we are taking care in the viral hepatitis control program. Vaccine, mother-to-child transmission, safe blood, safe injections, harm reduction, and testing and treatment should be scaled up. Other than these 5 interventions, other key shifts which are required is public awareness. Community mobilization is very important to avail these services. We could find out increased financial resources specifically for hepatitis B vaccination, and then scaling up for hepatitis B birth dose. Gradually, the coverage is increasing in India, and I hope that we can reach out to the desired percentage of coverage which we want for elimination. And then investment in primary prevention is very important, and then comes increasing testing, simplified and decentralized approach, which is there in the program, in the operational guidelines, but implementing in the real field is very important. Strengthening community and civil societies, this is something where we are lacking. We have talked about stigma and discrimination, and then we need some. I mean, we have talked in detail about in the morning about the drug regimens. If we can find out some cure for hepatitis B, that would be a landmark achievement. Regarding alcohol as a risk factor, this global alcohol action plan from 2022 to 2030 was released in 2023 by WHO, which was adopted by World Health Assembly also. And there's a study which clearly mentions that if a country, they have policies for alcohol, so you can find out that it significantly reduces the death which is occurring because of alcoholic liver disease if we have a national plan to fight against harmful consumption. And even if there is a restriction of alcohol excess is there in the country, it reduces the death which occurs due to alcohol-related cirrhosis, and definitely it will work for alcohol-related HCC also. India is lacking. We don't have any alcohol policy front. India's alcohol deaths are rising. They're more than China, and the per capita consumption we have seen in the previous slides is rising. So definitely we need a policy for alcohol. And according to WHO, we should say no alcohol, advocacy. We should stop mentioning harmful intake of alcohol. We should say no alcohol, as we say for tobacco, that there should be no tobacco. So no tobacco and no alcohol should be the message for the community. And in the tertiary care centers or in the clinics, we should merge preventive hepatology with alcohol use disorder clinics, so that there are many studies which has shown that it significantly helps not only for retention in the liver disease treatment or reduced long-term mortality, but also better outcomes, both for alcohol use disorders and also for alcoholic liver disease. So it's a win-win situation for both clinics. Now we talk about NAFLD and NASH. It's a spectrum of disease which starts from simple steatosis, pure fat, only fat in the liver, and then this fat acts as an irritant and causes inflammation. Then comes the NASH, and then this NASH ends up into fibrosis for F1, F2, F3, and F4 stage. F4 is cirrhosis, and which may end up into liver cancer at any stage. So you can see all the arrows, they are going towards HCC. At any stage of this NAFLD spectrum, a person can develop HCC. So it's a very important, we have seen the data that fatty liver is the most important risk factor for HCC. There is a changing nomenclature now. NAFLD in India, we are using still NAFLD word. Our guidelines use NAFLD word, but globally it has moved from NAFLD to MAFLD, which is like metabolic dysfunction associated fatty liver disease, and now recently as steatotic liver disease. They say fatty word is stigmatizing in non-alcoholic fatty liver disease. Alcohol word is stigmatizing. So remove these two words and use metabolic dysfunction associated steatotic liver disease. And it has also a spectrum of different nomenclatures in terms of amount of alcohol consumed. So there can be a pure alcoholic liver disease, then there are some in between nomenclatures, and then comes pure metabolic dysfunction associated steatotic liver disease. So early screening and diagnosis is very important, which is very challenging because like hepatitis B and hepatitis C, fatty liver is also asymptomatic. So people, they do not come to you. We have to find out these people and we have to screen them. NAFLD operational guidelines of India, they promote community-based assessment checklist, CBAC. We have ultrasound, it has its own limitation. It has PCPNDT Act, we can't use ultrasound in the community freely. Fibroscan is very costly, CT, MRI are costly, and they are used only for specific or research purpose. Liver function tests like EPRI and FIB4 can be used, but they're mainly for fibrosis assessment, and liver biopsy is the gold standard, but we are relying on community-based assessment. We need to do some innovations to do risk stratification. We can involve tailors who make the dress of the individuals, like if the waist circumference is more than 90 centimeter for men, more than 80 centimeter for women, they can ask them that you are obese, go and consult your doctor, you can check out for fatty liver. And even these, we can involve barbers, as was mentioned previously by one of the colleagues. Not only for hepatitis B and hepatitis C, we can ask the barbers whenever they do a haircut, if they see these skin tags or darkening on the back of the neck, this is a sign of insulin resistance. So these people, these individuals can be referred to, they can ask them to go and get your insulin resistance check or fatty liver check, or even diabetes, hypertension should be checked among these individuals. So this is the CBAC form. I'm not going into detail. It's available online. This is what National Alcoholic Fatty Liver Disease Operational Guidelines mentions, that we should use these 6 simple questions. If the score is more than 4, then the ASHA worker should refer the person to get it assessed for not only non-communicable diseases, but also for fatty liver disease. We don't have specific treatment. We have to take care of risk factors and health conditions. Comorbidity is important. As mentioned previously by Dr. Sareen, weight loss is the key strategy to get rid of steatosis, and this is the data which supports it. It says if you reduce 10% of weight, 100% of fat is gone from the liver. But how many people achieve this 10% is only 10%. So when you advise only 10%, they achieve the 10% weight loss, and out of those only 10% they maintain it for a longer period of time. So it's very difficult. It's easy to advise, but it's very difficult to practice. This is a long list of lifestyle interventions, and I'm not going into detail, but these are all very important. These all messages should be used in the counseling. Whenever you do counseling of fatty liver, it's not just fatty liver. It's very common. And whenever a person sees ultrasound, if a person is suffering from fatty liver, he should be well counseled and educated about the condition. Tell them it can end up into cirrhosis and cancer. Tell them the weight loss is the key strategy, and then follow up with these cases. INASL is Indian Association of Study on Liver Disease. These guidelines, they recommend vitamin E, pioglitazone, and seroglitazar, which can be used for fatty liver, but it's in the spectrum. They are mainly used in between when there is NASH. They are not useful when there is only fat, and they are not useful when cirrhosis or liver cancer sets in the liver. This is the last slide about fatty liver. Bariatric surgery is also used for management, but this is for only those who are suffering from morbid obesity. So the take-home message is to prevent liver cancer, health awareness is important. We have to create awareness among the community that they should understand so that they can have a good liver health. SCC surveillance is important. We have to scale up hepatitis B vaccine, not only in healthcare workers, high-risk groups, but also I mean, maybe as many as vaccinated is important for family members also. Hepatitis B birth dose is important. We have to scale up screening, test and treat policy is very important, not only for hepatitis C, but also for hepatitis B. Safe blood, safe injections, safe sex is important. No alcohol, no tobacco should be the message. Healthy diet, regular exercise, and keep a check on the metabolic profile is very important if you want to get rid of hepatocellular carcinoma in the country and globally. Thank you so much.
Thank you. Thank you, Dr. Ajit. It was a wonderful talk. As we're running short of time, we won't take any questions at this point in time. We'll move to the last talk of this session. It's on palliative care, addressing the needs of hepatitis and liver cancer patients. This will be delivered by Dr. Prakash Fernandez, who is the head National Palliative Care Partnership, CIPLA Foundation. He has more than 15 years of experience in social development and service delivery and program scaling. He has built multi-sector partnerships to integrate palliative care into healthcare systems, and he has led Childline India research and NSPCC substance abuse projects. Over to Dr. Prakash, please.
Thank you so much, and thank you for including palliative care within the conference. Palliative care generally is the last session of many conferences. Maybe it's because the endings are supposed to be more meaningful, more complete. That's the traditional view of palliative care. But nevertheless, I think palliative care and the message we want to really give is that it should begin from the beginning. And that's really what our experience has shown. I've trained as a social worker. I've been privileged to be associated for the last 8 years at a palliative care center that CIPLA Foundation operates in Pune, which is a 55-bedded facility for oncology patients and running home care services as well. Through CIPLA Foundation, about 5 years ago, we really felt that palliative care needed to expand across the country. And what was really required really was to support professionals, doctors, nurses, counselors, social workers, to be part of the team. And so today we have about 40 partners across India that we support. About 25, about half of, or more than half of them are just in oncology, but the others are in non-oncology, from neurology to integrated services, as well as working with the district hospitals, like in Goa, that we have working with the district hospital to really look at all serious illnesses. Sorry. Yeah, thank you. So just to begin with, I think the way we think about palliative care traditionally is really looked at as just end-of-life care. And I think today we say that palliative care is not just for diseases that are not curable, but people who are facing any serious illnesses that could have a hope for cure as well could access palliative care. It's really an approach. It's an approach that is really looking at not just the disease, but the individual, looking at how the disease is impacting the individual on their daily life, how it's impacting the caregivers. And I think a lot of research has shown how early palliative care is actually making a difference. And one of the key things is the adherence to treatment protocols. And really the pathway to that is because people are well prepared for what symptoms are going to come. They're told about hair loss, they're told about obesity, they may be told about the impact of medications that could happen. So they are better prepared. Caregivers are less stressed, so they're able to come and support patients better. Symptoms are, of course, reduced. It's really in palliative care about thinking ahead. Quality of life improves. There's better health communication. So really what this model says, which is now called the bow tie model, is that you have these two triangles. And the blue one is the disease management, and the other one is what palliative care does. And this really recognizes the duality of palliative care, that of course, you prepare individuals perhaps that as goals of care change, that there could be end-of-life conversations, there could be decisions to be made, but equally recognizes that palliative care is to support people for cure, for survivorship. People waiting for liver transplants, for example, require this care as well, require to be supported. And so often this is a tool which is used where people can actually fill in the boxes. So you can actually write in those spaces of what is the disease-directed therapies you're going to do, as well as fill in what are the pain, what are your actual symptoms you're facing that the palliative care team can address. And of course, the blue arrow is just to say that this is dynamic, it keeps changing, and you need to kind of take into consideration that. Palliative care professionals are also trained to really look and monitor at the symptoms that are changing. There's, of course, in India now a specialized MD course in palliative medicine, and so there's kind of a lot of training on how the palliative care professionals interact with the treating physicians to really get the best care plan. So this is one of the tools we use in all our projects, which is called the ESAS, and it's kind of adapted based on the symptoms. But really, it's used at each time the patient comes to be able to track what's happening and what's changing for the patient. So often the patients may say either kind of their clothes are not fitting well, that there's more breathlessness, they're tired. So behind each of these behaviors, it's a chance to explore. What is it behind? Is it ascites that they need to be tracked, need to be changed? And the palliative care team therefore provides a lot of information to the treating team to be able to kind of address these symptoms. And for the patient, it's quite visual as well once you graph it. It's a conversation to say that the last time we met, your pain was at 8, now it's kind of come down to 7, there's something good you've done, something that's changed, we need to do more of that, is the medication working? Or if things are kind of going up as well, is to kind of recognize the strengths that they're bringing in, their coping strategies, and what else needs to be done differently. Of course, I'm not going to talk the medical aspects of how these are managed, especially with morphine and things like that, how they specifically interact with liver conditions. And that's the discussion really that the palliative care teams have with treating physicians to be able to get at a care plan. Just to say, therefore, the quality of life is the key thing of palliative care. It looks at these 4 domains. And I think the palliative care teams are helpful so that you can track these changes. Because often people are told about exercise, you're told about physiotherapy. You need to have these conversations further to understand the barriers. When you're visiting people in their homes, you get a better understanding of where they're coming from and how do you adapt these solutions. How do you prevent things from happening? Often falls is a big thing that palliative care professionals have to do a fall risk assessment in their homes so that things don't deteriorate. Palliative care teams, therefore, have to look at a lot of aspects, and therefore it has to be multidisciplinary. I think we have a doctor, nurse, counselor, social worker. Because it is interdisciplinary, it's each one, therefore, contributing their skills and their knowledge to be able to have certain conversations, but at the same time, piecing it all together to get a more holistic understanding of that family, of that patient, and therefore what needs to be done. But I think it's that coordination which makes the difference, and where palliative care teams are able to strike a good rapport with the treating physician, is able to feed back to them. And the palliative care teams as well understand from the treating physicians what are the goals of care that they're working on. There is kind of joint up care. It works variously across our projects, but I think that's the aim, that's the goal, is to keep communicating. I think communication is the key. A lot of the training sessions that we have for our teams is really on communication and how do we address this. Because palliative care, I think, improves communication, of course, with the patient and the caregiver, because that's equally important. With the caregivers themselves, are often not looked at or are overlooked and they are stressed, as well as communication between treating physicians and the palliative care team. Just to say, therefore, that there are a lot of barriers, which I think the take-home message would be is that when do you refer, what triggers a referral to a specialized palliative care team? And I think that's where perhaps there's emotional distress, there are conflicts in the family. You need perhaps to refer, to call on to a specialized team. Ideally, it should be one team. It should be where the patient and caregiver don't think, therefore, you're being referred on. It's just a different skill set you're bringing in to be able to support them. I think it's to recognize the barriers that patients and caregivers do face, and how do we try to address them. And I think if we're able to identify, to talk about it, we're one step closer to be able to address it. I just really want to say that in India, we've got a helpline for anybody who requires to be linked to the nearest palliative care center, and that's called SAT. It's by the Indian Association of Palliative Care, as well as about 35 organizations that have come together to be able to really find out what the need is, assess it, and then be able to link callers to their nearest palliative care center. Really to end that, I think the palliative care philosophy is that we die only once, it's to live every day. It's how do we get the most out of it, and how do we really support patients and their caregivers to live the best quality of life. So I think, as we say, sometimes we cannot affect the journey, or we cannot affect the outcome, but at least we're there with people on the journey. We make sure that they don't feel alone at any point in time. We may not have all the answers, we can't support all their financial needs, but they know that there's a team there who is with them throughout, and they're able to talk to and raise their concerns. So I think the early integration of palliative care really helps build that rapport with families so that they're able to support them to their best. Thank you.
Thank you, Dr. Prakash, for the excellent talk. Due to want of time, there are no questions allowed. We are by closing the session. Thank you.
Thank you so much to all of our presenters today for this session. Requesting our chairs to present a token of appreciation to our presenters. And requesting Dr. Rakesh Agarwal to do the honors and present a token of appreciation to our chairs for this session. And a big thank you to everyone for being such an engaging audience over the last 2 days. We've had a lot of sharing of insights and learning. It's been extremely exciting. And of course, a wonderful array of panelists and dignitaries. So now for the closing remarks, I'd like to invite Dr. Vivek on stage. Let's give him a round of applause.
Thank you. Thanks, everyone. And as you can see, before we are thrown out, I just need to say a big thank you for our faculty, for people who are present here, for all our supporters. And of course, last but not the least, I'm pleased to announce the prizes of the poster competition which we had. I will do that. Yeah, okay. And could I request Carrie, please, on stage? The third prize goes to Mr. Maniganda Nasan, ICMR NIE. A big round of applause, please. Thank you. The second prize, Ms. Kanudeep Kaur from FIND. Ms. Kanudeep? I can't see her. Ms. Kanudeep? No. Okay. The first prize, Dr. Abhishek Sadasivan from AIMS Rishikesh. Abhishek? Only Abhishek should come. Ajit cannot come. Abhishek? And of course, as promised, we'll be giving away 3 consolation prizes. Jess, if you can come up on stage, please, to give away 3 consolation prizes. Ma, idha first kudukunuma. After this. Can I have all the following 3 people on stage who won 3 consolation prizes? Mr. Yashindra Singh, Dr. Arnab Sarkar, and Dr. S. Subha. A round of applause, please. Please encourage them, please. Yeah. I repeat, Mr. Yashindra Singh, Dr. Arnab Sarkar, Dr. Subha. All of you on stage, please. Who's missing? Yeah? Oh, okay. Miss Subha is missing. Okay, that's fine. That comes to the end of our first ever Indian Hepatitis Summit. Thank you very much indeed. If there's any faults, please write to me. It's my fault. I would take the responsibility. But hope to see you all soon. Thank you very much.